Good morning, Pune. How's the Josh? Love it. Welcome. Thank you for coming for the shoulder conclave in such big numbers. I'm really overwhelmed, and each one of you has reposed faith in us. And for your sake, we've set up this program. I think it is going to come out very well. And so we are in for 2 days of complete academic package. So there is, as most of you know, your repeat visitors, we don't waste time at the conclave. There is no inauguration. There is no ceremony. It's packed academics from first to end because the goal is academics. It's nothing else, okay? So welcome. It's a Republic Day. It's the best time. We're going to cover everything on shoulders today and some exotic stuff on shoulders that we have not done. You will, of course, realize that the bar has changed. We are taking it a level higher. You're going to see stuff like Kovalchuk procedure. You're going to see the scapula and the stem from Basam like never before. You're going to see cerclage like never before. So a lot of new stuff has been. So we are not going to be stuck in diagnostics and examinations and which is a cuff tear and what do you do with partial cuff tear. We know all that. We go a level beyond this. So what are the chances that you can get the Avengers and the Justice League together on the same stage? No chance. Not even in Hollywood, not even in America, but here, for sure. These guys, you have no idea. I have picked up 8 foreign faculty, hand-picked, and there's a story behind how I picked everybody up and how I conspired to get them here. It has not been easy. These guys are so busy. In fact, George has just finished his big ASAP meeting 2 weekends back. It's been very intense. They've been traveling the world, so they're not allowed to get jet lag because they're living through the plane all the time. But they're here for you, so soak it in and make the most of it. I can't tell you where they will be here again. 3 of our faculty were together, Chalmers, Basam, and Atwal, and Ladaman, 4 of them were together at the meeting, and they're back again here. So you can imagine in what demand they are. So grill them, corner them, question them. This is your best chance. They will not come back again, unlikely, unless I use the same magic wand over again. So each one has a domain specialty, and the talks have been curated to their specialty. So they are the final answer to their specialty. So the footprint is getting wider and wider. The conclave is spreading across the world. Thank you, South Africa. Thank you, Malaysia. Thank you, Thailand. Thank you, Nepal. Thank you, Dubai. Thank you, UAE. Thank you, Qatar. Thank you, Australia. Lots of them. So we are growing. Use 367 till Saturday, probably 375 to 380 today, and that's going stronger and stronger. So most welcome. Now, new features here. We are having an end of the day discussion with the surgeons about their surgery. So they will come up on the stage, and at the end of the day, time permitting, we'll grill them on their surgery. Why did they plan it in this manner? What would they have done otherwise? Was there a situation? Or how you bail out of that situation? Unfortunately, we had to change 2 surgeries. There was a scapulothoracic fusion we promised with Basam. There was a patient, and he was in Dubai. The logistics didn't fit in, so he's been swapped. But appropriately, we've got a fantastic lower trap transfer for Basam, which is Basam's forte. Basam will have his perfect time. He'll do this on the trot in theater, so we've got a good substitute for that. We also had an ideal type 4 isolated subscap for Peter Chalmers. Unfortunately, he caught COVID, so we changed it to a cuff tear now. So those are the 2 changes we had to do. We did have backup plans, but they were ideal hand-picked cases. Unfortunately, Mr. Murphy visits some. So that's one. Just a note of alert, on the 27th Saturday, unlike what is printed out, we will start with Hachem's surgery first, the cerclage for the bone loss, and then we'll get Alex Latherman come in second because Alex is going to be very busy with the breakfast workshop, so we'll give him some breathing time to go and reach the hospital. So there's just a small change in the program for you, nothing dramatic. The breakfast meetings were fantastic today. There are 5 tomorrow. If some of you have not been, you can still register with the help desk, with the registration desk, and there'll be 5 meetings tomorrow. Most of them are full, but there are some seats available. Today, apologies, we'll give you a working lunch, and it's in your interest because in order to get you that 8th surgery, that was the only time that we could compromise. So you are sitting through, we are not stopping for lunch. There will be breakfast, there will be takeout lunch on the back tables there. The left side will be non-vegetarian, right side will be vegetarian. Just show your registration badges and pick up and go to your seat and have food, no problem. And then there'll be a bin or a table on the far right where you can keep your boxes there. And again, that's hand-picked meal. It's a good meal, and that'll keep you from sleeping so that you can get max out of your time. So we want to do that for you. And tomorrow we have a formal buffet, so you'll get the full Monty tomorrow. There is round-the-clock tea, coffee. Don't want to break. Whenever you want, go grab your coffee, come and sit here and have it through. We'll have some other surprise items through the day for you to keep you awake, keep you alive. There's some 3-4 interesting things new this way. We have a calligraphy studio where you should go, put your name down, and they'll give you some very different kind of calligraphy experience. There is Chitale Bandhu there because we're giving you the culture of Pune, and he's the sweetmeat person that you must take home. There are savories and sweets both. Rely on them. They will guide you what is the best items. Take back home. Your family will be very happy. So I've bought this experience for you. They are number one. It's very difficult to get Chitale out of their shops, but they are here for you. And for your better halves who are missing you, this is Paitani, which is also from near Aurangabad. And there are these curios, so you can feel free to meet Dhanishri. She's going to have those purses and stuff for you. Feel free. Last time she was a riot, so that's why she came back and she said, she saw our promo and she said, I want to come back this time. Nandan Adla, the president, is here, so we are promoting SESI. Those who are not members of SESI, there is a facility to register yourself for the Shoulder Elbow Society of India. It's right next to the registration desk, far left, so feel free, go and do that. There is a big advantage, but the number one thing is there's an Indo-American Shoulder Fellowship only for members of SESI. The first team went in that last year. 5 of them had a roving time meeting, rubbing shoulders with the who's who in America. Finally, you will receive a Google form at the end of the day for your feedback. Do fill it. The certificate that you was going to get is an e-certificate, but it's provisional to your filling the form for today and tomorrow. So you'll get 2 different forms for your certificate. Finally, for the evening program, we have somebody that you've never even seen, thought, met. You must have heard of the person, but we are going to see him live in flesh and blood. It's a very, very different experience. To me, it's been a life-changing experience, and it's a different soul. I will not tell you any details about it because I want you to experience it yourself. So don't miss that. That's coming up in the evening. And Dr. Joban will take his interview, and it's a very, very special experience for all of you. And then we have the gala dinner. Apologies, it's Republic Day, so no liquor will be served. We did serve liquor yesterday to those who came in yesterday on the dinner. So apologies for that, we can't change that feature for you. And then the final alert. So the Indian-American American Shoulder Elbow Society has been very keen to participate and collaborate with us. And so what is in the offing is Arthroplasty Summit, a focused Arthroplasty Summit happening in the first weekend of February. And we have some big names like Grant, Patrick Denard, Anand Murthy, and Zamin Nagda, and there should be some more. And so we'll keep getting updates on that, but be careful, ensure that you've marked that weekend off for next year, not this year. So finally, please remind that switch off your phones, keep them in silent, you'll enjoy them better. And I don't want to stay here for any longer. Let's start with the program. I would like to invite the first moderators. So it's Nili. Yeah. So before I call the moderators on the stage, because it's Republic Day, I request all of you to stand up. We'll go play the national anthem, and then we'll start with the proceedings. Thank you very much.
द्राविड उत्कल बंगा उछल जलधि तरंग तव शुभ नाम जाने तब शुभ आशीष मांगे गाहे तव जय गाथा
जन गण मंगलदायक जय हे
भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jai! Jai Hind. Thank you. Thank you. Please take your seats. So I'm going to invite Raghuveer Reddy and Nilesh Kamath to take the stage and we start the proceedings.
Good morning, everybody. I request Dr. Ram Chidambaram to come and speak on challenges with banker repair and failure rates. Tension लेने का भाई.
अरे टेंशन नहीं लेने का अपुन है ना
Good morning, everyone. Thank you, Ashish. So I'm the opening batsman here. So challenges with Bangkok repair and failure rates as my affiliation from Chennai. So all of the faculty will agree, isolated Bangkok repair is almost gone. Remplissage is becoming a routine. Augmentation is the buzzword. Subcritical bone loss is in focus. So this patient I saw 1 month ago, 27-year-old recurrent dislocation right shoulder. He could see the large hill sag lesion. And we got a 3D end-phase profile CT, 12% glenoid bone loss with a malunited small glenoid fragment. So what will you do for him? We have many options. 15 years ago, while in UK, I think Bhuvaneshwar Machwani was my fellow at the time, we didn't have any confusion. We just do a simple Bangkok repair. But now we have more to do, more to think. So what we learned in Bangkok repair, labral ligamentous bumper repair, subequatorial below 3 o'clock, IGHL tensioning, south to north shift, and 6 o'clock repair to the posterior root. As far as the anchor is concerned, small suture-based anchor, suture tape, knotless or adjustable knotless. If poor bone, go for a material anchor. But the Bangkok failure rate is very high. 10 to 15% is coded. Longer you follow up, more the failure. If it includes positive apprehension, it may be much higher. The first step is to identify the factor. There may be patient factors like this, young age, second trauma, seizure disorder, etc. Or missed diagnosis. Of these, we'll focus on the glenoid bone loss. There are many ways described for glenoid bone loss. Easiest way is to compare the opposite side. And if you see this patient, 39-year-old lady referred for arthroscopic surgery. And if you look at the 3D CT, almost half the glenoid is gone. So she has critical glenoid bone loss. What's the definition? More than 25% used to be, but now it's almost 20%. It is dropping. So I did the ideal letter J Patty procedure. This was done 7 years ago, and that was a result in range of movement, rotation, and 1 year post-fracture healing, graft healing. Look at this patient, recurrent dislocation. That's a 3D CT profile. This is classed as now subcritical glenoid bone loss. Again, what's the definition? There's no consensus. A couple of papers say 15 to 20, and some papers say 10 to 15. So you can take it whichever you want. But what we know from the recent published literature is this, associated with a higher redislocation rate in primary surgery, and secondly, associated with poor functional score, and will convert on-track hill sag lesion to off-track. We have two options, scapular spine graft, ideal for subcritical bone loss, can be combined with Bangkok repair and remplissage. It's an anatomical procedure. It's described, and Dr. Hashim is going to do a talk as well as live surgery for you. The second option, recently popular is by DAS, DAS, Dynamic Anterior Stabilization by Alexander Ladderman. He's here, the man himself is here, he's going to show both his talk and demonstration. But here the biceps is detached and rooted through a split in the subscap and attached to anterior glenoid. It's an arthroscopic procedure. So next is the heel sac defect. You know the classification of this. And whenever you encounter a large heel sac lesion, we can immediately do nowadays remplissage, accessory posterolateral portal, prepare to bleeding surface, use the rotator cuff anchor, do a mattress suture or box type sutures, and labral repair and complete your remplissage. So this is straightforward and easier. And if it's a large lesion, you do a remplissage with the 2 anchors. What we know, it supports the Bankart repair, and concurrent remplissage reduces recurrence rate, and there is no significant restriction of rotation. So the last thing is a technical error. This is the most common seen in my practice, patient treated elsewhere coming with recurrent dislocation. Medial anchor, high anchor, less number of anchor, or poor repair technique. So 27-year-old gentleman had arthroscopy stabilization elsewhere. He failed in 3 months. Why? That's his CT scan profile. There is no glenoid bone loss here, but all the 3 anchors have been put here. The main action is subequatorial. So this is another patient, 22-year-old college student, arthroscopic stabilization 6 months ago, failed, but you see there's only 1 anchor repair. That's not going to solve the problem. So this is him at arthroscopy, very unstable. So you have an evaluation, you see a large heel sac and previously unrepaired labrum. So I did a capsule application, remplissage, debridement of the previous suture. Don't need to remove the anchor all the time if it is not prominent. And you do a minimum of 3 anchors below 3 o'clock. I'm just emphasizing on that. And create a bumper effect. Simple sutures, we can use a tape-based suture. And that's your final repair. A well-repaired remplissage, centered shoulder, anterior repair. And what did you do for the first patient? So this was the first patient, a young man, a recurrent dislocation, heel sac lesion, as well as subcritical bone loss with the previously malunited glenoid fragment. So you could do a lot of things. You could do arthroscopy, you could do stabilization, you could do remplissage, you could do repair, release the small fragment and reattach, Sugaya technique, or you can remove it and put a letarge or a bone block. So a lot of things to do. But I scoped him and I saw this. A type 3 slap, bucket handle tear, along with heel sac, anterior labrum, and also posterior inferior labral tear. You see a mild glenoid erosion. I saw the type 3 slap. Immediately, Alex's face came to my mind. So I did a remplissage, that's the bleeding surface, remplissage anchor in place. And then I did a posterior inferior labral repair. The inferior labrum you can address very well through posterior route. So I have put 2 suture tape anchors and repaired that. Then I went to the anterior labrum, repaired with the all suture tape anchor. The next is I did a DAS onlay technique where you put a double loaded anchor at 3 o'clock on the glenoid and make a subscap split portal and split the subscap in the lateral part. And through that you take the suture and go through the rotator interval and take bite on the biceps. Because the biceps is still attached, it is easier to do that. And once you do that, you release the biceps. And after releasing the transverse bicipital fascia, you just need to pull the other 2 suture, which will railroad through the subscap split onto the glenoid. So that is the finished repair of biceps rerouted through subscap to augment our Bankart repair. And after that, I checked the anterior superior labrum, that is labrum above 3 o'clock, it is a bit loose, so I just put an additional anchor and repair. So this is our final result, humeral head centered against the glenoid, posterior inferior labral repair and remplissage repair, and you have the anterior inferior labral repair and DAS plus anterior labral repair. So stable. And that is the patient next day. I don't routinely use sling for my patient, so he's comfortable moving his hand. And that is his movement last week when I saw him 1 month postoperative. So to summarize, instability surgery, you need a proper technique, choice of implants, recognize glenoid bone loss, that's the key, address the heel sac lesion, augment if necessary, do anatomical procedure as much as you can. If failure, go back to step 1. Thank you.
Thanks, Ram. We'll have all the questions towards the end of the session.
So next we call upon. Okay, that clip was important, but next we will call upon Dr. Alex Ladderman to describe.
ये बाबूराव का स्टाइल है
And that's absolutely in his own style. He is going to describe how does he do a DAS procedure and what are his indications for the same.
Good morning. So first of all, I would like to thank all of you for the invitation, and particularly Ashish. It's a pleasure to be here. Second time for me in India. The first one was in Goa, but I'm not sure that Goa is really India. I'm not going to talk about really technical tips and tricks, because this is something that we will see tomorrow during the live surgery, but rather on the rational indication and the biomechanical that is behind this new technique. So I have some conflict of interest. We talked this morning during the breakfast session about soft tissue, and in most of the cases, isolated Bankart for me, that has been with time the gold standard. No, thank you. Some want to restore anatomy, and I really hate anatomy that previously failed. So I want more. And this is why we, with Philippe Collin, had the idea to develop this technique called DAS, for dynamic anterior stabilization, that this may be the missing piece between the Bankart and the Latarjet. This is for this case with subcortical bone loss, but no Hill-Sachs lesion. So I remember this was in Paris in 2016. We were drinking a whiskey at 1 a.m. and Philippe said to me, I had a really stupid idea, and he told me his idea to deroot the long head of the biceps, and I said to him, it's a great idea, let's do it. So this is how it started. So this is the idea. You have here a normal shoulder with the long head of the biceps on the left side, the short head of the biceps on the right side. This is what you do when you do a Latarjet. You just take the short head of the biceps and transfer it onto the glenoid. And the idea was to do exactly the same, but with the long head of the biceps. And at the end, you do a standard Bankart repair. So you just augment anteriorly your Bankart. The indication, so you just show the best indication associated slap lesion, but otherwise it's all anteroinferior instability with limited bone loss, unstable painful shoulder, and instability in hyperlax patient. Why? Because this is not my best indication for Latarjet. And you saw a very nice case just now. This is another one. So you just transfer the long head of the biceps on the anterior part of the glenoid, the biceps going before into the subscapulary split that you created. And in this case, a remplissage has been added as well. So there are a lot of things that remain unknown regarding this technique, and one of them is the technique of fixation. I need to admit that I love the inlay fixation with an interference screws, because it really allows me to have a strong initial fixation, and consequently my patient can move right away after the surgery. Other surgeons thought about a different technique. Oleg Millennium from Russia tried to reconstruct a missing labrum with the biceps. Some are doing the technique of Pascal Ballot with an under button. This is also feasible. The Anna and Clara from Portugal try an only fixation with all suture anchors. A lot of possibilities have been proposed, and today I don't have yet the perfect answer. We are working on biomechanical study to try to determine what is the best way to fix your biceps. We have been working a lot to try to simplify as much as possible this technique, And when I was doing arthroscopic latarjet, one of the stressing part of this surgery was the subscapulary split. Why? Because it was not performed always at the right place. I was very often too lateral, not in the muscular part of the subscapularis, and I was, like a little bit everybody, from time to time too high. So what we did, with the DAS, we analyzed another way to create the split. You just pass the biceps through a small hole in the muscle, and then with the biceps under tension, you ask your assistant to do internal, external rotation, and as the biceps is passing in the muscular part, it just sprayed by itself the subscapularis, and this is something quite efficient. So this is a small video demonstrating this technique. You start, so this is a posterior viewing portal, and then with a probe coming from an anterosuperior portal, I just create a small window in the capsule that is just posterior to the subscapularis. And then with a clever hook, now I'm looking from a lateral view, with a clever hook coming posteriorly, I'm going through these windows, through the subscapularis, and I just grab suture that are attached to the biceps. The biceps is pushed between the subscapularis and the conjunct tendon, and with my clever hook, I will just grab this suture and pull the biceps into the joint. And this is something that is quite simple. You have a complete control. You don't need to see the axillary nerve, even if the axillary nerve is just medial, you don't need to see it, and you have a control, you make sure that you do not damage, and then you will simply push your suture posteriorly, and the biceps will automatically enter into the glenohumeral joint. So this is the case now. So you see the biceps going into the split, through the subscap, and then into the joint. So quite easy. And we show that this technique allows you to have a split that is usually long enough, around, it's a mean of 2 centimeters, and so this is unlikely to limit external rotation. And if you introduce with an inlay technique, if you introduce 2 centimeters of the biceps into the glenoid, you are usually isometric, and this is why we didn't observe any cramps or Popeye sign. Postoperative rehabilitation is, as you just show, quite easy. I almost do not immobilize this patient, only I just propose a sling for 10 days. They stretch since day one, but I asked several things. The first one is no sport with upper limbs during 6 weeks. I asked them to avoid flexion of the elbow against resistance, no more than a bottle, and I asked them not to carry. So this lady is 7 days after a DAS. This gentleman 10 days after a DAS. He already has quite a good anterior forward flexion, but you will see that the external rotation remain for the moment a little bit limited. And this patient is 3 weeks after a DAS, and he has already quite good range of motion. He's not doing push-up yet. But this is typically what you can expect after this kind of surgery. And as we have with the inlay fixation, a very strong fixation, I think that you can move them quite safely. So this technique has some theoretical advantages. It provides the hammock and the sling effect that are important stabilizing factors. It eliminates the risk of nerve dissection, so this is easier and safer than the arthroscopic latarjet. There is no traction on the crack rate process, and the drilling is inferior, so this reduces the risk of neurological damage. There is no coagulant transfer, so the procedure can be done with 3 very small incisions. It avoids cortical resorption, and as there are no screws or graft, it reduces probably the dislocation, the rate of dislocation arthropathy. There are some drawbacks, and George et al. Proposed one of these surgery, and it's because the short head of the biceps is not going down and up and down. So this might be one of the drawback of the technique. Is it biomechanically relevant? Yes. Several studies demonstrate this. So, and this is what I said this morning during one of the sessions. I love DAS because it's stronger than the nature. it's becoming statistically significant after 10% bone defect and highly significant after 20% of bone defect. But there is a problem. The problem is it limits the translation of the human head less anterior of DAS, but it's so strong that the human head remains posterior if you have an important bone loss, and this is probably why we should not perform this surgery with a bone loss of more than 20%. So another study performed by Alan demonstrated that the DAS plus bone count is not as strong as the Latarjet, but clearly stronger than an isolated bone count and than nature. That is my goal. So the results are good. I had personally 6 recurrences, 3 in the publication in of arthroscopy with 13% of instability that I succeed to try, that I treated conservatively in 1 case, and I had to do 2 revisions. Since I understood that I need to place the biceps more posterior, the results are good, and as I said, it has been published in arthroscopy. So in my practice, I do exceptionally isolated bone count. It's mainly for unstable pain.
Can you summarize?
Yes, it's done. And otherwise, in most of the cases, Latarjet, and this represents 95% of my cases. Thank you.
Thanks, Dr. Lederman. Now I request Dr. Hachu to come and speak on why, when, and how bone block
गोल्ड तो गोल्ड
metal-free
होता है
separate.
छोरा लावे या छोरी
Good morning, everybody. Thank you, Ashish, for the kind invitation. It's a wonderful city, wonderful conclave, shoulder conclave. So let's go to talk about this topic, why, when, and how bone block metal free cerclages. This is my disclosure. So why, to answer why, let's go to define what is the subcritical bone loss. More than 20 years ago, these 3 guys, Itoi, Bolkar, and Yamamoto, defined this quantity, and there are no controversy about critical bone loss more than 20%. And later, from South Korea and from North America, they defined a little bit a new concept about subcritical bone loss more than 13 or more 17% of the glenoid bone loss and anterior shoulder instability. So, and recently, Pascal Wallot defined, based in the risk of failure and reoperation after Banca plus remplissage, a new concept, maybe not a new concept, this is the threshold is lower, less than 10%. So maybe we can call it now a non-subcritical bone loss. So we know there are no linear relationship between the size of the glenoid bone loss and the stability. And the critical value of the glenoid bone loss is different for every single patient. It depends on the risk factor, size, and deep. So we know now the critical bone loss is less and less and less and lower. So, and when, this is to answer when, we should understand how we can manage the glenoid bone loss. From the beginning, we tried to define the engaging heel sac, but not easy during the surgery to provoke this engaging heel sac because it's a flu and the water. And all of us knows also the biomechanical model about glenoid tract developed by Yamamoto and Itoi. And regarding to this model, we can define now a threshold between 20 and 10 subcritical bone loss, and now we are not discussing about Banker plus remplissage or plus or not remplissage for smallest bone loss defect in the anterior side. And for critical bone loss, all you need in general is a bone, at least in the glenoid side. And we could be agree, all of us, with this critical bone loss, we should use reconstruction and to put our bone from the coracoid process, from the iliac crest, from distal tibia, whatever you have. But the gray area between 10 and 20, maybe this two kind of treatment, glenoid reconstruction with bone grafting or Banker remplissage, it's work in this area in between. And regarding to what happened in the literature, about the non-lateral procedures. Look at this, more than 500 cases with in this meta-analysis. They find low failure rate, low complication, and highly return to sport with this type of surgery. And regarding another meta-analysis, they put all these types or glenoid bone loss treated by graft by different type of fixations, and again, they found low failure rate, low complication, and improvement in all surgical procedures or clinical analysis. So my indication when I do it, when I have a lower defect, less than 10, 15, with or without off track, I prefer to use always bunker plus remplissage. And for greater than 10 and 15, I always prefer to do anatomy restoration of the glenoid bone loss by adding bone grafting using these cerclages without a metal-free technique. So how I can use it? So we published this technique in 2019. Tomorrow morning we will see tips and tricks. And this system of cerclages works for posterior bone loss, for adding bone loss in the posterior instability, and also for lateral jet. And this technique is a little bit, now we can use it with a new guide, precise guide with 2 offsets. 2 tunnels come from posterior. We can use smallest tunnel, 2.5 millimeter or 3 millimeters, and we transport suture tape cerclages from posterior side and recovered through the rotator interval. And now this cerclages comes from anterior to posterior and bring the graft from the rotator interval, respecting the anatomy. And this one of the tips, more important tips in this technique, is to interconnect these cerclages and to slide down the knot, the preformed knot, to the posterior side, and at the end adding tension and using a tensioning. So my goal is to restore the anatomy, but without forget the bunker repair on the top of the glenoid side, because I prefer to put the graft extraarticularly. This is anatomy restoration. That means we should detach all the glenoid side capsulolabral complex from anterior to until 6, 7 o'clock. After that, to reattach it, shifting from inferior to superior and from lateral to medial. This is a sling effect for me with the nature anatomy to restore the anatomy. So we recently also published a comparison study, biomechanical study, in between cerclages, 2 screws, and endobuttons. And what we found that suture tape cerclages fixations can be stable enough for bone block and achieve healing rate in clinical relevance. So, but in primary cyclic stability, we achieve a comparable stability in comparison with 2 screws fixation. And we enhance cyclic contact healing in between the bone interface in between bone. Recently, we sent to this paper, and it's in press now. We did our first result after with 23 cases. We reached a high union rate at 3 months with more than almost 3-year follow-up. We mix allograft and autograft. Look at these images here. This is a new shape of the glenoid. In the beginning, more than 2 years in the beginning, we started to follow this patient. We're using MRI because we don't have metal. We can do MRI. And look at this another case. After 2 years, the allograft is still there, but allograft, remember, present a delayed resorption. We should follow this patient more than 2 years and 3 years. And this is technique. It's reliable. It's very could be used for any single advanced surgeon. This is a case done by my former fellow from Chile. He sent me yesterday this case after 15 months with this technique. If you want to revise some cases, this case was a failed case from my series. Look at, because we received this allograft, it was very thin, so suffered resorption, and I detach again the capsule, I find the capsule, and I cut the tapes and redo the technique with a new guide, new graft from iliac crest, autograft, and then I reattach again the capsule, and what we found at the end, we restore again the anatomy without any metal, without any struggling with the screws, because all of us who know revise Ratarget procedures or revise Eden-Hibinet procedures with screws is a big problem. So, and now we started because we believe distal tibia, if it available, I have available in our department, distal tibia have, we can reconstruct both curvature of anterior, posterior, and superior and inferior. And we could use the same, but it's a very strong bone because it's a load-bearing bone from the donor without any struggling, any issue about the quality of the tissue from the donor. So now look at this. The shape is almost, we reproduce both curvature in anterior, posterior, superior, inferior, and we reach now, look at how the patient present at 3 months in Bernajot view, the density and of the cancellous bone is almost much more than the previous native glenoid side. So in summary, my indication and for this technique or for any bone block is almost more than 10-15% of the glenoid bone loss in anterior side. With on or off track lesion, I prefer the anatomy to restore the anatomy. Using cerclages, 4 cerclages in one tunnel, small tunnel, you restore the anatomy, you give stability, rotational stability, and at the end is as a metal-free system and safe, effective. I didn't see any, after having done more than 70, 80 cases, also only one case I had doing lateral cerclages. I have one palsy of axillary nerve, but fully recovered, and good outcome at 4 years. But we need, as always, long-term follow-up to understand if it's the best technique and the best graft for the future. Permit me, Ashish, to invite you for the next bias shoulder course in Barcelona. Thank you very much for your attention.
Thank you, Dr. Hashim, for being spot on time. And
Control.
so next up,
Control, Uday.
I doubt it whether he can ever control his surgical indications, but next up we have our own superstar surgeon from India, Dr. Dinshaw Padiwala, to talk on his 5-year follow-up clinical results on management of large glenoid fractures.
Thank you, Ashish. So I'm going to take arthroscopic repair for acute large glenoid rim fractures. What really are their long-term outcomes? In 2017, we defined a massive bony Bankart as one that extended beyond one quadrant of the glenoid. So all of these really are large or massive bony Bankart. These are acute glenoid rim fractures. And we spoke about how to fix them with an arthroscopic repair, but we really don't know what their long-term outcomes are. And therefore, we had this retrospective study where we studied the minimum 5-year follow-up following an arthroscopic suture anchor repair for acute large glenoid rim fractures. So how do we define this? Acute meant less than 4 weeks. Large meant more than one quadrant of the glenoid had to be involved. Glenoid rim meant Edinburgh type 1, both anterior and posterior, so 1A or 1B fractures. And besides fractures, we also included combined lesions, so those with rotator cuff tears. And we studied their minimum 5-year follow-ups. What were our exclusion criteria? So chronic lesions or chronic bony Bankarts with instability, either anterior or posterior, we excluded. If it was an undisplaced fracture, an articular step less than 2 millimeters, we usually treated this non-operatively. If it was a quadrant that was less than, if the fracture was less than one quadrant like this patient, we excluded it. Any sort of open or screw fixation repair, we excluded. And any prior operated Bankart repair with a rim fracture, you know, the postage stamp fracture as we call it, we excluded these. So we had a total of 37 patients operated between 2010 and 17, age between 17 and 64. We had 3 patients lost to follow-up, so we had a 34 patient group. The follow-up extended from 5 to 12 years with a mean of 8.2. And what we studied in all of these patients was their radiographs to try and assess their osteoarthritis. We graded this based on the Samuelson-Preto grade of glenohumeral OA. We also assessed their quick dash, their ASES, and their row score so that we could get their function, their instability post-surgery, and their normal function. So let's see what our group was. We had a total of these, so single row. So if it's any fracture where the depth of the fracture is beyond 10 millimeters, we performed a suture bridge, so we had 15 of these. If the depth was less than 10, we did a single row. If there were hinged fractures, we had only 3 in our group. We performed a single row with some modifications. And in the combined group with rotator cuff tears, we had 7. So I'll show you a few examples of the surgical technique and the results. This is a posterior bony Bankart lesion. So this patient had a posterior dislocation. We reduced it. You can see that large fragment there. Got his MRI done. We can see that there's loss of that glenohumeral congruity. It's subluxating posteriorly in that supine position with the MRI. Got the CT scan done. It's a large fragment there posteriorly. This would be an indication for me for a single row repair, especially posteriorly where that rim is very narrow. You really don't want to do a double row repair. So I usually visualize from the anterosuperior portal. These are usually less than 4 weeks, so the fracture is still mobile. If it isn't, you put your probe or your soft tissue liberator in, make sure it's free. I typically use a suture anchor inferior, where this will go around the labrum, so that becomes like your reduction suture. 2 or 3 suture anchors in the crater and above, and then you can bring that fragment back in its anatomical position. And we can see here, at the 1-year follow-up, we did CTs for all of our patients. At the 1-year follow-up, a good anatomical congruity for the joint. His 12-year follow-up, that's his X-ray. So he had a radiographic OA, none. A quick dash score of 0, that means good function, ASES 100 with a row score of 95, and he's a happy patient. Now the second group, which was a suture bridge, so large fragments like this patient, actually we were thinking whether we should conserve him initially, but when we got the CT scan and saw the displacement, we opted for repair. He also had a superior labral bucket handle tear and a posterior labral tear, which we repaired at the same stage. So as far as the bony Bankart is concerned, again, this is acute, done less than 4 weeks. Visualize initially from the posterior portal, clear it all up, make sure that that fragment's mobile, shift the scope to the anterosuperior portal, again, define the area. You want to get a good anatomical reduction, but you also want some soft tissue retensioning. So you put in 1 anchor inferiorly. After that, you put in your medial row anchor, and the sutures from that are going to go across the fragment. Now, in the initial part, we used to take a trans-subscap portal for these, but with the newer devices which are curved, you can actually do it with your standard anterosuperior portal. Do a trial reduction, make sure that that fragment sits perfectly in position so you can decide where your second row anchor on the glenoid goes, the lateral anchor, and then put in your suture anchors and then tie it down. In some cases, we used something like a push lock on the medial side, but in others, we used just a simple anchor there and then tied these down. We found that we had better control if we did that. Of course, this patient also underwent a posterior labral repair and a superior labral repair. So you can see at 1 year, that's his CT scan. And at 6 years follow-up, again, a good outcome, both radiographically and functionally. And the last, which were the hinged fractures, we just had 3 of these, and here we try and retain the hinge. So again, that's a fracture. You can see the significant step out there in the CT scan. Now, how do we treat these? So again, a similar sort of approach, but we try and keep the hinge intact. The hinge is typically inferior. It's also along with the labrum. So the labrum's attached inferiorly. There's some amount of bone there. Usually these patients have a significant step, and the step is really what you want to reduce. So again, put your scope in the anterosuperior portal, define the entire fracture, and the most important thing here is to first reduce it. So you've got your 2 portals now where you reduce it. You've got your posterior portal, you've got your anterior portal. Put your soft tissue liberator in and gently tease that fragment back into position. Now with your probe coming in from the posterior portal, you can do a fine sort of reduction there. Make sure that you're getting a good anatomical reduction. Once you've got that anatomical trial reduction in, that's when you can start putting your anchors in and going ahead with your suturing. So that's the first anchor inferiorly. In this case, we use a bone stitcher sort of instrument that will penetrate the bone. And you need to be a little careful here that you don't want to fragment these and cause comminution of the fragment. And again, you can use your posterior portal again to bring that fragment into position. Use your bone stitcher instrument to go across the bone fragment. You don't want to go all around it, otherwise you're going to have angulation of the fragment. You go across it and put your sutures through. The main reason for us doing this study was to really see what happens to these patients from OA point of view, because you've got these sutures that cross the glenoid. It's not a weight-bearing joint, but these sutures are non-absorbable sutures. They cross the glenoid. Are they really going to cause long-term problems to our patients? So you can see that's his 1-year follow-up, and that's his 11-year follow-up. So again, radiographically, no OA, a quick dash of 2.3, and excellent ASES and row scores. And for our combined rotator cuff tears with these bony Bankarts, we typically did it in the same stage. First, go ahead with the bony Bankart repair, and then do your arthroscopic rotator cuff repair, and you could choose whatever technique fitted best for that patient. So what were our results? We had fracture reduction, which was anatomical in 33 of 34 patients. Remember that these are acute fractures, so it's quite easy to get an anatomical reduction in these patients. But in one patient, we had a non-anatomical reduction, and this was primarily because we wanted good soft tissue tension antero-inferiorly, and to do that, we had to shift this fragment superiorly. But what's most important is making sure that this fragment is in plane with the glenoid. It's not proud, and that ensures that this patient's not going to have any instability or any increased rate of OA. And again, going to the outcomes there, we saw that the isolated glenoid rim fractures had really almost no rate of OA, even in long term, 5 to 12 years, with excellent sort of scores from Quick Dash, ASC, and ROW. Unlike that, the combined lesions, these were slightly older patients with rotator cuff tears, and so it was really the rotator cuff repair that dictated their outcomes, which were, of course, much poorer than the younger patients with the glenoid rim fractures. So in conclusion, arthroscopic suture anchor repair for acute large glenoid rim fractures, it's a versatile technique that can address all types of large glenoid rim fractures. If you've got a rim, which means a fracture which is less than 10 millimeters in depth, you could do a single row. Anything beyond 8 to 10 millimeters, I think a suture bridge is better to ensure that that fragment doesn't angulate. Hinge fractures, again, you can use a slightly more difficult technique, but still achieve an anatomical reduction. And when you associate it with, you could do this with a rotator cuff repair in the same stage. The anatomical reduction is usually achieved, but the technique is demanding. In this series, all patients had fracture union, so none of them went into non-union or delayed union. No patient had recurrent instability, but something that we do know that with these patients, as soon as union occurs, they get back to stability, and no patient had any reoperation for any other reason. And the patient-reported outcomes revealed excellent long-term results in this group, and almost no incidence of glenohumeral OA. So that suture that crosses the glenoid, which was our main concern, does this cause problems in the long term? We saw that none of these patients had any sort of long-term problems because of the sutures. I think that over time it either softens or synovializes. Thank you very much.
Thank you, Dinsha. I request Dr. Nilesh to come and speak on revision Bankart for fail instability.
ना हो पाएगा हमें तुम्हारे लक्षण बिल्कुल ठीक नहीं लग रहा है तुमसे ना हो पाएगा
So I would like to start by thanking Dr. Babulkar for his invitation. Always a pleasure to be a part of this meeting. And I'll be discussing on revision Bankart for failed or revision labral repairs for failed Bankart surgery. Well, for the uninformed, what it simply means when you say tumse na ho paega, meaning it's not everyone's cup of tea. So these are my financial disclosures. For over the years, for recurrent anterior instability, it was considered that probably arthroscopic Bankart repair is considered as standard of care. But then, is this really true? Because if you look at literature, even in the best of hands, the failure rate is as high as 4 to 19% and probably more. Then what is it that really brings about this failure? And that's something which is extremely important to identify. Commonly, it's a technical issue where either less number of anchors have been used or poor surgical technique, poor patient selection, and you've heard about this in the prior talks about the concept of subcritical bone loss or associated bone loss, failure to identify associated pathologies. But what is also important is a recurrent trauma for previously operated cases. So if you look at this systematic review, in all these papers, trauma had an important role to play, and that's something that we can't overlook. It means that you may restore anatomy, but how good is this healing for it to prevent a re-injury while re-trauma? So can we predict failure? And the French Arthroscopy Society looked up the subset in a multicentric trial for 11 centers for 328 patients. And with the ISIS score less than 4%, they followed it up by 18-month follow-up, and their recurrence rate was as less as 3.2%. So that's something which is worth noting. So we know that understanding the cause for failure is important, and if we look at the shoulder joint like a hammock, the hammock can refail either at the site of the glenoid, either in the form of a soft tissue or a bone loss.
It could be a poor capsule where probably a procedure like DAS would come into picture. There might be an associated Hegel or a Hill-Sachs lesion on the humeral side. But more importantly, look for bone loss, because bipolar bone loss is a concept which we can't really overlook. So over the years, for more than 20 years, when the concept of significant bone loss was described, it was not that magic figure of 25% on the glenoid, but we also know the concept of an on-track and off-track, which does come into picture on the humeral side. So what are the challenges when you look upon these revision surgeries? The first and most important thing is the tissue quality. If you look at the video on the right, you can see that a primary Bankart repair has a juicy labrum which is begged to being repaired out there. But the same thing in a revision setting, you can see it's a confluent fibrous mass. And that's when you're worried about how your tissue bites are going to be and how much of restraint is it going to avoid. The second thing is a combined bone loss and cartilage defects. So most of these patients, if not all, do have an associated Hill-Sachs when they present late. And if this is not looked upon when it's an so-called engaging Hill-Sachs, even at the primary lesion, that's effectively going to fail. The Moon study group actually looked at this, and for revision surgeries, they believe that there is a significantly high association of cartilage defects, and that's something which needs to be looked upon in the long run when you're looking at these patients up for a revision labral repair. Fortunately, we don't use metal anchors as much, but for the junior surgeons who are starting their journeys, especially in India, the temptation is quite solid to use cheaper anchors in a government setup. Humble request not to use metal anchors because it's a chaotic situation when it comes to try to remove these metal anchors. The other thing is osteolysis. Again, fortunately, we have evolved over the years, and now we don't use the PLA anchors, which used to cause about significant osteolysis, and you really don't have much of a playground on the glenoid when it comes to a revision surgery. We all know that these all suture anchors are really catching up, and this is one of my own patients at a 1-year follow-up. I do get serial x-rays done for them. And this is something which got me thought-provoking, that how much of osteolysis is going to happen when you're using an all-suture anchor. And we looked up our own patients for 72 consecutive patients with 196 anchors, and we did a repeat CT scan and looked for assessment of healing. Fortunately, majority of them did either heal or at least partially heal, and the osteolysis the p-value was not clinically significant. So at this point of time, at least in our study, we felt that the osteolysis was not significant enough to not use these anchors as we go along. So here's a case example of someone who's operated in 2017, a minimum of 3 anchors which was used, and then sustained a re-trauma, and there was a revision labral tear. So that's your, on the axial cut, relatively decent labral quality, and that's something you would want to assess on your pre-op MRIs. I do understand that's one variable that you can't look upon for every case. These are the residual anchors which are there, and that's the CT scan. All these patients will get a MRI as well as a CT scan as a mandatory factor to assess for bone loss. That's my operative technique. I operate them all in a lateral position with a commercially available 2-pulley traction kit. You assess for bone loss, and then viewing from the anterior superior portal, you try to look at the anchors and the presence of sutures. So even here you can see technically the suture bites, or probably the labral bites, were not as robust as what you would want. The first thing would be taking away each anchor in a sequential manner. Then you identify the associated pathologies, and in this case, there was an engaging Hill-Sachs. So this is a pre-operative decision for me whether I'm going to do a Hill-Sachs or a remplissage or not. You freshen it to get a good bleeding bed, and then in a sequential manner, go ahead, use a biocomposite anchor on the posterior aspect, get your sequential bites into the labrum, and then start on with your, into the posterior infraspinatus and the capsule, and then you go on to the anterior aspect. Now, one trick for the anterior aspect is that when you start releasing this, I wouldn't just use a liberator because the tissue is quite friable. So using a radiofrequency allows me to lift it up as a single sleeve, and that prevents any further disruption of the tissue quality. Using suture anchors, I don't bother to remove the previous anchors unless they're proud enough. And then using tape anchors, the reason for using tape is because your linear stresses are then divided. It does not cut through this tissue. And then you go ahead and do a standard Bankart repair. Posteriorly, later on, you go on and tie your remplissage anchors, and that's the final repair when you're looking from behind. So what are the risk factors for failure of arthroscopic revision anterior stabilization? So we know that when the patient has an off-track lesion in a young patient with associated ligamentous laxity, they might probably not be good cases for a revision labral repair. And that's where you need to put your thinking hat on and look at other options as was discussed earlier. Do they really return back to sports? If you look at this paper, 20 athletes, a mean assessment of 21 months, and they do return to sports, but probably not as well as what they were pre-fall or pre-injury. So this is something which is important when you counsel these patients, especially in the elite population, whether are they going to return back to full sports. Professor Imhoff has shown that in his hands for 56 patients at 37 months, there was a high rate of return to sports and high patient satisfaction. Well, is this reproducible? It depends on patient, depends on the kind of sport that you're playing and expectations from the patient. I've operated 17 patients, predominantly male. In majority of the patients, there was an additional procedure. So 83% of patients did require an additional procedure, either in the form of a Bankart or an associated posterior labral repair. So we started the talk by saying that tumse na ho payega. I probably think that now we can safely say that tumse ye shayad se ho payega, but your indications need to be right. You need to have patients with no significant bone loss. There is no evidence of generalized laxity, no arthritic changes. So patients who do present with recurrent dislocations after a prior surgery, there is a high incidence of arthritis. You need a compliant patient, and relatively low to moderate demand patients is the ones where I would look about thinking about a labral repair. So if I have to give a take home, failed cases can be managed by doing a revision labral repair, but mind you, in selective cases, not in every case, identification of a cause of failure is something which is very important before taking a decision on revision. Pre-op CTs and MRs are mandatory in addition to routine X-rays because you want to identify the cause. Intraoperatively associated pathologies need to be tackled and identified appropriately, and they are associated with a high rate of failure in young patients and those with ligamentous laxity. So choose your patients carefully. Thank you.
Thank you, Dr. Nilesh. Now I request Dr. Mihata to come and speak on overhead athletes, how to ensure a return to sports.
किसी महापुरुष ने कहा है कि कामयाब होने के लिए नहीं, काबिल होने के लिए पढ़ो। सक्सेस के पीछे मत भागो, एक्सेलेंस का पीछा करो। सक्सेस झक मार के तुम्हारे पीछे आएगी।
किस महापुरुष ने कहा है? बाबा रणछोड़ दास।
You can start.
Okay, first of all, Ashish, congratulations on the wonderful and outstanding shoulder meeting already. For me, it's a great honor to be here, and thank you very much for inviting. So my first talk here is overhead. It's not instability, how to ensure return to sport. It means mostly physical therapy. Here's my disclosure. As you know, the throwing motion is achieved by activation of kinetic chain. Throwing force is generated in the lower extremity first, then transfers through hip joint, trunk, scapular, glenohumeral joint, elbow, finger, and ball. Maybe not only baseball, maybe the cricket is the same, actually. The kinetic chain is very important to return to sport and also prevent shoulder injury. And the pathological mechanism here, most of the throwing athletes have the shoulder or elbow pain. The symptoms usually occur in glenohumeral joint and the elbow joint. But cause of the symptom is just before glenohumeral joint. It means the scapular, trunk, hip joint, lower extremity. So disruption of kinetic chain. So treatment of throwing injury, usually we do the physical therapy, surgery, injection. And injection surgery, usually we apply to the symptomatic region. It means the granula joint or elbow joint. So injections and surgery are symptomatic treatment. But actually, cause of symptoms, it's not here. So physical therapy can be applied to the causative factors, scapular, trunk, hip joint, lower extremities. So the curative treatment of throwing shoulder injury is only physical therapy. So now I focus on physical therapy. I'm telling about our therapy. First, we evaluate the symptom and pathological condition first before physical therapy. Of course, in the shoulder, internal impingement, cervical impingement, range of motion, muscle strength, shoulder laxity, pain provocation test, heart test, we check everything, and elbow. We check range of motion, muscle strength, nerve symptom, pain provocation test. And not only shoulder and the elbow, so we check the whole body condition, neck, scapula, trunk, hip joint, knee joint, and ankle joint too. Then we evaluate where is the pathological condition. Then after we found the pathological condition where it is, then based on this evaluation, we study the rehabilitation, namely conditioning. More than 90% of throwing shoulder injury, the patient has the posterior shoulder tightness. So we have more than 10 techniques to treat the posterior shoulder tightness in the physical therapy. Also, scapular mobilization is very important because most of the shoulder pain and athletes have the scapular stiff. And also trunk mobilization, very important to improve the scapular mobility. And also hip joints are also very important to get a good range of motion. Then next, I want to show our results of the physical therapy. 65 baseball player is a competitive baseball player with shoulder pain underwent physical therapy, 8 professional, 22 under university, 31 high school, 4 junior high school. And MRI findings, 32 strap lesion, 8 strap and passer. It's not so severe as mild passer, and 25 shoulder arthritis. So here's the result. Posterior tightness, we check the shoulder internal rotation angle to evaluate posterior tightness here. Then before physical therapy, only 21 degree, but after physical therapy, increased by 20 degree. It means the posterior tightness improved. This left is the before and right is after. Clearly, you can see the increased internal rotation after physical therapy. And we check scapular position. So using scapular spine distance. If the patient has more than 1 centimeter size difference of scapular spine distance, we call positive mean the scapular malposition. So before physical therapy, 66% has a positive, means the scapular malposition, and after our physical therapy, 98% negative. And hip range of motion increased around 16 or 17 degree after physical therapy, less before and right after. Of course, clearly you can see the good increase hip range of motion. And the internal rotation in hip joint also increased 12 degree in average. You can see the clearly increased hip joint internal rotation. Then afterwards, after we treat the whole body condition, then here's the rate of return to sport. So 94% return to previous level after physical therapy in the strap lesion patient and mild passer lesion patient. And here's another advantage of physical therapy. So better performance can be expected. So this is the baseball players of my patient is only the professional level. And this is ERA means it's a less than 3 point. ERA is a very good performance. So most of the players keep the good less than 3 means that keeps good performance after return to the sports, because even after return to sports, they keep doing our physical therapy to keep a good body condition. But sometimes actually the severe pastor or complete rotator cuff tear, we need to do the surgery even in overhead throwing athlete. because James Andrews published this paper, only one pitcher, 8%, could return to the competitive level after rod calf repair in full thickness rod calf tear. I don't do the rod calf repair alone. So now I'm doing the SCR plus calf repair for the overhead throwing athlete in complete tear or severe plaster, because high healing rate, even in severely degenerated rod calf tendon, and also we can avoid the over tightening. So this is the case. It's a complete rod calf tendon tear. Muscle quality is not bad, but actually the tendon part is very, actually complete tear, and the tendon is looks very weak because of many straight injection. And this is arthroscopic findings. We found many holes in the tendon tissue because of steroid, but reducible. So we insert the graft under the tendon, and then we fix the graft glenoid first, then great velocity. Then over the graft, we fix the tendon. But usually we medialize a little bit to avoid the over-tightening. This is a Graham joint, graft, and the tendon. So after 1 year after surgery, looks like very good tendon tissue, but actually this is the graft. And this is a severe plaster, supra to infra in overhead professional basketball player. And we fix the inside the graft. Actually, we make a complete tear first, then insert the graft under the tendon. The same thing, glenoid fixed and great tuber fixed, and over the graft we repair the tendon. Then 2 years after surgery, already very good MRI. So in summary, for throwing injury, physical therapy is the only curative treatment. And in baseball player, conditioning or physical therapy can relieve shoulder and or elbow pain and make better performance. And the SCR means the SCR for reinforcement or rod calf repair can be a good surgical option for severe partial or complete rod calf tear in overhead throwing athlete if necessary. Thank you very much.
Thank you, Dr. Miyata.
अकड़ पकड़ खींच के पकड़ पकड़ साले को चढ़ साले पे ठोक साले को खस्सी साला.
So that's Dr. Sundarajan for you, who's going to talk about knotless romposage with sequential tensioning in Bankart. Over to you, Sundar.
Good morning, chairpersons, and good morning, everyone. And thank you, Ashish, for having me again for this prestigious conference. So my talk is on knotless remplissage with the sequential tensioning in the Bankart. So it's a technical talk, and we had to think of why tensionable knotless all suture anchors. And we know that it comes with the two advantages. One is all suture anchors, second is the knotless technique. We know that there are some concerns in the solid anchors where you can have a chondral damage because of the anchor size. Imperfect ankylation can break that anchors. You can have an osteolysis which makes revisions difficult, and also post-operative imaging can be compromised. And we know that advantage of all suture anchors, especially the new generations, has got a less pull-out, small diameters, and the curved guides options gives you the exact trajectory what you want, and also it pursues the bone stocks, makes the revision easier if necessary. And we know that concerns with the knot tying in the Bankart repair, which we know that knot can slip and can give a migration, resulting in impingement, can cause chondral abrasions, and also technically you have to spend more time that. The tensionable all suture anchors, it comes with a 1.8 fiber tack soft anchor, where it also has got a curved guides, unstraight guides, as I told already, that it gives you the good trajectory for your anchor placement, so that the chance of less pull out. And it comes with 1.8 mm size, so that makes this a very smaller size. The curved guide options gives the exact trajectory to get you to that. The what blue thread which is having is the repairable repairing stitch, and what you have this on the loop passing stitch, which is can exchange your repair stitch with the anchor, resulting in the tensionable repair what you want. You can have a manual control tension on that. There are not many clinical studies, but there are biomechanical studies which they had showed that they are done on 18 cadavers. They have done different tensional repair has that done, which with good results. So this is a 25 years old male patient, recreational sports player with less bone loss, with Bankart, with biceps anchor intact, with that is the Hill-Sachs lesion of that particular patient. So here planning to do a knotless research with tensionable all suture anchors. That is the big alpha lesions in the front. And when you do a remplissage, you comes with the two anchors which can be used and it can be interconnected. What you are seeing in the center is the repairing stitch. It can be looped to the opposite looped passing sutures and it can be pulled by the passing stitch. The same way this repair stitch can be looped along with this first anchor so that both repairing stitch can interlink and make your knotless technique easier. So here can be done in the two technique ways, which I use always a single portal technique, which I use for my posterior portal. That is the first anchor which can be used, and that is the second anchor which is an 1.8 fiber tag. This can be done in a different way also, but I will show again. So this is how I do because it doesn't make an extra incision with a single portal and single cannula. Once after making the two anchors on your Hill-Sachs lesion, then you take the bites through the infraspinatus, and I take the first bite through the first anchor repairing stitch, that is the blue stitch, and the second bite takes the another repairing stitching of the blue from the second anchor. So you take it and park it, and once you finish the Bankart repair, then you interlink it. The other way of doing is that you can also doing by two different another percutaneous technique, that you can use the trocar with the two percutaneous incision and along with your posterior cannula. So that's why it makes a two incision in the posterior side. But the advantage of this technique is that you don't need to take any bite. Just put the two anchors, then you interlink with your repairing stitch. So this is again you come back to the labral repair. I think this is a big observation. If you are a young surgeon, this is the most important step in your Bankart repair. Spend enough time to liberate the capsulolabral complex from superior to inferior. So it starts from around 6 to 7 o'clock position to almost around 2 o'clock position. And go down deep as medial as possible. Make sure that you see the subscapularis muscle till some bleeding happens. So this is the important step, because if we don't liberate that labral tissue enough, then you cannot make a correct tensionable repair that can result in failure. So this is the time which you bend, you bring your whole capsulolabral complex to the glenoid margin, then you start doing the repair. Then you insert your first anchor at the 530 position, then you insert your 1.8 fiber tack stitch here, then you take the bite through the 6 o'clock position, you take the Nintal wire, then you exchange that Nintal wire with your repairing stitch, that is the blue thread from the fiber tag. The two white is for the passing stitch. So you take it through the posterior portal, then you exchange with your Nintal wire. So that is the first stitch. What you can see, the repairing stitch can replace that passing stitch through the anchor by pulling that passing stitch through the loop. So that's how once you make that first stitch, you don't need to tension much. You just keep it over there, then go for the second anchor, then take the second bite. That second bite helps you to bring that more capsulolabral tissue to your glenoid margin. That second bite is taken at 4 o'clock or a 4:30 position. And again, you take out that repairing stitch to the posterior portal, but keep parking that posterior repairing stitches in the posterior portal. Then take that second bite around 4:30 or 5 o'clock position. That gives you more capsulolabral tissue to bring into the margin. That is the bite which you take normally, you bring it entire tissue to the margin. Then you exchange with that. There are two ways of tensioning that. Once you're making the second anchor, you can tension the first stitch, so that will give you the more robust repair on the inferior side. Then you can do the second. Or you can make all the three stitches and you can make the tension at the end. So that is the second stitch, and that is the third anchor. So what you can make that after making the first anchor was already tensioned up. The second and third anchor can be tensioned with the controlled. So which you would have the same technique in the other knotless anchors. So you can bring it more capsulolabral complex and more tensionable repair here. This is the different case here, but again, you can see sometimes it is not an alpha lesion like a previous case, but you will have always one loose capsule along with the IGHL, and this is very difficult to put it into the glenoid margin and make it a correct tension is always difficult. So here you have a control. Once you can make all the three anchors, you can make it differential tensioning from the inferior anchor, then the second anchor, then you can make the third anchor tensioning. That gives you good, nice repair at the end. Then you finish your knotless remplissage. As I already said that the repairing thread of your first anchor is looped into the second looped passing stitch and pulled by the passing stitch that takes the repairing stitch to the second anchor, and the same way you can pass the second thread to the first anchor loop, then that gives the interconnect. You don't need to tighten up. Once you finish the both, then you interconnect it. After interconnecting the both repairing stitches, it can be passed alternatively and gives you nice, robust repair of knotless remplissage and also the tensionable Bankart repair. To conclude, tensionable knotless all suture anchor is a technique. Of course, it is comparable to all other technique, but give the advantage of a small diameter. It preserves the bone. It makes the revision easier and avoids knotting and chondral aberrations. Sequential tensioning allows for the proper reduction and adequate tension at the end of the procedures too. So knotless remplissage along with this tensionable repair is an easy technique and avoids knotting again and saves time. Thank you very much.
Thanks, Sundar. Now we'll have a quick 5 minutes question answer session, and you can come and ask the questions. Before anyone comes, I'll ask Hakim one question. I have used your technique both with old and new generation guide. In most of 50%, it is always goes offset 1 or 2 mm posterior drilling guide. What is the tip? How you place the guide?
The most important tip is in front of the hook, you have 2 larger mark. This mark is the exit point in respect to the anterior margin of the rim of the glenoid. So if you feel this is too medial, you mainly should put the posterior part very close to the posterior glenoid rim. The issue is posterior glenoid rim, put it as much as possible in this area.
My question is to Dr. Dinshaw with respect to the glenoid fractures. Now, when we talk about glenoid fractures which are large in size, contributing to almost 35-40% of the total glenoid in terms of its bone loss, the fragments which the suture anchors are going to be difficult because you're going to be finding it difficult to pass around the fragment. Piercing the fragment, as we know, is always going to be difficult, risk of comminution. So these are the fragments whom you think is suitable for a screw fixation. So what is your go-to procedure when you feel for those fragments when you want a screw fixation? Arthroscopic trips, and if you're going for open, then what are your tips in terms of subscap management and capsule management?
So for all of the glenoid rim fractures, we now do it arthroscopic. We're not using a screw at all, we use suture anchors. Our major concern, screws, there's nothing on the glenoid articular surface. Whereas with the anchors, especially for the large fragments, there's a suture that's going across the glenoid. And our major concern over the years was, does this suture cause secondary OA? And that's exactly what this study was for, to show that because it's a non-weight bearing joint and because these sutures probably synovialize or probably become thin or flat over time, they don't cause any rubbing, crepitus, or any secondary OA. So therefore, we use a suture anchor for all of these. Because it's arthroscopic, because you're not transgressing the subscap, these patients then land up with excellent sort of outcomes, both from function, pain, and stability. So it's very rare for us to use a suture, to use a screw. Now, if it's anything beyond an Edinburgh 1, I think then you're going to require an open. We are just talking of Edinburgh 1, that means rim fractures, those all, whether it's anterior, posterior, anterior, inferior, the really large fragments also, I think all of them are amenable to a suture anchor repair. I think the only difficult ones are the ones which hinge. So if it's a large fragment, you can still go down to the neck to put your medial scapular anchor for your double row. But when you've got a hinged fracture, unless you break the hinge, you can't go there. But you don't need to break the hinge, because in that case, use a single row, but don't try and go around the fragment. Go across the fragment with a bone stitcher sort of instrument.
So for the Edinburgh type 2, when you feel that, this is not suitable for a suture anchor, screw fixation, do you still do it arthroscopic, lateral decubitus, any tips for those? Or
Depending
you go
on
for open?
whether you're going to really get the approach, if you're going to get a good access and you're going to get a perpendicular approach for that cannulated guide wire and the screw, I think you can do it. But typically in these scenarios, doing a simple open approach for type 2 becomes, I think, my sort of preference. To do a type 2 arthroscopic is a fiddly affair.
Right. Thank you. Mic 3.
Okay, my question is to Dr. Ladhaman. Is there any consensus about the final positioning of that biceps? Is it on face, at the wall, or superior or inferior to equator? Is there any answer to the final answer?
And I think that this is a lovely part of the technique because it really depends on your patient condition. If you have a patient that really has an important hyperlaxity, you can do a split rather high and put your anchor low, so you will push more subscapularies down. So I decide depending really of the condition of the patient, and it's not really standardized.
And is there any answer on the face of the glenoid or at the side or wall, the final fixation?
One more time?
To fix that biceps on the face of the glenoid, or is there an answer to that?
So at the beginning, I was implanting my biceps probably too medial, and I had recurrences, and Philippe Collin did not have, and he was really implanting the bicep really close to the cartilage, if not on the cartilage. And since I'm doing the same, my recurrence, I didn't have any more recurrences. So I think the key is really to bite a little bit, and to be on the cartilage. Yes.
Okay.
Right.
Hey, Alex, so if the patient has big muscle, okay?
If
the patient has big subscap, if the patient has a big subscap, and now you're putting the biceps on top and inside, and you start to do this, it's pulling a lot of the muscle inside the shoulder. What is your comment about? Because this can bring the musculocutaneous nerve closer. This can relax the rest of the conjoint tendon, especially if the subscap is bigger. So when you take the biceps through the split into a thick subscap inside the joint with motion, do you have any comment or potential issues with it?
So the first thing is you don't want to put the biceps above the subscap. You need to do a split, and traditionally we do the split during the Latarjet at 2/3, 1/3, and for the DAS, I would recommend to be in the middle. Maybe not as low as with Latarjet, but in the middle there is absolutely no problem.
Right, so I know that there are tons of questions which are waiting in the aisle, but unfortunately we have Dr. Peter Camels waiting in the theaters, and we want to stick to the program schedule. We can continue these discussions even on the floor later on, and if we can have the audio link from the OT, we can go on to the next session, that is a live surgery for an arthroscopic repair with Dr. Peter Camels. And may I request the moderators for the next surgery, that's Dr. Dinsha Padiwala and Dr. Sundararajan, to come on stage.
3-3.
Going on to the case history. So we have case number 1, 54-year-old female, complaints of right shoulder pain and weakness for past 1 month, history of night pain present, no history of injury, neck pain or tingling. VAS score was noted to be 6 on 10, UCLA was 13, ASES was 45. On right shoulder examination, the ROM was found to be 170, 170, 20, and SI joint, with ER 90 to be 90 and IR 90 to be 50, with a VAS of 7, UCLA 15, and ASES of 45. Going into strength examination, the MTCAN was found to be 4 on 5. Full CAN was found to be 3 on 5. Infraspinous was noted to be 3 on 5. Hornblowers was noted to be 3 on 5. ASP subscap was found to be 5 on 5. The Napoleon test was found to be negative. So was the O'Brien was positive, and Gerber's was negative. Going into the investigations, X-rays, note the outlet view shows a small acromial spur. MRI, T2 COR shows supraspinatus and infraspinatus tear, approximately 30 mm in AP, with retraction up to the mid-humeral head. The T2 SACH actually showed posterior-superior cuff involving supra and infra tear. T2 axial clearly shows biceps with subscap in good continuity, and the central rotation is affected due to absence of infraspinatus. Final diagnosis, right shoulder, massive rotator cuff tear, both SSB and ISP, type D Collins with type 3 acromial spur. We'll now go for the live demonstration under Dr. Peter N. Chalmers.
Morning, Peter. We can see you and we can see the arthroscopic image too.
Can you hear me?
Yes, we can. Very well.
Great. Great. Well, thank you again for having me. This is, as you guys have seen, a very retracted tear with a fair amount of atrophy of the infraspinatus. We've done a lot of work to get this all cleaned up already. So you can see here, this is kind of the apex of tear right here at the scapular spine. That's its maximum retraction. Infraspinatus is here, supraspinatus is here. We've already done some work to debride our footprint. I'm looking from a posterior portal with the 70-degree arthroscope, which is my preferred scope for rotator cuff repair. I will say that although the patient says she's only had pain for a month, I think this is definitely a more chronic tear than that. You can see, despite releases above and below, it will just barely come to the footprint, which I've medialized about 3 to 5 millimeters. The infraspinatus is a little more mobile. You can see we've cleaned up the entirety of the capsular side. We've cleaned up the entirety of the bursal side. So we've done kind of the most releases we can do, except for a posterior interval slide, which I don't routinely do. But you can see the infraspinatus will come. So that's what we're going to do. Is what I planned here was to do a single row repair with additional covering tension bands, which I sometimes call a triple row repair. It's kind of a maximalist repair. This is a tear you could also consider doing a patch for. I know that Bassam is here with us. This is also a tear you could consider doing a low trapezius transfer for, but we're signed up for a repair, so that's what we're going to do. So the first thing we'll do here is place our anchors. So can I get the all, please? Gray all? Great. So I've already placed made percutaneous anchor portals here right off the spine. So we're going to use those here to get anchors in. So we'll try and place these again, not right at the articular margin, but quite close to it. Can you hold the camera here for just a moment? So to get the right trajectory here, we're going to want to try and camera just a little bit more this way. Perfect. Get these right in here. All right. Anchor. Got some squeaking there. That's always satisfying. Yeah, and I found the 70-degree arthroscope to be very helpful for rotator cuff repair. The thing that I think is particularly helpful about it for me is that it allows us to continue viewing entirely from a more posterior view portal. That allows you to get more space between your portals. More space between the portals reduces chopsticking, and I think generally makes arthroscopy easier. But that's obviously a personal preference. It takes some time to learn the 70-degree scope, but I found that time to be a worthwhile investment. So, the shoulder's a curved joint, so the ability to look around corners is a big advantage, I think, in the shoulder, and that's part of the reason why I think the 70 is pretty useful. All right, so here's anchor number 2 going in. And for a single row medialized repair, I've been passing simples. Part of the reason for the simples is there is some, I got it, if we could just, there is some biomechanical evidence from our lab to show that simple sutures actually get better bite within the tendon than mattresses. The main reason why is because the edge of the tendon is going to be the cable. And let's get the, yeah, this guy. All right, can I grab this from you? And the cable, as you know, passes kind of orthogonally. It passes from anterior to posterior instead of passing from medial to lateral. And so the reason that's important is because you get a better bite within the sutures, therefore, if you grab them this way, or better bite within the tendon if you grab them this way. So I'll show that to you.
Peter, we've got one question from the floor.
Perfect, yeah.
If you get, at this point of time, you've put your anchor in, the patient's osteopenic, and the anchor pulls out.
The other one, the grasper grabber. Thank you so much. Yeah, so there's a couple of different options in that situation. With these anchors, they also come in metal. And you know, sometimes I think with a metal anchor, you get a little bit better bite. You can also get a 6.5, which that's usually my bailout, is to go to a 6.5 metal anchor. The other thing you could do, and this is something that I don't do routinely, but is an option. So we're going to try and get a bite here as anterior as possible, is to put in a buddy anchor. So you can put two anchors right next to each other, and the first anchor gets bite basically within the second anchor.
Thank you.
Yeah. What has been your general approach in that situation, Ashish? Can you hold the camera and give us a view of that? Perfect.
There's one more question, Peter.
Yeah.
Now, when you say a low tension repair, how do you decide how much of a bite you want to take in this cuff?
So, yeah, that's a great question. Certainly that's going to be one of our primary issues in this situation. I'm not sure we're going to be able to get a low tension repair, just to be honest, in this situation. We're going to do our best. And the general way that I'll do that is to try and be a maximalist on releases. And then for bite, I usually aim for somewhere in the order of 5 to 10 millimeters to try and get, again, what I want to do with mine is to get medial to the cable. So you can see here, you can see the cable fibers running this way. Ideally, you'd like to get medial those. You want to grasp those, ideally, with your suture.
Peter, one more question.
Please.
The infraspinatus still looks like a bit stiff. So what did you do for your posterior release, and what was your end point of posterior release?
Yeah, so what I'll usually do is start anteriorly, and I'll start, and you know, we have this is something we've already done in this case, but I'll start at the coracoid, and I'll go all the way from there posteriorly, and the goal, of course, then is to get all the way to the back of the tear through that same approach. So I'll go from there all the way along the top and all the way along the bottom. You know, and I think that the releases on the bursal side are, to be frank, more important than the releases on the capsular side, but that's obviously a matter of opinion.
The other concern is an osteopenic bone. When you use a triple loaded anchor, does it put some extra tension that chance of pull-out is more?
Yeah, I think that's a real concern. You know, obviously this is a relatively younger patient. I think that in females you have to be very conscious of how long has it been since the patient underwent menopause, because as soon as you lose that estrogen support, I don't need any. Yeah, we don't need any of those. I find that makes my life more difficult instead of less difficult. You know, there's definitely concerns for osteopenia. So that's situations where you want to start with, you know, and you obviously what I do is I'm pretty conscious of that as I'm putting in the anchors. We got a pretty good squeaky fit here. You can see my anchors are relatively close together, so there may be a little bit of interference fit between them. So my hope is that's going to reduce the amount of concern I have there. What I'm actually going to do here is, again, with this single row medial is not going to be entire of our repair. Again, what we're also going to do is place some separate sutures medially. Okay, I got the camera, you can let go, thanks so much. So then I usually, you know, the apex is where it's stiffest. So what we're going to try and do is come on either side of the apex, and I'm probably not going to put any sutures directly at the apex, because I think that's the part that's least likely to actually come. Maybe we'll come just a little bit closer to the apex, right there, perfect. Okay, if you can hold the camera just right there, perfect. So usually I'll take a look at that. Did we get a good bite? Golly, I don't love that bite. So we may take that one, just relax on this for a second. I may take that one out and redo it because I wish that it was better. Obviously this is going to be pretty critical here. Just got one suture there that needs to be pulled, or we could end up with some issues.
Peter, there is a question from the floor.
Please.
Biceps, was it intact before?
Biceps was intact, but it was very frayed or on its lateral aspect. You can see the lateral aspect of the pulley here is compromised. So we've done a tenotomy already. And I routinely in my practice do a biceps tenodesis, but I think as long as the deformity is acceptable to the patient, that I think a tenotomy is equivalent, and there's really no evidence to suggest that it's worse.
And is it your routine technique for infraspinatus, especially when it's retracted, or do you change your scope to the lateral portal, use your retrograde device from the posterior portal to take the good bite of the infraspinatus and tenos minor?
I'm not sure I understand the question.
Sorry, is it your routine technique to take bites from the infraspinatus, especially when it's retracted? When you use an antegrade device, you cannot go so deep to take a bite. So will you change your scope to the lateral portal and take some retrograde device from the posterior portal to take a deep bites on the infraspinatus?
We could do that, yeah. I've done that before. I think that one of the things we've done here that you can see is we've done a lot of work to make sure that we have, make sure that we can get full thickness bites. So that's part of the reason I've done all this work on both sides, so that I can get this to come all the way around the tendon. So I do think that's important to make sure because I think that that either way can work. You also could, again, from here, I could create an accessory posterior portal, and we could we could, as you mentioned, we have like a penetrator here we could use for that. And sometimes we do that. It's a little bit quicker because there's one fewer step, but I don't think that it's really all that much easier.
Peter, Ashish here.
I think it has a tendency to over-tension. One of the things that I really like about using the espresso device is it gives you a lot of control over exactly where your bites are, so that it keeps you, I think, from over-tensioning the repair, because the tension of the repair is going to be a critical aspect of its healing in this particular tear type.
Hi, Peter. Ashish here.
Yeah.
I'm resonating you. I completely agree with your plan. You're doing well. It's been projecting very nicely here. I was just wondering whether you could have used that biceps as a biceps SCR as an augment.
Yeah, you could do that. I have not done that in my practice. There's very little literature about it. So it's a little bit unclear. Do you have the other grabber? Perfect. We're going to tie some knots now. So it's a little bit unclear how well it works. There's the biomechanical evidence about the quality of that tissue is that it is not good. So that's been my main concern. I will say that, the one thing that is a little bit different about what we're doing right now and what I would routinely do is normally when I do this, I would probably add a patch. And I use an acellular dermal allograft. And I'm not sure that it matters exactly what patch you use, but that's the one that has the most evidence.
And you'd use that patch like an SCR patch, or would you use that to augment? Or?
Ideally, I'd like to get some of the native tendon down to the bone, but I think you could do either.
Okay.
So it looks like this is actually coming down, so that's somewhat satisfying. We had some concerns when we first got in. I was like, oh man, this is a really retracted tear. You sandbagged it, Ashish. You told me this was going to be an easy one. And we're doing our best to make it look easy, but it's a big tear, very retracted.
You're doing a great job.
Hey, Peter, it's George Athwal. How are you doing?
I'm good. How are you, George?
Yeah, everything looks beautiful here.
It's good to hear your voice. Do you have a cutter?
I was going to ask you, it certainly seems like the anterior leaflet has more tendon attached to it, and the kind of the posterior infraspinatus seems like it's almost at the muscle. I was curious as to why your thoughts are that the infraspinatus tendon is so minimal.
George, I'm having some trouble hearing you. You mentioned I heard that the tear is almost at the muscle. I agree that's very retracted. Can you repeat the rest of the question?
Absolutely. Why do you think the infraspinatus tendon is quick to go away versus the supraspinatus, which seems to be has a preserved tendon. Why do you think they're different?
Oh, that's a great question that I do not know the answer to. I personally think that part of it, and this is my opinion, I don't have any evidence to base it on. So part of the issue, I think, with the infraspinatus is if you look at the infraspinatus tendon, it wraps around the tuberosity. And it wraps around the tuberosity almost like like the tuberosity is a cam, almost like the biceps tuberosity, for the distal biceps tendon. So I think that there's more tendon loss when the infraspinatus tears than we appreciate. The second thing that I think is that I think tears like this typically start at the supra-infra junction, or maybe even a little bit within the supra. And typically what happens is that by the time the tear involves the infraspinatus, it's usually a quite chronic tear. So I think that's a big contributor as well. What do you think, George? Do you have other opinions? Maybe you could teach me something.
As you know, I'm not really a cuff surgeon. I'm an arthroplasty surgeon, so I was hoping you can enlighten me. I was wondering if anybody else in the audience understands that. I've often wondered that, even when looking at the fat infiltration, that typically the supraspinatus undergoes atrophy while the infraspinatus undergoes fatty infiltration. It's just a bizarre phenomenon.
Yeah.
It looks awesome. You're doing great.
Well, it's great to hear that. We're doing our best here.
Do you routinely start taking your knots from posterior to anterior, or do you have a preference and you modify that based on the type of tear?
So it is my practice to pass from anterior to posterior and then to tie from posterior to anterior. The main reason I do that is that if you do it that way, there's never any suture tangling. And I don't need to worry about, so you noticed earlier, like I don't put any clamps on the sutures. It just makes my life a little bit easier. It makes the suture management a little bit easier. I think you could consider altering that, and I have at times altered it. If you're worried, I'll take the camera here for a moment, please. Thanks. If you're worried about getting it to come over. So in this situation, you could consider, for instance, this part is more retracted than the front part. You could consider tying from the front to try and zipper it down. I think that we're going to be able to get it from here, so I was just going to continue tying from the back to avoid suture tangling. But I think that's the main reason you may consider it. In the subscapularis, a lot of people will say that. They'll say with a really retracted subscapularis, that you should tie from the bottom up, because the subscapularis, again, tends to retract inferior in addition to retracting medial. And so at first I was doing that, and it makes your life very, very hard. So I will say that instead what I have been doing in the subscapularis is tying from the top down, just because it's so much easier, and I found that to be fine. The subscapularis still comes over as long as you do the releases. And you see the same is true here. This is the tendon's coming over. I was saying earlier, it doesn't want to come over. It's been retracted medially for some time, but it is coming. And then again, this is just stage one of our repair. We're going to do a secondary stage with tension bands over the top of this to try and get the most amount of suture crossing our repair and to try and get the best biomechanical repair that we can in this medialized and retracted tear.
And Peter, another question.
Yeah.
I'm sure that you have medialized the repair.
Yeah.
So how far you can go for this medialization?
Typically, I will go no more than 3 millimeters. There's not a lot of biomechanical evidence about that. Certainly the concern is about loss of abduction. And I don't know, the 3 millimeter number is one that was taught to me. I don't have any evidence to support it.
Hey, Peter, first, this is fantastic work. Congratulations, this is great, this looks great. For the medialization, I think there's a study done at the Mayo Clinic that showed up to 1 centimeter you can medialize with acceptable function. Second, as you're working, this is not a question, this is more a comment that this is a case that if me and Tiru Mohata, we stand on, this is a case that we're gonna say you augment with either SCR or you're gonna do lower trapeze transfer. So for me, this is one of those cases that probably I would definitely augment with lower trapezius in my own practice. Not for this case, of course, but what do you think when you have it that medialized with these kind of tissues? Would you consider any form of augmentation, Peter?
Yeah, I would, as I mentioned earlier, I completely agree with you. We are signed up to do a rotated cuff repair here, and I'm going to make that look as good as I can. But in my own practice, typically this is given the severity of the atrophy within this infraspinatus and the severity of retraction, I do think it would be very reasonable to do either an SCR in this situation or to do a lower trapezius transfer. I think if you do either of those things, and I would be curious to hear your thoughts on this, that it's very reasonable to try and do this first, though, to try and get as much of the native cuff as you can to heal, and then to add either your SCR or your lower trapezius as an augmentation to that. Because obviously the native cuff is always going to be better than any salvage procedure.
My question to Basam. So when you deal with the same kind of case, I know you're 100% you do a lower trapezius transfer because the infraspinatus is very weak here. So would you do the same technique of repair and augment with your lower trapezius transfer, or what is your way of taking this case?
So would you do a partial repair with lower trapezius, or would you do just the lower trapezius?
Excellent question. We are trying to collect the data to show it doesn't make any difference. What I mean is, this is fantastic, and there's a very good chance, like when Ashish will show us the follow-up, it may show some repair, but for me, with this one, I think we have one tomorrow. If it's like this, I just do the lower trap, I don't do anything. Sometimes the medial, so there are 4 anchors, one anterior, and there's one medial to lateral. That medial anchor, I just pass it through whatever you have tissues to work only as like additional soft tissue
This is a
coverage
cut one.
and
Do you
put
have
it
a fresh
on top
one?
of the
Yeah.
Achilles tendon. But I will not do these steps. I'll go straight for it because when I try to compare the data, and we're going to publish about it, it did not make any difference. So adding more anchors just to repair did not make any difference in terms of the outcome. So I do not try to go out of my the way just to repair it because it doesn't make any difference.
Thank you. Bassem, while you're there, I have a question for you.
I think that will give a more information, because when we talk about lower trapezius with infraspinatus repair, we don't know the external rotation, you get it because of the infraspinatus or your lower trapezius transfer. And if you could show that isolated lower trapezius transfer alone can bring that external rotation, that will be great.
Yes.
So in this patient that has external rotation,
holding this.
are you planning on doing any study to show that lower trapezius is going to be better than partial repair? Because it seems like right now there's so many people just doing a partial repair for a patient like this that have quite good outcomes.
Excellent question, George. So this is why, even though I know if Tero is here, he's not here, right? Mehata. So even though I'm not a big fan of the SCR, but this is one of those cases when someone has ER, I think anything's gonna work. So let's say someone do bicep SCR. Early on, I get excited. No, lower trap work more. No.
Thanks.
If you do biceps SCR, it may work. If you do SCR, it may work. If you do partial repair, it's gonna work. If you want to add your trapeze, it's gonna work. With this specific scenario, I cannot prove that doing a lower trap is better than anything else. No, I think anything can work. When you have the ER lag, this is when I can debate more that lower trap will be a better option.
Yeah, I totally agree.
Fair enough?
Yeah, I agree. I think with a true external rotation lag sign, the lower trapezius is a very good operation.
I could add one comment. This one. We are not comparing between lower trapezius with and without lag sign. With lag sign, the improvement of external rotation, active external rotation, is less with non-lag sign. By doing lower trapezius for both population, I mean, because the patient had 20. When you add augmented with lag sign with the lower trapezius, your improvement is much better than lag sign. Catch it? Exactly. This is what I'm doing now. The improving on strength and external rotation. Yeah, this is what I learned from Bassem. If I have more than 3 or 4 fat infiltration, I'm going to add low trap with or without the partial repair of infraspinatus. And my feeling in our way of preparing the paper now, we improve functional results in external rotation in terms of external rotation and function and strength regarding the lag sign in the same population.
Yeah, so Hashim, it's all about biomechanics, okay? So people ask me often, like, does lower trapezius improve? What does lower trapezius do? Everything external rotation. Will it improve flexion? No, this is external rotation. It improves the force couple. The force couple will improve the flexion. If you have teres minor, even though it's weak, some patient with teres minor, they have good strength. Some patients with teres minor, they don't. You add these tissues, it could be lower trap, it could be SCR, it could be biceps. The mechanics improve, the teres minor work better, now you have better external rotation. If you do have a true lag, this is where you need more muscle, you need more power to get the external rotation. Fair enough? No, George, I love it. We disagree. Disagree, jump in.
Peter, we have a bit of a discussion going on here. We can see your surgery, and we're enjoying your surgery, but we just have a little bit of a debate going on here while we'll be seeing you do those steps.
I think that the debate about indication is probably the most important part of this case. So I love the debate. I mean, I think that that's the main question is this the right operation for this patient? Sure, is it technically feasible? Hopefully I will show you yes. But the question I think is it also correct, you know? And that's certainly what we're, what we need to do more research to study here in this situation.
Awesome. Basam, come in. I'll throw another
okay.
cat amongst the
Probably
pigeon.
good.
So, loving this, we know everything is working. Now, where does for the similar situation, weak external rotation, whether there's a lag or not, where does lat dorsi come in vis-a-vis lower trap?
You know, latissimus has a very good long track record. I cannot deny it whatsoever. But in this specific case, if you have an ER without complete ER lag, I do think latissimus work. It will, sorry, we can add it to this list. Biceps, partial repair, patch, SCR, all of this stuff. However, I always tell, and this is one time I had a debate with Professor Christian Gerber. I told him, can you do a latissimus transfer in brachial plexus injury? In adult brachial plexus? The answer is no, you cannot. Why? Because the inferior port of the latissimus, when you don't have deltoid, it will not improve. Can you do lower trap? Yes, you can. So biomechanically, if you want to compare the both, the lower trap is definitely much better. The big advantage of latissimus, you don't need augmentation. You can transfer it without this augmentation. With lower trapeze, you need augmentation.
Clamp.
And
yeah,
if I add my 2 pens, in the males, the lat dorsi does better. Female lat dorsi, especially in this population, tends to be very weak and poor quality.
So maybe we could.
But again, my friend, this specific case, in my opinion, you can put a list. I cannot say this is better, honestly.
Yeah, agreed.
Biceps SCR, patch.
Yeah.
I get excited because like I like lower trap, but no. Yeah. If you tell me, if Mihata here tell me I will do SCR, they have great outcome, I tell him yes. Partial repair, this patient may do very well, but you cannot guarantee it. Yeah. There is a chance you'll do well, maybe not. We don't know. That's it.
Super.
Peter, one question to you.
Yeah.
Peter, this is Hashim. I realized this in this type of bad quality of tissue, the round sutures, it's going to be cut through the tissue. What's your opinion about the flat suture at tapes and to use knotless systems in these cases with an I don't want to speak about technically a commercial promotion, but I mean using tapes without knots in this type of bad tissue quality.
Yeah, I'm not aware of any clinical evidence that tapes are better than sutures. You know, this particular suture that I'm using is a self-tensioning suture, and I find that to be really helpful here. You know, in this kind of situation where I really do care about getting the tension right. But I don't think it's wrong to use tapes. Yeah, thank you. So I think it's fine either way. I do think that where you pass your sutures matters, and that's the reason why, as I discussed earlier, you know, I really do try in this situation to get to get simples and then to get these more medial bites. So I'm trying to get the best fixation possible within the bone.
Peter, could you give us a few?
Within the tendon.
Sorry.
Yeah.
Could you give us, so just to recap, you did a medialized single row repair. You cut the sutures, and then you've taken a separate set of sutures where you've taken into that lateral row. And that's basically to take the tension off your single row repair. Is that correct?
Has multiple benefits. So one is that I've got two different, you know, our issue, it's the tendon. So I've got two separate areas of bites through the tendon. I've the row, you know, that I put in with my medial row, and then I've got this, which is a separate medial row, which I can show you in just a moment once we've got these sutures. In addition, I've got basically two decoupled repairs here. thing to actually cut. What am I doing wrong here? Hold on 1 second. Okay, it's got it. So both repairs have to fail separately. So this is the advantage, I think, of doing this over a traditional double row, is that here I've got to get my tension bands to fail. So you see I've got these sutures that have this kind of more lateral bite and these sutures that have this more medial bite. So I've got two separate rows of bite within the tendon. That's the basic concept behind this repair.
Peter, can we use independent ripstop suture tapes which will not put any stress on your medial row?
Yeah, that's the other thing you can do. Is so my hope is that this takes some of the stress off the medial row. Yeah, I think that's another option here. The other option would be to put a Mason Allen's through the tendon. Not yet. You have to take that off. Thank you. That's okay. All right. Perfect. Thanks so much. Yeah, so let's get this guy now a little more this way. Perfect. Thank you so much. All right. So now we're going to put the posterior of the anterior one in first. I usually put the anterior one in first.
How inferior do you want to go with these anchors? Do you base that on the patient's bone quality?
なんとかはいけてそうなのか。でもそれをこれと固定できるんかいな。これと
I think we're hearing the audio of the next OT. Yeah.
前腕に当てるってことね。
Now we got to find the hole. That's always the biggest issue here. Right there is the hole.
Hey, Peter, it's George again. I was just curious if you could just tell us what anchors you're using here, what your medial row were, and what company they are, and what lateral row they are.
These are helixes. You can see.
Oh, I think we've lost the audio.
Doesn't sound like. With the audio.
Peter, we can hear you now.
But you can hear me now?
Yeah.
Yeah.
Okay, great. So I'm using helixes. They're made by, oh, thank you so much. They have this differential thread that you can see on the top. You know, this kind of a narrower thread, vertical surface improves your bite where bone is best. Utah. That's Utah. That's a Utah thing. My goodness, we need a suture cutter that actually works here.
So for the audience, what we've got here is medial row anchors, and with the medial row anchor, he's taking simple bites so that he gets low tension repair. But he wants to take the tension off those medial sutures, so he's taking separate sutures. He's taking separate sutures and putting it onto a lateral row. But this is not truly a suture bridge, so it's not the sutures from that medial row anchor which are then getting onto the lateral. It's a separate suture that's being put in.
Our apologies. We have a broken suture cutter here. We're just going to overcome that, and then we're going to cut our final sutures, and we'll show you the repair here. Thanks so much. So the other thing is these are, again, the Dynacord is a self-tensioning suture, which I think is nice. I think that you can get a good, repair with a variety of anchors, and I'm not sure that factor is the most important, but I do think that it's helpful to know your system and to find something that works for you. And I found these to be efficient anchors with a low rate of pullout and a good repair here.
And
My
Peter,
goodness.
Peter, the question was, your preferred choice of using anchor is that's a peak one, or use a bio or a metal in the shoulder?
Thanks so much. Say that again?
Your preferred anchor in the cuff repair, does it peak or do you use metal and biodegradable?
My preferred anchor is PEEK, and I would prefer not to use a biocomposite because I do worry about cyst formation. I have seen that. So here's our final repair. I think you can use metal anchors. The challenge I have is that they definitely make post-operative imaging with MRI more challenging. So that's the main reason why I would prefer to use a PEEK anchor. I think it gives you the best of all worlds. So again, you can see here, this is our medialized repair here. These sutures come medial to it, so hopefully those are decoupled. We've done our best here to get this down. Again, as you saw from the beginning, it's a very retracted tear, but I think we've got pretty good compression of all of that tendon against this area of footprint. We've medialized the repair to try and take tension off the repair, and then again, we have this kind of double row construct, but with deconstructed double rows. So that's the completed repair. How do we do? So
it looks great.
We're right at 45 minutes.
Yeah, it looks great. And last question, your rehab for this kind of a tear. So what sort of rehab would you use for this kind of a tear with this type of repair?
Yeah, so typically my rehab for these patients is that we will start passive range of motion at the 2-week mark. So for 2 weeks, they're in a sling, and for those 2 weeks, I will just do hand, wrist, and elbow range of motion. At the 2-week mark, we'll start passive forward elevation and passive external rotation to prevent stiffness. I'll say with that protocol, I've only had probably 2 patients out of the last 800 cuff repairs that I did where I've ever had to go back for stiffness. So I think it's really helpful to start a little bit of early passive motion. I usually have them do that on their own at home with no therapist. We'll start formal physical therapy at 6 weeks with the goal of restoring full active forward elevation and full active external rotation by the 3-month mark. I'll delay strengthening until 3 months. At 3 months, we'll start strengthening. I usually tell patients it's going to take another 9 months from there. Can you put the shaver back on? Another 9 months from there to restore their strength. There's evidence from the Swiss now that you get more strength between 6 months and 12 months than you do between 0 months and 6 months. The other thing I tell patients is, based on Ionati's data on the time it takes for the tendon to heal, that I want them to avoid all contact and collision activities for the first 6 months. So in my area, that's things like skiing and snowboarding. I think the other things you may consider are things like, like contact collision sports. So I usually tell patients they're not allowed to fall down for that same period of time. And if they do fall in that early period of time, I'm fairly aggressive about imaging it because I do think that there's a substantial re-tear rate, and in general, bad news doesn't get better with age.
Thank you, Peter. I think it's a wonderful demonstration. We can hear the great round of applause from the delegates. Thank you for your excellent show.
Thank you, Peter.
Thanks, guys. Appreciate it. Okay.
Okay, so we're going to move on now to shoulder instability 2, and I'm going to request the moderators, Dr. Raju Ishwaran and Dr. Nandan Adla, to take the chair's table.
क्यों हिला डाला ना क्यों हिला डाला ना
So we'll have the first speaker speak on posterior shoulder instability, and as an exception, since Dr. George. Yeah. Good morning. We'll have Dr. George speak on posterior shoulder instability, and as an exception, since he has to leave for the live surgery, we'll take a quick 1 or 2 questions after his talk. All the other questions at the end of the session.
Thank you, Mr. Moderator. I'd like to thank Ashish for this wonderful invitation to come back to India. Both of my parents were born in India, and so it's always wonderful to come back here. I think I'll stand a little further away to avoid the feedback. Is that sound coming across okay? Should I move closer? Sorry, I guess I should move closer. So I'm going to discuss the Kovalchuk procedure and some of the research that we've been doing on it. Over the next 10 minutes, I'm going to focus in on 4 particular areas of this presentation. I'm just going to briefly go through posterior instability. I'm going to describe to you the Kovalchuk procedure. I'll also present some of the data that we've done in our lab looking at this particular procedure. And finally, I'm going to end off with some clinical outcomes. So we all know that the management of posterior shoulder instability is multifactorial. There's many reasons that people get posterior shoulder instability, and certainly the management options are also controversial, which we'll learn about this afternoon. Now, typically in patients that have posterior shoulder instability with associated bone loss, it certainly seems that the bone block procedure is probably the gold standard when you have critical posterior bone loss. The problem is, if you look in the literature, the long-term outcomes show a high recurrence rate. And this is probably a mixed bag because some of these patients are probably early osteoarthritics that have posterior subluxation. So here I present to you the Kovalchuk procedure. It was first described in 1993, and what it is, it's an acromial bone block with associated vascularized deltoid flap. This is the original paper published by Kovalchuk in 1993. So here's a posterior view of the shoulder, and here we have our deltoid muscle. And what we're doing with this operation is we're harvesting a bicortical acromial graft with its associated deltoid. And then what we're doing is once we've harvested that graft, we're going to transfer that to the area of the bone defect along the posterior aspect of the glenoid and have this deltoid flap potentially have a double blocking effect. So the first effect of this procedure is the bone block. The second effect is this hypothesized deltoid muscular hammock. And so I'm going to share with you some of the cases that I've done. This is the first case. Case number 1 is a 25-year-old male. He's had 3 prior failed arthroscopic stabilizations, and now he has recurrent instability. You can see here he actually came in dislocated. He has a substantial reverse Hill-Sachs defect with posterior glenoid bone loss. And here's a CT scan on the right. So I indicated him for a Kovalchuk procedure and an allograft humeral head reconstruction. I used the arthroscope in this case. I was planning on doing this operation completely open. This is an open operation in this patient, but I just used the arthroscope to assess my reduction of my graft posteriorly in this case, and we did a humeral head allograft anteriorly. This is him postoperatively at day 1. You can see here is where I harvested the acromial graft. This is him at 1 year follow-up. You can see the graft posteriorly and the humeral head anteriorly. And this is him at 4 years follow-up. We seem to have some incorporation and healing of the humeral head allograft. This is a second case. This is a 27-year-old male, failed posterior soft tissue repair for posterior instability. Once again, you can see on the 3D image, he has a reverse Hill-Sachs defect, and he also has some, probably about 10 or 15% posterior glenoid bone loss. So I had indicated him for an arthroscopic Kovalchuk procedure and a reverse remplissage. You can see here on the image on the left, I'm harvesting the graft, and there is the graft once detached from the spine. So we'll go ahead and play the video. The camera is coming in through the anterior superior portal, so I'm looking down anteriorly. Here you can see the reverse Hill-Sachs defect. The switching stick is coming into the standard posterior portal. And what I'm first going to do is I'm going to go ahead and pass my sutures for my reverse remplissage. I'm going to debride the reverse remplissage lesion. And once I've debrided it, I'm going to bring a spinal needle in from anterior, lateral to the conjoint tendon, and template the location of an anchor. I typically use metal anchors in cases like this because I find it easier to screw through the tendon of the subscapularis. I'm going to place a metal anchor inferiorly in the reverse Hill-Sachs and one slightly higher. And we did some research looking at the location of the best anchor positioning in patients with Hill-Sachs defects. And what we find, placing it more deep in the valley is probably a little bit better because what it does do, it gives you a greater surface area for healing of your tendon rather than placing it right at the articular margin. Sometimes when you place it right at the articular margin, the tendon doesn't really have a place to heal because the cartilage prevents it from healing down to the bone. And so now what I'm doing, I'm just bringing in any sort of penetrating device from anterior, and I'm going to do a bunch of horizontal mattress sutures, passing through the tendon, picking up a suture, and bringing it out anteriorly percutaneously. So I'll go ahead and pass all of my sutures for my reverse remplissage first, and then we'll go ahead and do the Kovalchuk procedure after. So this is our inferior anchor And now we're going to go ahead and template the location. You can see there's the conjoint tendon, the CA ligament. I'm coming in from anterior, just lateral to the conjoint tendon. I'm going to screw through the subscap tendon. Arguably for this top anchor, I could probably go over the top. And so most of these are all done percutaneously and viewing from that anterior superior portal. So now I'm going to go ahead, and it's that same anterior superior portal. I'm now viewing along the posterior rim of the glenoid, and I'm going to go ahead and debride the posterior glenoid, and now I'm bringing in my Kovalchuk. So here is the bicortical acromial graft with the attached deltoid. I'm just using in this particular case, I'm using the Mitech Latarjet Experience instrumentation. I find it quite useful to use. Now the key when doing posterior bone blocks, which is different than anterior, especially when using screws, is that the guide pins, when they come in from posterior, are directed anteriorly, and they arguably, if they go too far, they're aiming towards the plexus and the neurovascular structures. So you want to be very careful with your posterior to anterior guide pins, something we really don't have to worry about when we're bringing the graft in from anterior. So what I will do, once I've positioned the graft, I will then go anterior and then ensure that I'm not going to have my drills go into the anterior neurovascular structures. And then finally here, we'll go ahead and tie our rim plissage after we're done. And here's our patient. There is our bone graft for our Kovalchuk, and here are our metallic anchors for our reverse rim plissage. So the question that we had is, does this hammock effect really exist? And we wanted to test this biomechanically and compare it to distal tibial allograft. And our goal is there to see the Kovalchuk and compare it biomechanically to the DTA. And these are our methods. We used our shoulder simulator. We tested 10 cadaveric specimens. We had a pretty intensive testing protocol looking at multiple different loading conditions. And this is essentially what we assessed. We assessed the intact glenoid, the 25% glenoid bone defect, the distal tibial allograft, and we compared that to the Kovalchuk. And with respect to the Kovalchuk, we tested it with the deltoid under no load, so 0 newtons, 5 newtons, 10 newtons, 50 newtons, and then just to study the bone block effect of the Kovalchuk, we actually detached the deltoid, just to get an assessment of how the bone graft, because the bone graft with the Kovalchuk is smaller than the distal tibial allograft, which typically is about 10 millimeters. And our outcomes are posterior humeral head translation and dislocation, and these are our results. So on the x-axis here represents glenohumeral abduction at 0 and 60 degrees, and this is posterior translation. This first white bar represents the intact specimen, so no bone defect. This is the 25% bone defect. So you can see there's a substantial increase in posterior translation and instability. Here's the distal tibial allograft, restores it, but not to normal. And here are our two Kovalchuks at Kovalchuk just with the graft and Kovalchuk with the graft unloaded. So you can see that the bone block effect, because it's smaller, is not as good as the distal tibial allograft. However, once we start to add tone to the deltoid muscle, which is a vascularized flap, at 5 newtons, 10 newtons, and 50 newtons, you can see that there's a substantial decrease in posterior humeral head translation and posterior instability. So we felt that the deltoid hammock effect, or this muscular effect, actually truly does exist. And certainly, if you load the acromion or load the deltoid graft, it is substantially better than the distal tibial allograft. So with respect to the biomechanics, the hammock exists, and it is biomechanically superior than the distal tibial allograft. Now, what about the clinical literature on the Kovalchuk procedure? This is a paper published by the French Arthroscopy Society. Really, it's a technical note. Now, if you look at what's available in the literature, there's not a lot available in the clinical literature on this particular technique. Kovalchuk published his results in 2006. He had 11 cases, 2 failures. Francois Sorbeau published his in 2004. He had 9 cases and compared them to 9 cases of bone block, and he felt that the Kovalchuk was superior to the bone block with respect to patient outcomes and stability. And if you look at my personal series, I've done 8 of these cases. So far, no failures. So in summary, the hammock effect of the Kovalchuk procedure biomechanically certainly seems to be present. The operation is clinically safe and it's effective, and it certainly is a really good option for patients that have substantial glenoid bone loss in the primary scenario or the failed revision surgery. Thank you. Great, so I'll take some questions now if we have any. My good friend Bassem. Can we turn his mic off? Dinshaw,
They
you're
don't want me
first.
to, they don't want me to talk. Okay. So George, a quick question. Thank you for a very elegant technique, really very nice. In fact, two questions. Number one, you know the axillary nerve, when the branching of the axillary nerve posteriorly, it is more distal of the posterior deltoid, come closer in the middle deltoid. When you're taking the posterolateral and you're trying to dissect to move it down, number one, how close is going to be the nerve and kinking of the nerve? That's number one. Number two, as you said, some of these patients develop arthritis. Some of these patients may require reverse in the future. Now we shot the posterolateral acromion. What this will do on acromial potential stress fracture in the future?
That's a great question. So first of all, this surgery is not indicated. I don't indicate this for patients with pre-existing osteoarthritis or like the B0 or the patient with static posterior subluxation. It's indicated for true posterior instability. So not patients that have increased retroversion that have a higher likelihood of going to reverse. What's interesting, when we looked at my patients with the acromial grafts, over time the acromion hypertrophies, I'm not sure if I can go back, you can see this picture right here. I'll show you that, well, is it not going up? Sorry. We probably can't, right, there it is, thank you. So right here, if you look down where the acromial graft was harvested and compare it to the initial picture, you can see that the bone actually starts to incorporate and gets thicker and more sclerotic there. So it certainly probably is an area for a stress riser. And with respect to the axillary nerve, I usually only dissect about 2 to 3 centimeters because that's all you need to get it. And ideally, you don't want to completely separate the flap because then that destabilizes the flap. I still want the flap attached side by side to the deltoid. Dinshaw.
George, my question is, where exactly do you take that bone from? Because where you take it from is going to decide your deltoid tension and the hammock.
Yes.
And it's also going to decide, whether you're going to land up with a secondary fracture because that goes near the spinoglenoid notch. And not all, spines and acromions are the same. So do you change it based on patient or do you study that on the CT scan? What are your decision-taking points there?
Yeah, excellent question. So I do study it because all of these patients get a 3D CT scan, and you're absolutely right. The scapula and the acromial spine morphology is so variable between patients. And so what I try to do is I take it just at the level of the glenoid. I try to go as lateral as possible to decrease the lever arm, but many times as you go lateral, it gets very thin. So you kind of have to gamble between that or try to identify an area that's good. The one thing that we do to decrease the risk of acromial insufficiency fracture is we take a bicortical graft. So it's the lateral cortex and the superficial cortex, but we try to keep the deep cortex intact. So it's a bicortical. It does make for a smaller graft, but then certainly we're relying on that hammock effect to exist.
Thank you.
Thank you.
Can I just ask one last question, George? Here.
Yes, sorry, Mr. Moderator.
If you are doing it an open procedure, how do you make sure that the alignment of the graft and the articular surface is right or wrong?
So as I mentioned, so the open one we used, the first one I did was open, but because I did the Hill-Sachs defect, I managed it with a humeral head. But typically all of these operations are done arthroscopic. So if I'm doing a humeral head allograft, for me a humeral head allograft is an open operation, it's not an arthroscopic operation. But if I'm doing a reverse remplissage, those patients have it all done arthroscopically other than the harvest. So I use a scope to assess the reduction.
So to conclude, we are using it only for a bony posterior instability and not for a retroverted glenoid.
Correct. That's absolutely certain.
Thank
So there may be an indication in the future to study that, but right now my patients are very clean. They're patients with true posterior instability with failed primary soft tissue repairs.
Okay. George, thank you very much.
One last question.
I think we
George,
are running short of time. A quick one.
Were you able to differentiate between your reverse remplissage, the power of your reverse remplissage versus the bone block? Because you've been doing in all those 8 cases, right? So how much of the centralization of the head was from reverse remplissage and how much was from the...
I mean, I've done less than 10 cases, so I have to be honest with you that I don't think I can differentiate between the remplissage versus the bone block. The remplissage is not something I always do. I typically, most patients I do, the Kovalchuk do not get the reverse remplissage.
Okay, thank you very much.
Thank
George.
you.
Now I'll ask Dr. Ishwaran to talk about non-coracoid options. So he's going to tell us, agar ye chalega ki nahi.
Thank you very much. Thanks, Dr. Ashish, for this invitation. Subcritical bone loss and shoulder instability is quite literally a radioactive topic. And regardless of the subcriticality of bone loss, there are critical levels of disagreement on three key areas: how to measure bone loss, what exactly is subcritical, and how best to treat a subcritical bone loss. Now, when it comes to measurement techniques, this recent review identified 4 basic measurement techniques. The linear measurement technique, like the ones in the original paper by Shaha, and the Griffith method. Then you have the area methods, the more complicated trigonometric method, the Pico method, or the Barchelon method, in which the defect area is divided by the total area of the glenoid, and that is expressed as a percentage. And then there's this very innovative Giles method, which relies on the relationship between the glenoid length and the glenoid width based on a mathematical proven formula. Now, this recent paper found that the Barchelon method was the most reliable on 2D images, and the Shaha method, which is a linear method, MRI-based method, was the least reliable. And we generally overlap a circle based on the intact glenoid onto the injured glenoid, but studies show that they may not be exact superimpositions of each other. There are subtle differences between the intact glenoid circle on the affected glenoid and the circle which we draw on the injured glenoid. And why is this difference so important? Why do we need to be so pedantic? Now, sometimes when we think in terms of percentages, we forget that we are dealing with actual numbers. And this editorial commentary very nicely pointed out that the difference between a glenoid bone loss of 13.5%, that is subcritical, and 20%, which is critical, on Caucasian glenoids, which measure 29 mm in AP diameter. So Indian glenoids will actually be slightly lesser. It's only 2 millimeters. It's not even 2, it's 1.86 millimeters. So you are relying on a measurement technique which tells you the value with 1.86 millimeter or 2 millimeters of accuracy. That can make the difference between what is 13.5% and what is 20%. And then if you are a person who likes to do the measurement yourself, you would be well advised to read the very nice book written by Benoit Mandelbrot. He asked a very simple question: how long is the coast of Britain? And the answer, it seems, depends upon the length of your measuring instrument. In this particular instance, it depends upon the length of the digital zoom that you use to draw the circle. The bigger the zoom, the more accurate the circle. That is the genesis of the fractal theory, if you remember your high school mathematics. So does a simple method exist? Thankfully it does for dummies, and the flat anterior glenoid is a reliable measure that you have a certain amount of subcritical bone loss. And quite interestingly, the same flat anterior glenoid, when measured by 3 different techniques, gave 3 different measurements. So whenever you are relying on a number supplied to you by a radiologist, you must ask this question: what method the radiologist used, or in case you are doing it yourself, what method have you used to calculate this glenoid bone loss? And how accurate do you think this calculation really is? Because if you are treating your patient based on a number supplied to you by a radiologist, then I guess best of luck. Now, why 13.5%? This all emanates from this paper by Shaha et al. And they used an MRI-based determination, which is now shown to be the least accurate. And their patients are high-demand military population, which may not be the typical patient that you and I treat. And this paper looked at the error. Now, if we look at these figures closely with the Shaha method, it overestimates the glenoid bone loss by 4% by both experienced as well as inexperienced observers. And if you remember that 1.8 millimeter threshold between 13.5 and 20, 4% is a lot. And a lot of concerns have been raised on whether 13.5 is actually the right number for critical bone loss. And I guess if one looks at the bigger picture, the patient parameters into account, then I think this is just another number. This is something, as Ram alluded to in his very first talk, some people define it as 15%, some people define it as 13.5%. But as our Japanese authors have shown, the glenoid has a power of remodeling. So even if you think that there is a small bony bankard, don't rush into a bony augmentation procedure. With time, with Wolff's law, it will remodel into something quite appropriate for the patient. What does the literature say? This is a Delphi-based consensus. A lot of people, a lot of big names in this particular panel. And not unsurprisingly, they can't agree on what exactly a critical or a subcritical bone loss is, and neither can they agree on what procedure is best done in such instances. What they did seem to agree upon is that regardless of whatever graft you use, all of them will give you reasonable answers. And as far as grafts are concerned, they have thankfully been quantified in biomechanical studies. The typical formula is that 40% and above, you need a Latarjet. The best suited graft for subcritical bone loss is the scapular spine. Distal clavicle, which I have no experience with, can restore up to 30%. And this was a very interesting editorial commentary on a paper published by our own Dr. Sanjay Desai. And this commented on whether we should pay more attention to do a better and a more robust standard Bankart repair in our patients with subcritical bone loss, so that we end up with a well-healed capsulolabral repair and a good result for our patients. A lot of us are fans of Remplissage procedure, and none other than Dr. Alexander Ladderman asked this question. We all think that we are doing an infraspinatus stenodesis, whereas we all perhaps might be succeeding in just doing a capsulomyodesis. And now imagine this is a young patient, and if he develops a rotator cuff tear later in his life, this is very close to the Cho type 2 re-tear that is typically seen with a double row cuff repair, and this will present a very vexing problem to treat. There have been descriptions of safe zone techniques on how to do a good remplissage, and this is the safe zone postulated by these authors based on cadaveric studies. But if you imagine, most of us do the shoulder arthroscopy in the lateral decubitus position, so you have to account for the fact that the safe zone for a lateral position is far more lateral than what we think it is. So can augmented Bankart be the right option for subcritical bone loss? It is a new procedure. We heard the master surgeon, the originator surgeon speak on it. The jury is out on it yet. Rerouting anatomy, I think long-term studies will tell us the answer. We would all do well to remember words of Matheson. Surgeon is the method. So as of now, I am a little skeptical in adopting these non-anatomical procedures. Time will tell, long-term published evidence will tell whether we are headed in the right direction. Thank you very much indeed for your kind attention.
Thank you very much, Dr. Ishwaran. We'll move on to the next talk, which is on comprehensive management of recurrent posterior shoulder instability by Dr. Hatcham.
Thank you.
कोई बात नहीं चाचू, सब ठीक ठाक है. All is well, all is well. कोई बात नहीं चाचू, सब ठीक ठाक है. All is well, all is well.
Thank you again, Ashish, for the invitation. So this is my disclosure. Posterior shoulder instability is uncommon, is misdiagnosed, and often is delayed, and present a wide variety of presentations. And we should thought about high clinical suspicion about it, and the most important thing, in some cases, a patient comes to us with a demonstrable and non-voluntary dislocation. But there are many glenoid factors predisposed to posterior shoulder instability, as an imbalance of muscle pattern, hyperlaxity, glenoid dysplasia, and this anomaly in the development of the scapula maybe increased a glenoid retroversion and provoke a posterior hyperplasia and hypertrophy of posterior labrum in order to compensate this retroversion. And this leads to early stages of recurrent posterior instability and eccentric osteoarthritis in young population. And sometimes this imbalance between the muscle pattern and anomaly of the scapula started very, very young patient as this childhood in early years. So this leads to a question, which happened first, the egg of the chicken. So look at this patient. He wasn't able to reach the foral elevation, but to have a good foral elevation, he repositioned the scapula in order to achieve the abduction and foral elevation. He improved only by physiotherapy. And look at this patient. We should distinguish between the voluntary and non-voluntary. And some cases, the patient comes to us in non-functional position, and another one at the right side of the slide, he wasn't able to reach without pain and without subluxation the shoulder. And some cases, as this one, in another non-functional position, but non-voluntary, but demonstrable. It's very difficult to find which voluntary and non-voluntary, looking at the patient without X-ray and CT and MRI. So all of us know the posterior shoulder instability classification by Philippe Moroder, which the patient evolved and from subtype to another one and developed alteration of the structural lesion. And we know also from studies, if you have a posterior glenoid bone loss, maybe posterior capsule repair alone and soft tissue repair increase and have a failure rate 10 times failure rate after this procedure. And if you have more than 15% of the posterior bone loss, maybe you will have 25 times more failure rate without other procedure. So if we look at the posterior bone loss, the same, we should look at a bipolar bone loss. And this is a gamma angle described also in between the bicipital groove and medial edge of the reverse heel sac. If this gamma angle less than 90, it will not be engaged, and if this gamma angle is more than 90, will be engaged. So, but if you took a look at this one, you should take a look at the another side, in the glenoid side, and we should look at every single degree and adding this degrees to this management. So, but how we can treat posterior shoulder instability? We publish our experience, our real experience after having done this technique, and we try to find which cases has demonstrable hyperlaxity defect, and we try to put our proper algorithm. So if the patient in the beginning, all the patients should stay with improving, strengthening the muscles, and these cases, the majority of the patients improve with this kind of physiotherapy. But we should detect the voluntary patient, and we do not operate it because we will fail. And then we look at as a bone loss. If we had less than 10% posterior bone loss, we could manage with soft tissue anchor only, as we did all of us, by repairing the posterior labrum, by doing knotless system, it doesn't matter. And then if we look at the gamma angle and the posterior defect, if we have more than 90% of gamma angle, it's a risk factor for failure of soft tissue. So we publish also our technique by reverse remplissage bridge technique, by one screw through the subscap, and then these tapes come from inferior, from in front of subscap, and we switches to posteriorly. It pass around the subscap, and we introduce these tapes, as you can see here, where is a reduction of the subscap. We introduce these tapes in the second anchor above the subscap that only produce one subscap penetrated. So the other scenario is when we have these conditions, dysplasia, more than 10% of posterior glenoid bone loss, or retroversion less than 20-25, and or failed repair, soft tissue repair, and in some cases with demonstrable but non-voluntary cases. In my experience, this cases is the best indication for posterior bone block. It's reliable and efficient, and we had present a good outcomes. But we know from the literature, this technique, if you put the screws, 1 out of 3 patients, you should remove the screw because provoke after osteolysis, irritation, and muscle irritation and pain in the posterior side of the scapula. Look at this patient. This patient, we did it in 2018. He improved a lot. And we removed, after 5 years, we removed the screws, and now he was able before, he was able to provoke this subluxation, but 5 years after, he couldn't do it. He's still stable, he's still happy, but we did the removing of the screw because he was worried about this posterior pain. And we published, after that, we published this result with this technique, so with the using cerclages as we did for anterior bone loss, but in another way, the same tapes come from posterior to anterior, but we introduced the bone graft from posterior before finishing the technique. As you can see here, the graft is coming from posterior, but we load the suture first, and we push the suture, and then we tension the suture, and then we reattach the capsule above the graft to keep it extra-articularly and doing anatomic restoration. And here, this is this case. 2 minutes, okay. Sorry. This case we did last month in Barcelona. We use live surgery. We use distal tibia allograft. As you can see here, the same technique. We started to use distal tibia after having done more than 15 because it's a strong bone, and believe maybe it's reproduce the shape of the graft. Look at this patient. He is a special one because he wasn't able. He wasn't able to do flexion, forward flexion without subluxation in the shoulder. We stabilize the shoulder. The compression test. He's still doing it. He only was able to stabilize the shoulder by pushing the humeral head. So at the end, we put this graph, and look at the patient now. 6 weeks after, he cannot reproduce this movement, this strange movement to reaching the arm, but it's still a little bit stiff after 6 weeks finishing. This is from the last week. So now I'm going to show you some cases. Look at this case. This is 2 years after the bone graft. Good healing, good shape of the glenoid because of low wall flow, and he wasn't able to reproduce the dislocating. And look at this lady, 4 months after the surgery, fully integrated, and she is now happy without any pain, and we didn't lost this control. This is a special one, very young. Look at the open feces, still open feces teenager. He suffered a posterior epiphysiolysis of the shoulder. He remodeling in posterior position, so he will lose the arm, but now 5 months after is perfectly. And the last scenario is when you have a rotoversion more than 20-25%. We describe this technique as a feasible. We use the same guide from the for anterior one. We introduce 2 key wire. Then we, with an osteotome comes from posterior and the direct visualization, we provoke a posterior open wedge osteotomy, and we obtain the graft from posterior scapula, is autostable, and we put 3 soft anchor through this graft and through to reattach the capsule and to provoke a stable posterior graft. This is the video. We introduce switching stick, and we exchange with to hook, and then the guide come from posterior to put 2 key wire 2.0 almost, and under direct visualization the same as we did for anterior. Then under direct visualization, as you can see here, we can see the entry point of this osteotome to inferior, to medial side, to superior side, and only we could penetrate 15 millimeters under direct visualization of this one, almost. And at the end, we reattach the capsule. Look at here. We change the osteotome from inferior to superior, and then this is the graft from the scapula spine. We introduce it inside the osteotomy, and is autostable. At the end, we fix it with 3 or as you can see, with soft anchor through this graft. So to finalize, the most important thing is to diagnose, to have a diagnosis. This what kind of patient we have. The management is if you have a good algorithm, is going to be better to understand the posterior shoulder instability, and the arthroscopic posterior open wedge glenoid osteotomy. Maybe it's makes the surgery more accurate, less challenging, and will be the future for this kind of patient. Thank you very much for your attention.
Thank you, Dr. Hetchem. It was a very comprehensive talk.
Don't underestimate the common of a power man. Power of a common man.
The power of the common man, a surgery which we must all know how to perform well. I have great pleasure in inviting Dr. Laderman.
Thank you. Okay, so I think we are late, so I will go quite quickly, directly to a video. So this is, I think, a 4 or 5 minute video, and it's almost 100% the technique of Gilles Valge that I learned. So you just do 4 to 5 centimeters skin incision at the tip of the coracoid process. You develop the deltopectoral plane, and then you put a Hohmann retractor on the coracoid process. When it's done, you put your arm in abduction, external rotation. This will nicely expose the lateral border of the conjoint tendon. You find the CA ligament and you keep as much as possible, if possible, around 1.5 centimeters. Then you put the arm back in adduction. This will expose the pec minor that you cut, and with a 90 degrees angulated saw, you create an osteotomy of the coracoid process that you complete with this chisel. When it's done, you use a first museau to grab the coracoid process, and then remove the knee of the coracoid process, and with your angulated saw, you just prepare the undersurface of the coracoid process. You have to know that Lionel Netton developed now a new museau that has under the forceps a blade that protects you, that protect the wires and the drill to go through the skin. You drill at 3.2, 2 holes at around 1 centimeters of distance between them, and then mark the other surface of the coracoid process to find it, and you just hide then the coracoid process under the pec major. When it's done at 2/3, 1/3, like I said before, you just create a split in the muscle, introduce this Hohmann retractor, and then with love, you just develop the plan between the subscap and the capsule. You use then another angulated GLP retractor to expose the capsule, and don't cut at this moment the capsule because the human head is dislocated. So you really ask your fellow, you see, to pull the arm back, and this will expose nicely the place where you need to do your horizontal osteotomy. Start inferiorly to protect the axillary nerve, and then you introduce this tria retractor. This is the only retractor that will allow you to expose nicely the anterior glenoid, because there is this hook that helps you to rotate the shoulder blade. So you have medially for the moment a Hohmann, you have superiorly and inferiorly the GLP, and you have laterally the tria retractor. You put 2 sutures on the labrum, and with an inferior Hohmann retractor, you push your labrum you push your labrum down, and this will nicely expose the anterior part of the glenoid. And then I add this glenoid retractor medially. Then at 8 millimeters from the joint line, you put your first key wire. It has to be parallel to the glenoid, and it has to go up. And I always fix my coracoid process with an inferior screw that measures 28 millimeters. Don't be longer, because in most of the time you will have a very good bite, and then you add another suture screw superiorly that you measure. And I will show you then another video with a tip and tricks to better reconstruct the capsule and the labrum. So this is the end. It's a 5 centimeters incision, something really small. So now, tips and tricks. I just go quickly. Yeah, so again, you put your 2 screw, inferior screw, 28 millimeters. You measure the superior screw. You have 2 sutures on the labrum, and 2 sutures are already passed through the coracoid process, through the CA ligament. You are really flush, and then I will add an anchor between the glenoid and the graft. And with this suture anchor, I have 2 sutures. You can use 3. I just do a shuttle roller with the sutures that are on the labrum, and then with these 2 sutures, I will reconstruct my labrum between the glenoid and the coracoid process. And this creates a huge bump effect that is useful for this kind of surgery. And this makes your graft extra articular. And when this is done, you reconstruct the capsule, and I will show you another tip and tricks that I have. So if you have a look to all the videos that are on ViewMedi, even the video of Gilles Valge, the capsule is reconstructed when the human head is in abduction external rotation, meaning when the human head is anteriorly subluxated. So what we do, we put the arm in adduction, external rotation, elevation, and my assistant will pull the human head back. So it means that we really reduce the human head before tightening the capsule. I repeat, elevation, adduction, external rotation to avoid, to limit postoperative external rotation, and then my assistant will pull the humerus back, and at this moment I tighten my capsule. I put one suture on the lateral part of the subscap to close what I opened before, and the surgery is finished. Thank you.
Thank you very much. That was a very elegant presentation and useful tips. Open surgeons are not common man, but we have a superstar surgeon here showing us the technique done arthroscopically.
अक्का पब्लिक को मालूम है कौन आने वाला है तेरे को नहीं मालूम.
Thank you. So we'll quickly dive into arthroscopic I included talk because the live surgery was not meant to be arthroscopic initially, but see the trend across, especially in Europe and other countries, in Australia, the trend is moving towards the Latarche instead of Bankart, and Bankart is slowly, if you follow the blue line, is dipping down, and there's a perception that the Latarche is a much more stronger and better surgery, but with more volumes in Latarche, we're facing newer challenges, problems, complications, and that's why you're getting newer and newer versions of Latarche, the ones that are button, cerclage, arthroscopic, and so many iterations of them. Unfortunately, the literature is not very charitable to the new ones, and my contention is that it's been going well. If it ain't broke, why fix it? So there's a perception that the Latarche is a bad surgery. It's not a bad surgery. I think the technique is very, very important. So the conflicts are several. Should we use autograft? Should we use coracoid? Is it the same? It's not the same. The native original Latarche, whether the Walsh or the congruent arc as described by Dibier, were the original Latarche, and there are several modifications of them. I don't think there's a big deal about open or arthroscopic, provided you do them. And in my hands, I think both are technically equally demanding. The question we'll deal with at the end is, should we do them without bone loss? And again, the discussion moves, as we saw from Hachem's lecture, which is no bone loss, critical bone loss, subcritical bone loss. So there's a lot of debates coming into this. And now it's going from implant to minimal implant like cortical button, and no implant at all like cerclage. And then the rate of osteolysis and so on. So of course there's a learning curve. This is Brian Cole's series. They said minimum 30 to 50 surgeries to get a learning curve flattened significantly. For the arthroscopic, I would say it is 50. For the open, it should be about 30 as such. Whether you repair the labrum or not, it does regrow. This is a patient, we did an ICBG arthroLatarche, and you can see when we went in to remove the screws, the labrum has grown back imperceptibly. It's given a nice capsular formation there, and that helps and makes the graft also extra articular. So even if you don't repair that. One spoiler alert for revision cases, when you go in to remove the screw, that axillary nerve is absolutely kissing that screw there. Don't flirt with it, and just don't go willy-nilly blind. Because we went arthroscopic, we got to see the relationship. In the open surgery, it's impossible to see this association. You can just feel the nerve because there's so much more scar tissue there. In fact, the anatomy changes. Saha and J.P. Warner's paper, that all the brachial plexus axillary nerve comes in medially, and so you have, laterally. So it's right there underneath your wound. For sure, you all want to do your post-op CT scans because not all grafts are obliged to heal. And if they heal, they may not heal perfectly well. There's osteolysis, the screws could be naked, they can create problems. So why do we want to reinvent the wheel and redo the proven, time-tested Latarche? One, because the arthroscopic latargy is strictly done in the beach chair position, so the enthusiasts who are in lateral position need a different metric to do this. A lot of the surgery is anterior to the subscap, so this is a field that you may not be too used to, and you have to compulsively, obligatorily see the musculocutaneous and the axillary nerve, would do that in open surgery as well. The blame that's thrust on the arthrolatargy and the open latargy is a lot of them do need screw removal. And so the hardware was perceived as a problem. The elephant in the room is not the implant. And because so much attention being given to implant, there are newer versions coming in. Of course, the duration of arthroscopic latargy can be long, and that very dangerous supramammary portal is the issue. The issue really is because of the screws. So if you look this is CT scan looking very impressive, till you do a sag oblique and you realize that in the coronal plane looking good, in the sagittal plane not looking good at all. And these errors are happening because these are errors of commitment. And then in our initial series, this is mine, it's gone too high, it's still good, patient is fine, not dislocating, but it's suboptimal. And the actual view is brilliant, the graft's healed, but I'm not happy because it's in the higher plane here. Screws directed medially is a challenge. They can irritate the suprascapular nerve. We've had to remove screws for those reasons with an immediate relief if you spot it out early before the wasting happens in there. So I have modified this technique. I will do my best endeavor to show you this newer modification within the arthrolatargy. I think it will help build this up. So number one, the coracoid is not a standard straight bone. It comes at a weird angle. So this, when the guide wire goes in, you perceive to put it in perpendicular, it is not. So that is the correct trajectory of it has to be perpendicular to the plane of the coracoid, not to the skin, not to the clavicle, not to the floor. And this we have to get to understand because graft fracture while taking the graft is not unknown. The subscap split is the next challenge, so you have to identify the upper border, then the lower border, the three sisters, and then come at that 2/3, 1/3 junction, and then use a nice, good quality radio frequency, make a few dots to dot the line because there's a tendency to start lower and come above. And then that can damage the subscap or it can avulse the subscap as well. You want to be right in the line of the fibers. Of course, the field and the anesthetists are very critical to having achieved this. So the new technique, what we did was, instead of capturing the graft, we first go in directly with the cannula. Graft capture is easy, it's not a challenge. Here we're just manipulating the graft with the hook probe. We'll come to the newer technique. So in the newer modification, we just come in with the blue cannula directly because it's a transparent cannula, you can identify the location. You can go low, you can go parallel, and you will ensure the screws are not skewed and not directed medially because you can tweak the cannula much better. Once the graft comes in, you're compelled to take the direction. The soft tissues, especially in a muscular individual, will not allow you to take the channel. So you just drill the alpha hole, that's it. Just drill the alpha hole and withdraw the wire like so and keep it there. And so gently withdraw the wire as we're doing here and then keep it there just at the edge and then move on and then do the graft capture and come with the graft again and then recannulate that guide wire. Now this is the tricky part and it adds a little more time to the smooth arthrolatargy, and once you can achieve this, then you know that if your bottom hole is correct, the second hole is going to be parallel, and then you're going to get a much better positioning of the graft. And you can see on the X-ray on the light, your lower sector, your parallel, and the graft is sitting exactly where you want it to. So our success rate with the screws, there were about 10 to 15% patients who had screws in suboptimal position, different directions, graft healing. Clinical, it doesn't impact the clinical picture at all. So between our first 25 and next 25, our alpha angles improve, and it's important to get this right. And our mean alpha angles came down to 10 to 15 degrees. So this is Matthias paper. Screw removal does remove this awkward pain, unexplained pain that arthrolatargy patient may have. This is one of mischievous papers by Pascal Boileau, which said that the screw complications are much higher, 18%. But if you look at the series from 2018 onwards, it's just 0.7%, 4%, 7%. It's really not that high. As long as you get that supramammary portal correct, it should be wide, low, and medial. That is what will dictate your screw position. But you must do your CT scans. In our series, we had, in the first 200 patients that we mentioned, we did 9 plus 2. So 9 screws we removed. 2 patients we advised removal of screws, they refused. They said, we have no problem, we are not coming in for screw removal. So technically it was like 0.4% of screw removal rate. Open Lataja also has a similar complication rate. The discussion really should be we use the coracoid for epileptics? What can we do to mitigate the hardware? So this is the new technique coming in. Really low morbidity surgery. The redislocation rates are very low. So that's not a metric to measure the Lataja success. The 10 steps we'll go through during surgery, so I'll not cover this because I'm going to repeat that when I'm doing surgery. And just dealing with some of the literature for the double button Nicola Bonivier paper, I recommend you read it. Much longer healing rates, almost 9 months. Nicola was open Lataja, went to the arthro button and has gone back to open Lataja now. This is Chinese paper, bone union took 6 months to achieve with the cortical buttons. And comparing these, Metai said there's a higher redislocation rate, 6.25 versus screws, which was 3.5%. Comparing the screw and the other types of fixation, I think the screw is tried and tested. It's rigid, it's robust. I get a good feel. I don't see any unmet need to change that. But you're compared to doing beach chair, there is an implant removal problem. I would say 7 to 8% as such. The other techniques, there's no screw, there's no implant-related problem, but late healing and micromotion can be real problems, and it's a newer modality we don't know in the long term as such. Certainly, going home, don't do Lataja when there is no bone loss for sure. These are some of our patients who have had instability and they have contact athletes. Not only have they resumed play, they've actually gone back and achieved gold medals. This is a patient just came in last week, 17-year-old. He's not a bankart, he's just arthroscopic labroplasty and still got a gold medal at the national games. So finally, in conclusion, Lataja, very predictable. There's a learning curve which you all will surmount eventually. Be careful that the Asian coracoids are smaller, but I would still, even for wrestlers and contact athletes, still do a soft tissue surgery without doing a Lataja at all. But that's what I meant, that not all difficult instabilities need treatment with a Lataja. Thank you. Thank you very much.
Thank you very much, Dr. Ashish. Do we have time for questions or are they ready in the theatre? Oh, we have 5 minutes for questions. So I invite discussion from the audience, and till that time, let me get the ball rolling. Dr. Ladaman, I would like to start by asking you, most of us don't have access to the curved saw. Can we use a giggly saw or a wire blade as an alternate? And most of us also don't have the Tria retractor. We use the more commonly available Fukuda retractor. Is it equally good, or what are your comments?
So for me, the Fukuda is a little bit too wide. So you are obliged to do a very wide capsular incision that I don't like. But of course, you can do it. And the second thing is for the saw, you can use, I use from time to time simply a curved osteotome. But don't try to take all the piece in at the same time. I start medially and then progressively move laterally with the osteotome, yes.
Mic 2, please. Turn mic 2 on.
Yeah, I have a question for all faculty for this session. Now, I have a patient who has got 20% glenoid bone loss and got a relatively bigger, larger heel sacs, which is engaging. Now, I do irrespective free bone graft or Lataja. Now, will you do remplissage when you have put the bone graft anteriorly? If yes, in what cases? So bone grafting, Lataja plus remplissage. What are the indications?
I did it once in a catastrophic situation, but honestly, in most of the time, this is something that is not necessary.
Not necessary.
Yeah.
So I've done it only once as an exception, but this was a Lataja done in Bangladesh, and it was very well done. The patient was still subluxating. So I removed his implants and did a remplissage, but that's an extreme. For my primary cases, I've never done that. Never, ever.
From my point of view, if you take a look at 25% of the defect, the glenoid tract is, I mean, with almost 20 of heel sac is off track. When you restore the anatomy, if you have 20, you still have more than 20, you still have peripheral tract or off track. In these cases, I should add, I recommend to add the remplissage, but never filling all the defect to reduce it from 20 to 10. That means it has become from peripheral track or off track to on track by reducing without filling all the rate of the heel sac in these cases.
Coming back to the Raju's question, for osteotomies in the coracoid, we don't have access to the curved osteotome. And I use now only curved osteotome now. With the sharp osteotomes, I never had any issues so far. What is your take or other faculty take about osteotomies with the osteotome for the coracoid instead of using the curved saw?
So I used to use a curved saw, but all the open latages are done by my fellows. I supervise them from start to end. The saw in their hand is a little tentative because you need perfect speed control. So we switched to the osteotome for all our open latages. And even arthroscopic, I always use a saw, always use an osteotome.
Sundar, I borrow the reciprocating saw from our joint replacement colleagues. That is a small blade and does a very good job.
I think I've always used a curved osteotome, no problem.
Hashim, this is for you. So I just want to mention in front of the audience, whenever you see, we're going to talk about scapulothoracic abnormal motion. Whenever you see this amount of scapulothoracic abnormal motion, these patients are very, very challenging when it comes to posterior shoulder instability. Because the minute you tilt the scapula forward, you can slip the shoulder outward. So in this setting, if there is no bony deficiency, the scapula should be addressed. If there is bony deficiency, which means structural, with the scapulothoracic abnormal motion, this is when you have to decide whether you need to do one or both. What do you think?
Absolutely. In fact, this is the scapular compression test is your test. You teach me about it because if I stabilize the scapula and the patient wasn't able to reproduce the symptoms, it means he will be good with physiotherapist. But if I compress the scapula and stabilize the scapula, but patient is still losing the shoulder and provokes subluxation, in these cases, I put my finger. If my finger pushes the head alone and stabilize the shoulder, it's gonna be good with the bone block.
Mic 3.
Hello. I would like to ask Ashish sir that in case of a neglected dislocation of shoulder, usually we don't have glenoid bone loss much, but there is a large heel sex lesion. So can this be managed indirectly by a Latarjet technique?
Au contraire, if you have a persistent, neglected anterior dislocation, is that what you're asking me for?
Yes, sir.
They will definitely have glenoid bone loss. The head sits on the glenoid. We don't perceive it because unless you do 3D scans, which are subtracted, and if you subtract the humeral head, you'll realize there's a big void there. For sure. For sure. So then the heel sac is not relevant at all. You have to go in. Now there is a very difficult problem there because there is no anatomy. You don't see the subscap is widely internal rotated. The head is almost sitting on the brachial plexus and you are unable to reuse the head. Anybody who is 4 to 6 months beyond, I treat them non-operatively, the pain goes away. I don't think in my hands surgical intervention is going to change their function or range of movement. You can't. And I've done this and I have several patients on this side. But if you're within 6 weeks, then it's a good time to go in. The first thing I would recommend is do a coracoid osteotomy, take the C ligament off, and with the coracoid, with the pec minor, just flap it out. You get a fantastic exposure. The brachial plexus is safe, vein is safe. If you look at published literature, there is a very sprinkling of 1 or 2 cases from each author. The incidence of axillary vein injury is almost 80 to 90%, in my hands at least. So take out the head, easy to relocate, keep a vascular surgeon on the side, and use that coracoid to put it as a Latarjet. That gives you an augment. But that's why when you do an osteotomy, don't do an osteotomy for a flap. Take it from the base of the coracoid because then it works like a Latarjet. Then you need 2 screws to fix it.
Thank you very much, Ashish. I think we are ready in the theatre. We will go ahead with the live surgery. Now I invite Dr. Nagaraj and Dr. Dinsha Pardiwala to come and moderate this session. Thank you.
Case number 2, we have a 51-year-old female patient, complains of right shoulder pain and weakness for the past 6 weeks, history of fall on right shoulder, history of night pain is present, no history of neck pain or tingling, VAS score is 8 on 10, UCLA 13, ASCS is 33. On inspection, SSP and ISP wasting is noted. Codeman's point tenderness is present. LSP tenderness is negative. AROM was 170, 160, 40 in L3. IR90 was 80 and ER90 was 30. Strength testing, empty can was noted to be 3 on 5. Full can was noted to be 3 on 5. ISP was noted to be 3 on 5. On the right side. Now going into horn blowers, it is noted to be 3 on 5. ASP subscale was noted to be 5 on 5. Gerber's was negative, and Napoleon is also was found to be negative. Investigations, the X-ray. MRI, T2 coronal showed massive supra and infraspinatus tear with retraction up to the glenohumeral joint, somewhere about 40 mm retraction. It's close to the glenohumeral joint. T2 axial showed joint diffusion with COR slightly posterior due to the absence of infraspinatus. T2 Sach posteriorly superior T2 Sach clearly shows a cuff tear involving supra and infraspinatus. T1 Sach, supra about 20% wasting with grade 1 infiltration. There's minimal atrophy of infra and T minor hypertrophy is also noted. It's a massive rotator cuff tear with type D Collins. Now we'll have the live surgery demonstration by Dr. Teruisa Mihata. Over to the moderators.
Sir, your mic on, sir.
Hi. Hi, Teru. We can
Hey.
see you.
Oh, you can see?
Yeah.
Oh, can you see the inside of the joint?
Not yet.
Not yet, please. Yeah, switch to the inside joint. I want to show the arthroscopic finding.
Perfect. So we see you and we see the arthroscopic image too.
Yeah, now it's a supra and the infra tendon tear, and this is the teres minor, big tear. And actually, measuring probe again. Yeah, already we measured the defect size, and we started to make a graph. And on the grade velocity, this is a 3 centimeter anterior posterior. And actually I measured from supraglenoid to the lateral edge of the grade velocity here. So it's around 3.5 centimeter to here. So I want to insert graph 1.5 centimeter more medially. So 3.5 plus 1.5. So graph, now he's making graphs 5 centimeter and 3 centimeter. And already almost finished actually. Now I'm making the inserting suture anchor. So the, yes, gold one, yes. First glenoid and medial anterior side, it's actually coracoid base here. So usually from the just anterior to the AC joint through the very good direction to here. So can you hold scope? Actually, I want to tap here. Yeah, so this is a coracoid. So coracoid base, this is a very wide area, so very easy to insert. And so far, anterior anchor usually I put here. It's a 4.75 millimeter screw type suture anchor. And yeah, this top because very young lady. And, okay. Even massive tear, just 2 anchor on the glenoid. So this 4.75 by composite suture anchor. Then
Teru, what are you planning for the
double loaded.
biceps? What are you planning for the biceps?
Biceps, actually, always I keep it, actually, biceps here. The biceps, good biceps, I leave it, and also subscapularis, it's okay today. Yeah, so only the show. And one other anchor through the Nevisor portal, from the Nevisor to the posterior superior location with the glenoid here. So let's see.
Dr. Mihata, any indications to put 3 anchors on the glenoid?
Actually, never. Can hold? Yes. Yeah, even 5 centimeter graft or, yeah, actually, it's maximum 5 centimeters so far. And yeah, 2 is enough. Actually, I never failed in the graft tear in the glenoid side. Yeah, because it's a 4.75 or sometimes 5.5 screw type, the suture anchor, so very strong.
And the trajectory from the naviator portal is best for you, not from the posterior posterolateral portion of the acromion?
Posterior acromion what?
So the trajectory from the naviator portal is the best for you for this anchor, or?
It's from the, actually it's a Nevisor portal. It's a Nevisor, I can, yeah, if you see the outside, maybe.
Can we see outside larger image?
Can you see outside? Oh, yeah. So now, how I can show? Yeah, where is the camera, actually?
Other way around.
Oh, that camera? Oh, yeah. So this is, it's not the, actually, anterior from the anterior camera, not superior camera, so we cannot see. But
camera from the posterior.
Yeah, can you move this way?
No, but I think we understand.
Yeah, if you move this way, that much.
Neviaceous portal that you're taking the.
Yeah, anyway, this from Nevisor portal, and this is from the AC joint. So usually these two, you can take. Yeah, take here.
Okay.
Perfect. We
see yeah. So this is from Nevisor. Now I just take out this. Yeah, this is Nevisor, and this is from anterior AC joint. So these two is enough. And next year, again, greater tuberosity side, here, can hold. Yeah. Hammer. Yeah, so, I make a different one. Yes, so the, okay, so the very anterior, the very posterior, so just 2 anchor is enough, even big tear again. So just behind the biceps, I put the 1 anchor, and it's a very medial, and tap. 一応しておきますね。結構そんなに強いんですよ。And this lady has a very good bone, so I make a tapping too.
Dr. Mihata, have you tried to mobilize the infraspinatus? Have you tried to see its repairability?
No, actually, we don't have to actually, because ACR. Yeah. But I released the, okay, I can show later. Actually, I released the glenoid side to make a bone footprint on the suture anchor on the glenoid side. So actually, yeah. So I actually to make a bone footprint on the glenoid side, I release actually here like a mobilization, and also one more.
Would you attempt any partial repair in these cases?
No, actually, if you do partial repair, for example, retriever, please, retriever. If you do partial repair like this, actually I take out. Then actually the defect size decrease should be, but here this part is over tightening. So That makes a detail of the infraspinous tendon, even graft is okay. So bleeding. So that's when I started this surgery long time ago, I did the partial repair first, but I found the infraspinous tendon tear or minor tear after HCR. In posterior, it means the posterior tear. So that's why I stopped to the partial repair. Then, so instead of that, I make a very big graft, actually, yeah, to avoid the over tightening of the other tendons, so the residual tendons. So it's bleeding here.
Dr. Mihata, with
Yes.
respect to biceps, you believe in leaving it alone versus biceps stenodesis because you want some amount of humeral head depressor effect addition to your graft. So why do you leave it alone? Why do you prefer it over a biceps stenodesis?
Okay. So actually, if you want to cut, actually, you can cut. If you cut the biceps, more space, so maybe surgery is much easier. Wait. But wait, now I'm making suture anchor, and okay, see. So this is a biceps. Actually, graft is graft coming here. Then afterwards, and if we keep the biceps, graft and biceps, they actually unite. Maybe 6 months or 1 year later, when I see the second look, so it means the biceps can augment the graft. So if you keep the biceps some make some advantage, mostly to prevent the graft tear, graft augmentation. So yeah, but if you cut biceps, this patient we can see very well, but sometimes the tendon edge around here, that case it's hard to see the glenoid bone. That case maybe if you cut biceps much easier. So yeah, you can cut biceps, but I try to keep the biceps. Yeah. But maybe but even cut the bicep, the graft is healed. Maybe the result is very good. So yeah. Anyway, depends on the graft healing. So this surgery. So I inserted two suture of the glenoid and the great tuberosity already. So now I'm waiting the graft and can hold. Yeah, and then. Actually, the lateral side, then maybe you can see this lateral total. It's only 1.5 centimeter, but the graft is 3 centimeters, so we need to cut a little more. So it's nice.
Then what happens if your subscap is irreparable?
Yeah, so I did many things actually before. First, I just leave it, but I found the high graft tear rate or high infection rate. So now, then next I did the teres minor transfer, but for me it's not good. Actually, no change in the result compared to the just leave it. So now I'm making the anterior capsular reconstruction if parallel cuff tear, parallel subscapular tear. But then actually the results looks okay now. It's better. So now I'm making anterior capsular reconstruction, and this you can see this syringe. Actually, maybe here. Yeah, I cut the tip of the syringe and also cut longitudinally like this. Then this is this cannula, actually manual cannula inserted the joint from the lateral portal. Yeah, then, yeah, so now I'm making the, I inserted the graft. Then, can I use this one? And
that's a 20 ml syringe, is it?
Where is the, yeah, so, anyway. bleeding something? Wait, bleeding somewhere from the bone, maybe. Yeah, should be okay. Yeah, it should be okay. And the graft, where's graft? Yeah. So now, yeah, he did good job actually. This graft and the ruler. Do you have ruler? Yes. So this shared graft. It's a 5 centimeter and 3 centimeter, and graft thickness around 7 millimeter to 8 millimeter. And this side the same thing too, 8 or 7 millimeter. So this is the graft. And also, he make a suturing in the medial mattress. It's very good to make a stiff graft. So before suturing the medial mattress, actually very soft actually. But if you make a medial mattress suture like this, it increase the stiffness. So maybe this graft push down the graft, the humeral head very well. So anyway, now I'm inserting the graft. Then wait. In this ruler, I don't need. Oh, where's the ruler? Yeah. And it's usually I take. Okay. And retriever, blue one. Such a retriever, the blue one, yes, thank you. So now, yeah, it's hard to see inside, but now outside, it should be okay. So anyway, this leading suture I put in the joint, then take her through the anterior portal. Oh, one more time. And I need a big needle. Do you have? Oh. Can you see? Oh. One suture and another. Oh. Okay. So now I take the lateral anterior suture first and tape. Actually tape on the sutures. So one by one. Then okay, and then the pickups. Yes. So now please show outside here.
Outside view large, please. Not the picture in picture. Not the picture in picture, not PIP. Yes.
Okay, thank you. Oh, I want to show, do you have the marker? And ruler again. Ruler? Oh, ruler somewhere. Ruler here? Oh, do you know where is the ruler? Paper ruler. Oh, here. Yeah. So usually they are 1.5 centimeter from the edge. I make a mattress like this. Then around from the 1 centimeter to the medial side, make a mattress here. Yeah, so this is a good location to make a mattress. So this is the anterior lateral on the great tuberosity. So make a mattress suturing. Yeah. Retriever again. Retriever, blue one. Oh, where's the retriever? Oh, here. And another suture tape, blue and white. Give me again. Okay. Okay, one more time. Retriever here. And the posterior lateral. Yes, so take out. Okay, give me. And tape and suture together. I put.
So we can see that Teru's taken out the sutures from the medial anchor and he's suturing the graft
on the great
outside.
velocity, yeah.
Yes.
Yes.
And you can see that what he's doing is he's keeping all his sutures in a very methodical manner so that they don't get entangled.
Yeah, so that's why I'm using this manual syringe. Maybe you can realize later, maybe soon. Then, yeah, so this. And do you have mosquito? Small, yeah, two, they have two. Yeah, then take a syringe. Yeah, we cut the longitudinally so we can take out the syringe now. And do you have something? Oh no, okay, that's fine. And inserter there, and syringe again. Yeah, so now putting the syringe again. So that is very important. Now you can see the all the suture lateral side is outside the syringe.
Yep.
So now next take out the medial side on the granule. Then yeah, suture problem, tangling or the if the suture cross medial side and lateral side, that's a problem. So to prevent that a problem, yeah, first lateral suture everything, then insert the manual syringe again. Then yeah, now we can separate the suture completely. So then no problem about the suture problem during the insertion of the graft. And then around 1 centimeter from the edge to here. So already what I mark.
And this would be mattress too?
Yeah, mattress, yes. All mattress.
But here you are taking a single suture, and there you took two sutures in this first.
Yeah, two suture on the ground. Each suture, each anchor has the two suture, double loaded. Yes, so. Yeah, so two mattress and next I use the knot pusher, I think. Yeah, mattress here. Steady cross. Okay, so one more retriever here. So finally, from the granule side, the posterior side, here, this is the suture from the nearby portal. See, take everything here. Okay, so mattress again. Yeah, this is the last one. So wait a minute. Yeah. Yeah, any question? Yeah.
With regards to your graft retrieval, obviously you would try to go near the Gmax insertion. Any tips you want to share for the beginners as to how your graft to make sure you get a very nice thick 7 mm thickness?
Yeah, it's actually the Dr. Uchida, my fellow makes it, but again, the intermuscular septum, it's necessary to make a thick graft. So maybe he can show where is the intermuscular septum. Maybe the replay videos. Oh, you have the movie file already? Yes, yes. Oh, maybe they record it.
We can see if we get time for that, but we are
Yeah.
enjoying the suture relay that you're showing us.
Okay, so now I make all of the sutures.
Then one question. We've got, you've used the same technique for the graft, for the last 10 years.
Mhm.
But there have been other authors who then put a muslin mesh in between the graft, and that seems to give the graft more strength. Do you think that's really needed?
Yeah, I agree. It should work very well. Yeah, I did a biomechanical study about this. Then we found the stronger and very so the yeah, but it depends on the material actually. But anyway, it should be helpful to graft here to prevent graft here. Then next, I take out this syringe. Actually, the medial suture, lateral suture now completely separated. So don't worry about the suture problem. So now take out because the very big graft, it's hard to insert with syringe. So now usually I take this two suture ring from the one suture. Then these are not pusher, so can hold. Then, yeah, if we move the medially, suture very loosen. So every time I make a tighten, maybe each 1 or 2 centimeter, then all suture take the pull, then move again. Yeah, then loosen, so take again. You have mosquito, another? Oh, okay, that's fine. Yeah, so I can hold this one. Oh, should be okay. Yeah, now almost the coming to the joint. Now you have to rotate up. Oh, again, we need to cut the skin a little more. Can make a knife? Yeah, that's here. Too big. Then, yeah, so you can see the skin stem. So rotate 90 degrees to put the graft to the joint, like this. Then again, the all suture pull to make sure tighten. Yeah, so now inside. Yeah, inside you can see the inside joint, but the sutures become tightened. There are some sutures still. That blue one. Oh, it's not. Rotate back like this. Then pull the suture again to make sure tighten. Yeah, so now going to the joint.
Inside picture now, please. Arthroscopy view.
Okay, so now we're coming to the joint. Then I want to put the graft under the tendon. I push here. Yeah, so maybe already, yeah, good position. So now not time of each suture from the white one. Can you see here? Oh, okay. So it should be okay. Yes, yes, this suture and this suture. Suture cutter, please. Suture cutter. Okay. ノットル参加も2つ出しておいてもらっていいですか Yeah. We need notless anchor to
Teru, while you're tying the knots, maybe ask you some questions?
Yes, please. Yeah.
Okay, so a critical part of this is going to be the tension that your SCR is in. Now, once you fix the glenoid, how are you going to decide what's the perfect position of the arm for the tension on your graft?
Yeah, tension of the graft. Actually, I'm sorry, that's a suture too long. But anyway, yeah, tension. Now I don't need to think about the tension because now just I fix only the glenoid side. But yeah, and when we fix the lateral side, we think a little more. But actually, the tension is already. We cannot change so when we make a mattress suture outside, already it's tension. We cannot change the tension already. Yeah, so the making a suturing location maybe the one of the critical part, I think.
So your measurement, your initial measurement of where you're going to take the sutures really decides the tension.
Right, measurement very important. Yes, and. First suture, I couldn't cut very well, so I need to cut again.
Dr. Dinsha, a quick announcement that they can pick up their lunch boxes, which are placed at the back of the hall.
Yeah, please have a lunch. Yes, so maybe. Yeah, that's suture. I don't know. I can cut grasper. That's wrong.
So while Teru's doing the SCR, just an announcement there that we're going to go through with lunch in the auditorium itself. So
please. Yeah.
You all can pick up your boxes and sit in your chairs and have your lunch while we see the next two surgeries too.
Yeah, and now two more not time, so you can have lunch. Anyway, yeah. So this is the anterior side, and
Dr. Mihata, just to take the discussion forward, what Dr. Dinshaw started, the reverse trampoline effect that we are aiming for, when you are tying your lateral row, double row sutures, don't you think that some amount of tensioning or retensioning can happen based on the arm position, based on the tension of your double row anchor?
I'm sorry, what do you mean? It's a tension double row anchor?
So your lateral row anchor, which you are going to be placing, when you're placing that lateral row anchor.
Oh, okay, yeah.
Don't you think the position of the arm will help?
Good question actually. Yeah, so I usually do the around 30-degree abduction. Maybe you can see outside view. Yeah, so 45. I think it's too tight. To measure. So the 30-degree is. So I think from my experience and from my biomechanical study, it's a perfect angle for SCR.
30 degrees.
Yeah, 30 degrees. Yeah, 0 degrees is too loose actually. Yeah, so, yeah, thank you very much. It's a very good question. Suture cut again, please. Yeah, so my fellow want to show the how to prevent the hematoma. So maybe you can see outside view here. Which not time, maybe blue one, right? I forgot. Okay, not time first. Yeah, it's after intermuscular septum harvested, the big defect if you don't suture very well.
We need to hear you clearly. We can't hear you so clearly.
Just a minute, sir.
Yeah, so now he is suturing between the gluteus medius and the vastus lateralis or femur bone. Yeah, because he harvested the intermuscular septum between the gluteus medius to the femur bone. So that's suturing very important, I think, to prevent hematoma.
Okay.
Cutter, please. Yes, so now. This suture. It is. Okay, I don't need this one. Okay. So one suture attached to the needle. Yeah, big needle. That one. Yeah. So now I fixed the glenoid side here. So next the lateral side. So I want to show a little more very well.
So the SCR fixation on the glenoid side with 4 mattress sutures is completed.
Right. And now, okay, can I see? Yeah. Can I hold? Yeah, I can hold. Yeah, scope now. Yes. And I want to show you more.
So Teru, we have another 10 minutes for your case.
Okay, so maybe just we put a lateral anchor, then finish. So there.
Do you tie knots on the medial anchor or do you just tie them down to the lateral anchor?
No, I make a medial mattress suturing in the at the end. And can you hold? Can you track a little more? Yeah, can hold scope? I want to change the traction. Where the foot pedal of the spider?
Can we see the outside picture of the traction now?
Yeah, spider foot pedal. Where is this? Where is the spider? Oh, can I see? So hold. Oh, yeah. I hold a little more. Yeah, does not change. Okay, can you see?
So more forward elevation and 30 degrees abduction.
Okay, yeah, more traction I did a little more. And but actually. Okay, so retriever, please. Blue one, retriever, please. Yeah, blue one. Yeah. Yeah, so now I need to take this suture. Oh, this suture we don't need. And can you go down a little more? Actually, go down. It's, can you put the pedal? And ここ支えといて。はい。ちょっと後ろが手伝って。Push foot pedal. Foot pedal, where is foot pedal? Yeah. いや踏んで。踏みます。Okay. Yeah. Then これでちょっとこうしといて。Okay. Then retriever here, and this is the lateral sutures. I want to show a little more better. I'm sorry, traction is not good, so you can see. This medial sutures now, finally.
Teru, while you're clearing up, we'll ask you a few questions.
Okay.
What's your indication for a tendon transfer?
Tendon transfer, I don't make too many, actually very rare. Actually, only for the external rotation strength they need, I do. So this suture take off through the anchor portal again.
And why do patients with SCR get an improvement in their strength? Why do you feel that happens?
Yeah, because if we stabilize glenoid joint, actually, especially deltoid muscle works very well. That's why the stability very important. So yeah, even not only the root cuff tear patients, the instability patient also, if they have the instability, anterior instability, posterior instability, but yeah, if you fix the anterior posterior instability, then there maybe it's again the Dr. Bassem told same thing, the scapulothoracic, scapular movement, scapular stability getting better, then maybe muscle strength getting better. So yeah, biomechanically it's restored very well. Then yeah, so wait a minute.
So
we need to find
question to anybody who can answer this, even if he's busy, then that SCR, does the movement come first or does the pain go away? So in my experience, there were few patients who had an elevation, at significant elevation coming up, but their pain doesn't seem to settle down.
Yeah,
I know commonly, is it an experience with everybody or is it in first few cases?
Good point. Yeah, pain relief also they are good. Yeah, good for the muscle strength.
So at least from my point of view, both are interrelated, isn't it? As long as pain doesn't go away, function won't really improve. Bottom line is, at least in my experience, these patients take a long time. You need to counsel them that they're going to take a long time to get their pain and function back.
What long time is defined as long time? So by 6 months, your SCR should heal down. MRI proved that your SCR is healing. But this is for patients who started off with little arthritis, pseudo paralysis, and you do an SCR, and in few of the cases of mine, their pain is not going away. So I just wanted to know what extra do you do or anybody else that their pain also resolves, or maybe they take a lot of time for the pain to settle down. I'm not sure.
So the pain relieving measures which we typically do in most of these cases, you need to do a good tuberoplasty, you need to make sure that the biceps is taken care of. At least I believe that the biceps has to be taken care of. You need to make sure that there's a good space created there, both on the acromial side, on the tuberosity side. But at the end of the day, these are procedures which are non-anatomical.
Okay, so now abduct. Yeah. Okay, abduction more. Abduction more.
All the procedures which we have described for irreparable cuff tears work on the ability of your graft or tendon to depress the humeral head down. And as long as you are able to achieve a very strong, thick graft which depresses the humeral head down, I think the functions and the pain will always improve faster.
Yes. So now I'm making cannula again.
Okay, so Teru, we're going to give you a little bit of a break.
Sutures? Okay, yeah.
We're going to go to the other theatre. We'll let
Okay.
you finish off the tuberosity sutures, both the medial row and the lateral row. And then we're
I
going to
will
come
clean
back.
up.
Yes, and then we're going to
Okay.
come back to you to see what the final image looks like.
Okay, okay, thank you.
Thank you, Teru.
Going into case number 3, we have a 68-year-old male gentleman, a known case of left shoulder post hemiarthroplasty done on 23rd August 2010. Came for follow-up. No complaints on regular rehab and supplements. VAS score was nil. UCLA was 32 on 35. ASCS of 93 on 100. Going into the range of movements, he had a 165, 165, 85 bar D12 with an ER 90 of 90 and IR 90 of 70. Cuff strength were all noted to be 5 on 5, no DNVD. X-ray actually shows severe glenoid erosion with reduction in the glenoid vault. These are the axial, coronal, and sagittal CD sections. If you notice, you can find that the vault is very much thinned out and the severe glenoid erosion. Now we're going over to Dr. George Athwal to help us guide us with the planning.
Hello, how does that project? Yep, can you hear me?
George, we can hear you.
Oh,
We're just
wonderful.
waiting for the image to come up.
So there should be a PowerPoint presentation, and we're just going to discuss the preoperative planning of this revision. There you go. So you can see the x-rays. We've already seen those. This is a cemented humeral stem. Can we hit the next button, please? Yeah, you can see that there's substantial superior glenoid erosion. Next button. There is some retroversion associated with that also. And you can see that there is a fair bit of cement distally, and so we're not going to plan on removing all of it. We're going to do, our plan is for a cement on cement revision within the humerus. So when we play the preoperative plan, the revision planning, you can see there's the BF stem. I can cycle my way through it, put in the humerus, and you can get an assessment that there is some greater tuberosity and humeral head left laterally, and I'm actually going to use that to graft the glenoid. Here's our glenoid, substantial erosion, and we're going to reconstruct the glenoid with an augmented implant, but I'm going to have to use a hybrid technique because this is a 15-degree wedge implant, and it's probably insufficient to manage this gentleman's erosion. If you can see in the bottom right coronal image. So let's go ahead to the next, please. Here's, if I'm imagining that this is the augment, to get the correct RSA angle, I'm going to correct to minus 10 degrees of retroversion and neutral inclination. I'm going to have to angle a guide about maybe 8 or 9 millimeters off of the bone to get the correct axis. And then once I start doing that, I'm going to ream, and I'm going to ream to get about 50 to 60% seating of the base plate with 100% of the boss in bone. And then I'm going to make up the superior bone defect with some autograft. I don't think we need a substantial amount of autograft. It only needs to be about 3 or 4 millimeters thick, if you can see there. Next slide, please. And so this is what I'm going to measure. That's my start point. My start point is going to be about 15 millimeters medial to the inferior rim. We'll plan that. We've got a ruler here. And that's going to be our plan. And what we can do is we can ream to get 100%, or we can ream to get 60% and use lateralized sphere. I think we're probably going to do the latter. So we're going to aim to get about 60% backside seating, 100% of the boss, and then augment with a little bit of bone. Next slide, please. On the humeral side, this is where probably it's going to be a little bit more challenging. We're going to have to take out the humeral implant. And the cement mantle, it's a fairly thin humeral implant, so we're probably going to revise it with a longer stem. There's no advantage to go short here because there's that distal cement mantle. So typically in this case, if there was not any cement, I'd revise this to a short stem. But because there's cement distally, it doesn't make any sense. I think might as well put in a longer stem or a traditional 130 millimeter stem. And we're going to use an eccentric poly. Next slide. And this is what it's hopefully going to look like when we're done. We're going to have a full wedge 25 on the glenoid and a long stem on the humeral side. All right, well, let's go live. I'm going to slide over here. So I'm going to slide. Okay, thank you. All right, so I'm going to slide a little bit further over. What can you see? Can you see the incision? I'm just going to be a little bit closer. We'll take a right angle here. So all we've done really is, if we can look down at the incision, please. We'll, right here. Okay, so all I've done is really expose. So here's my subscapularis. There's our subscap. Here's our coracoid, our conjoint tendon. So we've very carefully dissected the interval. I'll put this over here just to show. We'll grab that, and we'll put the Brown retractor in just a moment. There we go. So what you can see is, here's the coracoid, the conjoint tendon. There's our subscapularis. And here's our humeral implant. We haven't done anything, and we're going to start really most of the operation live. So let's get started. So what I'm going to do first is I like to put this Dara retractor in here, and this is going to go right at the bottom. So we've done our releases already. Good. And you're going to hold on to this, and we're going to put this here. So one hand here, one hand here. You're going to hold on to the suction. And now we're very carefully going to dislocate this. We'll move the Mayo stand out of the way. Oh, let's keep this up here. And so I'm just going to very carefully, let's just move this up. There we go. Slide it out. So I've done all my releases. And we're going to hold that there. Now I'll take the remover of the head. So we're going to use this device here to take the head off. Now this may fly, so ready to catch it? All ready? Who's ready? You? Good. All right. So there's our head. Now what I'm going to do is, do we have a small rongeur? So there's typically a little bit of membrane there, so we'll take that out. And you can see on this case that there is a substantial amount of tuberosity still left. So I'm going to use that tuberosity to potentially bone graft the glenoid. All right, let's pass that back. And I'll take some pickups and my cautery. So there's the rotator cuff footprint right here. I've released a little bit of the supra. I'm going to take a little bit of this bone right here, because I'm going to need to get access to the implant anyways. So I'm going to eventually take this little bit of bone right here, and we're going to get access to the implant, but then we're going to go ahead and do the glenoid first. Typically what I like to do is I like to do the glenoid part of the revision first and keep the stem in. The reason I like to do that is it decreases the chance of me fracturing the stem, which is always the number one problem with a revision. All right, I'll take the saw, please. So I'm going to come in with a saw. So what we're going to do is we're just going to gently move the arm like this. Can you hold it like this, please? Good. That's excellent. So very carefully, I'm going to come in and remove some bone here. Here. Now I'm going to come in from the top, and hopefully this doesn't go on the floor. I'm going to catch this. All right. Let me see that. Do you have an osteotome? Let's see an osteotome. All right. Let's hope someone can catch this for me. Okay, there we go. Now that cannot go on the floor. Rongeur, please, large. That's good, that's good. I'll take that. Good, so we'll take this one. Okay, you can let go. Number one. This is good bone, we'll save that. This is the bone right here that I'm going to hopefully use to reconstruct. That's all we're going to need because it's a 25 millimeter base plate. So we need this bone. That's very important to keep. Okay, good. So I'm not going to take out the humeral implant right now. So everyone can come out. So we're going to take everything out. And now we're going to start onto the glenoid. Great. So to start on the glenoid, the first thing I'll take is this. You're going to hold on to that. And then what I do is I take my large DARA, this instrument right here, and we're going to use this to place this behind the glenoid, just like that. And actually, okay, I got it. Okay. And you can take out that retractor. And you're going to hold this with about that much force. That's it, nothing more than that. And we can hold the arm here. You're going to hold this. And so now we're going to expose the glenoid. I need to get in a little bit closer, so we're going to move this. I usually operate with a spider, and this is a nice big table we have here, so it's going to take me just a little bit of time to get used to that. And we have some pickups. Good. So what can you see? Good. So here's the coracoid, right here. And now what I'm going to do is I'm going to do essentially a coracohumeral ligament release. So I'm going to come in right straight towards the glenoid, right through here. Right down to the glenoid. Remove all this tissue. And there I am. I'm on the anterior glenoid. I can see that. So now what I'll do is I'll grab a small DARA, this retractor right here. I'm going to make a small defect right there. And so I'm going to start to get around this glenoid. There we go. And now I'm going to, so I'll hold it. That's okay. So I'm going to start taking this thing off. Now do you have a long-handled scalpel? So here's some still residual labrum. I'm going to try to take that off.
George, during your releases,
yes,
did you do any release of the pec major insertion tendon?
Not much, no. I'll take a knife, please.
How about the CA ligament? Any minor release there?
No, I leave the CA ligament also.
Okay.
So we're just waiting on a knife. Oh, thank you. Oh, that's a nice way to pass it up.
George, do you routinely take cultures for your revisions?
If there's a good reason for failure, like in this gentleman, I do not. If I'm concerned, then I will. So now I'm just mobilizing the subscap.
We actually can't see the release very well. We didn't see you releasing the MGHL portion very well.
If
So
we switch maybe to this side, you might get a better view. I'll take the Batman retractor, which is here.
yeah,
Maybe
that's better.
Give me a second.
That's better.
We've got a great view now.
Okay.
Yeah, you carry on.
So we're going to switch this to here. So you're gently going to hold on to that. I'll pass this here. And so now what I'm going to do is I'm just going to quickly do my releases, excise this tissue, and then we're going to keep on moving because I've been told I got an hour to get this done. We're going to start motoring. So here's the anterior tissue. There we go. We'll pass that back. And now what I'm going to do is take this small DARA and I'm going to work underneath the glenoid. Right down here. And I'm going to push these tissues down like so I can get right on the inferior rim of the glenoid. So I'm trying to protect my axis. There we go. I'm going to try to get this stuff off. Roger, please.
Your posterior extent of your release, would it be 530?
Yeah, I'm pretty much at the bottom part right now.
Yeah.
This is at 6 o'clock. I'm just trying to get underneath it. And there I go. I think I got underneath it now. Right like so. Good. Now I'm going to reposition this retractor gently right down to the bottom, right like that. Okay, so we're getting there. And I'm going to excise a little more of this labrum. And then we're going to start by reconstructing the glenoid soon.
There's a nice presentation of yours where you talk about the arm position when you're doing your glenoid releases.
Yes.
So is it now in a bit of adduction and extension?
It's in actually external rotation. I would normally when I position, I have a spider which helps me. In this case, I don't. I have some wonderful assistants. They're great, but it's just not something I'm used to doing. So it's a little bit different than my typical positioning. So there I am. I'm at the bottom part. So we found the axillary nerve. It's right down there. I'll take the small DARA. So here we are, right there. I'm underneath the glenoid. All the way around. Can you see that? Okay, so there we are.
You can see it really well.
Okay, I'll take the Robin retractor now, right here. And so we're at so now you can see it at the bottom. Okay, so now what I'm going to do is I want to adjust this position to that. Great, so we're going to be ready to, I'll take a curette. We can take that out. Do you have a curette? So here's the bone. It's a little, not much, just a little bit of fibrocartilage on it, but that's all I'm going to do, not more than that. Now I'll take the large rongeur, please. The large rongeur, and we're going to get ready to put the glenoid in. So I'm going to go ahead and just remove a little bit of this lip right here, which I plan to remove. And excellent. And so the next step for me is to take that little ruler that we had. Remember that ruler I made? Oh yes, yeah. And I'll take the mark. So we templated about 15 millimeters our start point. So right about here. All right, so I'll take the 25 millimeter guide, please. So here's the guide. I'm going to put it right down at the bottom. I'm going to lift it off about 8 millimeters and put a guide pin in. I'll take the guide pin. Okay, and then we're going to get ready to ream. We'll open up a 25 full wedge with a 30 millimeter central screw, please. We can open that up. So that's what I'm going to ream right there. And let's see where my positioning is. I'm a little bit higher. Let's go a little bit lower. I think I'm going to like that. Let's do that. All right, so our guide pin's in. All right. And just a little bit like that. Perfect, and we'll get started. Reamer, please. We can open up that base plate if we haven't. So here's the reamer that we're going to use. It's going to be about 15 degrees off axis. I'm going to come in, and now what I'm going to have to do is I'm going to preferentially ream till I get 60% seating, so you can see that the superior aspect of the reamer is off bone. So we're going to have to start reaming to get 60%. Ooh, that's a drill function. How do we switch that to ream? There we go. Let's just see, that's maybe 50%. We'll do a little bit more. So we're starting to get around. So let's take a look. Got all around the bottom. So we're up here. So we're probably, this would be 50% here. Let's do a little bit more. That's okay, just nice. I think that's what we're going to aim for. Good. And we'll bone graft the top. Okay, so now I'm just going to go ahead and drill my central boss hole. Oh, now it needs to be a ream. How do you switch that, please? Let's just test it before we do it. That's good. All right. Okay. Great. So now we'll take this pin out. I'll take a wet sponge, please. So here's our drill guide. So I'm going to put that in first. And you can see by putting that in, there's only about a 3 millimeter distance here. And that's what I measured on my preoperative plan. So we're going to be able to put a tiny little bone there. And so I measured about a 25-30 screw. So there, that's it right there. Excellent. So now we're going to take the implant, please. Oh, thank you. And so now we're going to go ahead and put in our implant. I think we're just opening it up on the side table. And
George,
then after that, yes?
What's the maximum wedge that you can have with this
So
implant?
on this, the maximum wedge is 15 degrees. And so then the rest, either you can ream more, and that's why I kind of selected halfway in between here. So how's the implant coming? We'll open up a 39 millimeter sphere, please. .39 eccentric. Great, so here's our implant. Right there. And I'm just going to reposition you just gently, just like that. Nothing more like that. And so we're going to go ahead and get it started like that. There it goes in. Now I'm going to stop a little bit proud. So I'm going to stop right there. So everyone don't move. We'll take that bone graft and I'll take a rongeur. So let's see if we can get this to work for us. Oh, thank you. So I'm just doing a little bit of bone graft prep. It's not very exciting. There we go. So it doesn't need to be too big. Oh, that's good. I think we'll take that little bit of cement out. That's all we need. It's not very big. Okay. And I will take, I'm going to put that right there, and I'll take some pickups, please. We have a little bit of a yard sale going on here. There we go. So let's put this right back there. And I'll take the bone punch. Oh, it's going to be perfect. Look at that. So now I'm not going to, there we go. Okay, so the bone graft's in, which arguably you have to question whether or not we need it. So now I'm going to go ahead and seat the implant. There we go. Okay, so let me get, do you have a septal or something that I could check to see if it's seated? It looks very good. Okay, I'll take a mallet, please. And now we're going to go ahead and put some screws in. Excellent, thank you. All right, let's put some screws in. Let's start drilling. Here's the drill. We'll load up a 22 screw. I typically use that for superior. I don't like too much of a large screw superior. All right, so I always drill the bottom first. Is this going to work? There we go, okay. I'm just going to peek my head in to see. Oh wow, nice long screw.
Did you angulate a bit or just a bit for the pillar?
You know, I honestly go almost straight in, just a little bit off axis.
Yeah.
Not much. Wow, let's go 40. And now this one's going to be a small little one, just a 22. Because we have such great purchase with that central screw. I don't need anything more than that. There we go. I'll take those on power, please. And then we'll open up the sphere.
39 eccentric?
Pardon me?
39 eccentric.
No, 39 lateralized. Pardon?
We go with the implant?
Yeah, we can open it up, yeah. I'll take the screws though, please.
39, 3 of 6?
Plus 3, yes. So I'll need the screwdriver. Do you have the power screwdriver? Or any screwdriver? And so arguably, I mean, we could have used allograft here, but it's really nice to get that autograft from the tuberosity. I find if I can get it from there, that's usually pretty good. Oh, no power? Okay. What size is this one?
22.
Okay, I'll take the larger one first, inferior.
George, this is a revision scenario.
Yes.
A fracture sequela. So the exposure is
40, please. 40. I'm sorry, we're just getting the screws organized. 40 screw, 4P. I'll take 38. I'm sorry, what was the question again?
The question is that here the exposure is very well done and we can visualize very well with just 2 retractors. In a routine case of arthritis, what are your retractors on the glenoid? What is the typical?
This is pretty much what I do. I have a straight Dara retractor posteriorly.
Okay.
And then I have a Batman anteriorly. If I'm having really difficult, then I'll put a Robin or a small
Inferior.
bank cart superiorly. I'll show you.
Okay.
Do we have the small bank cart? Here. So then sometimes if I need to, I can put this up here to get a little bit of a better view, but I'll put that behind. But in this case, we don't need to. I'll take the second screw, please. This is oh, wow, nice, look at that. I got it on power now. So this is a nice small screw. We don't need anything too long here. All right, I'll take the screwdriver now, and we'll tension these down, and I'll put our sphere. So we get the sphere loaded up, please. So we're gonna tighten these down. Not too hard, there we go. We'll do this top one. And I always take another shot at this central screw here just to make sure to see if it's well seated. And we're just gonna see if we can get a turn on it. And that is rock solid, great. So, wow, that's very good. All right, let's get a sphere in there. We'll use this here. So we can come out with that. Let me just see for just a moment if we can get access. Let me see this for a second.
So there is no need to use the other two screw holes because of the purchase?
I don't think so. I think we're going to be able to get a glenosphere on here. So you're going to hold it just like that, counterclockwise. Perfect, just a little bit, perfect. And suck down to the bottom. And I'll take the sphere, please. And then we'll get onto the humerus, which is going to be more fun. Oh, we can open that, yeah. And so so what I did here is I just used the Dara retractor to put a little twist on it. And I'm going to hopefully get it in. If I can't, then I can use this retractor that has a little bit more of an offset. But let me see if I can reposition this again. I'll take that. I'm just going to move you a little bit lower. I'll hold this just nice and relaxed. Just gently like that. Perfect. So you're going to rotate, rotate, rotate to just like that. That's good. No more. Ooh, that's good. Just like that. Oh, there we go. Here's our sphere. So we're going to give this a shot to get in. Going to come up over, go under. And you can relax now. Just relax. Just let go. There's our spheres on. So what we're going to do is impact it now. There's our impactor and a mallet. Merci. All right. Now we got a safety screw here, so we're going to set the safety screw. And then we're going to move on to the humerus. Oof. That is good. All right, so we'll take that out. This stays in. This can gently come out. Now I'm going to take that brown retractor, and let's just get a sense of the tension here. So I think it's probably going to be a 0. So I'll take the brown retractor, which is the round one. Oh, here it is. So now this is where I'm going to be very careful to dislocate because I do not want to fracture the tuberosity. So with this, you're going to hold this differently. You're going to pull this towards you. All right, this can come out. I'll take the medium Dara. This is going to come here, and very gently, we're going to get that out. Okay, we'll move this out of the way, please. And let's not dislocate just yet. I need to slide in there just a little bit. All right. I just need to get in there. Thank you. All right. I mean, very so nice. I'll hold it. It's okay. This is where I'm always nervous about fracturing the tuberosity. Okay, there. We came out. Excellent. Okay, good. So now I'll take the Batman retractor. I'm going to put this right here to see. And now we're going to take the burr. I'll take some suction. Good. Now we're going to try to take this thing out. Actually, let's take the saw first. And so with this saw, we're going to try to break up a little bit of this mantle. I'm just trying to, I'll use this to start off with. Do you have a longer blade?
Yeah.
Same things, but longer. And that'll help me break up. not going to leave her. Good. We're just going to give that. Now, what I'd like to do is very, very carefully, you're just going to move this just like that. I'm going to get a little closer. We can suck back there. I'll take a rongeur, please. So I've gotten the anterior portion and probably the lateral. And I'm just going to very carefully take a little bit of this bone off here to get me access to the back. There we go. And I'll take that again. Got here. All right, now we're going to take a little bit off here because I'm going to need to find a place to hit it. Rongeur, please. So can we get the extractor for this setup, please? There should be an extractor instrument. All right. So this is the extractor. All right. So here's the extractor device. Let's try this first. I've not used this. But let's see, this goes. There we go. All right, fingers crossed. All right, so the first thing I'm going to do is I'll use a mallet. So we're going to very carefully hold the arm straight. I'm going to hit it in. I always like to hit it in first to try to break up the mantle. So we'll try that. So everyone's nice and safe. I'm going to hit it lightly. All right, let's do it again. All right, as we anticipate, it's not coming. So now we're going to take the burr. Yeah, I'll take this off and we'll go to the burr. And we'll try that again. All right, and can I get a little bit of irrigation just so we can see here? And I'm going to move this away. Okay. All right, and we'll suck in there. All right, I'll take the foot pedal. So we're just going to start working our way around again. Try to break up this cement mantle. And I'm also going to give myself an area to hit right here. Need a longer tip burr too to get in there. All right. Let me see the suction, please.
George, what's your threshold and when do you decide to do an episiotomy?
Yes, it's a very good question. I'm going to it's usually a time threshold. So okay. I'm going to keep on going here because I think there's a good chance we should be able to get this out.
Okay.
But if it goes past, where I've basically done everything I can to remove the cement here and it's still not coming out, then I'll probably extend the incision here and just get a saw to go right down to the mantle, but I'll put a cerclage wire around it first.
Right.
I'm hoping that we don't have to do that. I'm just going to get these fins right here. I mean, feel free to ask me questions. This is all right, we'll take some irrigation, please. We'll take some irrigation. Yeah. And good head, yeah, get it right in there. I'll take that. All right, so we're going to give this a little bit more, and then I'm going to try to hit it. I'm feeling good. All right, should we try hitting it? All right, so we're gonna hit this a little bit differently now. So I'm gonna get you to turn it just like that, and I'll take the mallet. So we'll just try to give it a little hit here now. Ooh, that's not moving. All right, I don't think that's moving for us. All right, let's put the inserter again. All right, and we'll try that all again. And we're just gonna keep on doing this. And
George, do you have any pre-op predictive sort of things that you look on an X-ray which tell you this is something I'm going to have to do a osteotomy on primarily, or do you always follow
Yes.
this stepwise approach?
It all depends on the implant. So say if you have a press fit implant that's been cemented in, those I'm pretty sure I'm gonna have to do an episiotomy. All right, so here we go. Let's try it again. So you're gonna support the elbow and push up. All righty. All right. Can we have something? Yeah, we'll try that. But I'd like something that gives me a little bit more force.
Is it better to do this before glenoid?
For me, no, definitely not, because look at the bone that I've removed here. And so what happens to me is that if I take the stem out and then do the glenoid, there's always risk of fracturing here because I'm levering on this hollow stem. And even if I put a trial implant in, say I take this out first and then put a trial implant in, there's usually still gaps here. And so the proximal humerus is weaker. So I've been much happier doing this after. Oh, something's coming.
Excellent.
All right.
Excellent.
Okay, let's get, so here's our cement mantle. We'll get ready with our number 2 stem, please. And can we open up some cement also? We're going to be cementing it.
George, there was a round of applause here in the auditorium when that stem came out.
Thank you. All right, let's get a burr. And we're going to open this up a little bit more. I'm just going to open this up, and then we're going to try to put the stem in right now, just to open that up a little bit wider. All right, let's get some irrigation, please. And I'll take the trial, please. All right. This is a size 2 long. All right, that goes down. Let's go this way. I think we're going to have to expand it a little bit because this is in anti-version. Let me see the 1 long. It's okay, I can do it. So, let's see how that's going to go down. Ooh, that might be good. So I can see I have to expand a little bit more here. I'll take the mallet. Yeah, so let's take the burr, and I think there's a good chance we're going to cement in that 1 long stem. Or it's not really long, it's really 130, so traditional length. So I got to expand here, and then if we can open up the cement, please. We will not need a cement restrictor. And believe it or not, we might actually need a new burr. Irrigation, please.
So George, with the destroyed proximal humerus anatomy, how do you know for sure regarding your height of your prosthesis?
Yeah, so basically what I did is, once I put the glenoid in, I got an assessment of the tension.
Yes.
And I should have showed you that a little bit more detail. It's just basically the distance between the native stem and the glenoid. If there's contact, it usually means it's going to be a 0 for me, like a 0 polyethylene.
Okay.
We're going to go ahead and put that trial in right now. We'll take that again. Thank you. So here's our trial. We'll put that in. Good. It's going in a little bit further. I think I got to do a little bit more anteriorly here. I don't want to force it too much.
This is the smallest trial?
Pardon me?
This is the smallest trial?
Yes, this is a size 1.
Okay.
And so we're just going to open this area up here where the fin would sit. And this will definitely be, he still has a lot of good cancellous bone proximally. So I think a cement in cement revision is going to be fine. All right, let's see how that sits down. Oh, we're getting further and further. Let's see, where is that being held up? Stuck in there, please.
With respect to version, what's your preference?
So in here, I'm going to aim, so this would be neutral. I'm probably going to put it in maybe 10 or 15 degrees and just match the cut that Ashish made previously, which is actually very good. So I'm not going to change it too much. We'll get some more burr, please. Do we have a more aggressive burr that takes a little bit more cement away? If not, that's okay. We're just going to take a little bit more of the cement away, because I want to be very careful in that, because this humerus is quite osteopenic up here. When I'm doing my reduction, that's where I'm greatest risk of fracturing, and I don't want to do that. My number one complication with revisions is greater tuberosity fracture, and now I'm very happy that we've got everything done well. Ooh, just get nice and easy there. Oh, sorry. Let's just right like that. Perfect. Good, good. And the last thing I want to do is fracture anything. Oh, good. So that's getting down further. We could try a reduction here. Let's get the mallet, please. So this is going to be cemented a little bit high, but okay, now we're going to get you to support the elbow. Push up. We can take this out. So push up on the elbow. And I'm just going to bang this down. Okay, we'll get ready with a 0 poly. We'll just give this a little hit.
Is the trial and the final stem size to size, or is there a...
No, there's a press fit with the final stem.
Okay.
All right, so let's take a 0 poly. So this is a 39, no, I'll take a symmetric poly, please. And so what I can see here is that here's the greater tuberosity, so I'm sitting a little bit proud. But I'm just going to do this to get an estimate of where I am. Because if I'm loose, then I'm going to have to cement the stem a little bit high. So symmetric 39, perfect, good. So here we have our symmetric 39. We'll put this right like so. All right, everyone out of the water. Okay, that can come out gently like this. Good, you're going to hold on to the subscap. I'm going to slide over here, please. Can you put your hand right here to support the neck? He can do it there, so that I don't want to pull the patient off. You're going to hold on to the subscap. So we got the subscap in control. We here, I make the deltoid real nice and relaxed. Now we're going to pop this in. Okay, long skinny, please. That's this thing right here. Okay, so with that, I'm actually pretty happy with that tension. I'm going to put some support on the coracoid, pull down, and that's actually pretty good. So I think what we're going to do is we're going to cement this stem in this position. Based on this, we'll probably I'm going to use a retentive poly, but I'll take the dislocator right here. So I'm going to have to seat this down a little bit further. So I'll grab that, thank you. So we're just going to very carefully dislocate, bring this to the front. All right, take the brown retractor again. We'll put all our retractors very carefully back in. So I'm just going to put this very carefully right like so. I'll take the medium Dara, so no twisting. Yeah. All right, so let's put this here.
George, you were happy with the soft tissue tension.
Yes.
Can you tell us some of the factors that you were looking at when you assessed that?
Yeah, so this is still the trial, so I'm not at the final stages yet, but I will be. But basically, I'm looking for the overall quality of the reduction, how easy the reduction occurs, and how much gapping I have between the polyethylene and the glenosphere. So let's go ahead and take the extractor, please. And so we can open up that number 1 long stem. But before I do that, let's get a ruler. Let's just measure our height here. So we're confident that we can recreate this. And I'm going to go ahead and take a little bit more bone away, and then we're cementing, and then I will use a retentive polyethylene here. So the one thing I did do is I did a trial reduction with a symmetric poly, and with this system, you can switch from 135, this is a 135 monoblock stem, to a 145 poly, which I don't think we have right now. And so by switching, in most cases when you change the neck shaft angle, you increase distalization and lateralization. Here, it stays the same. So we're just increasing the lip to give us more capture without changing the tension relationship. All right, can I get that ruler again that we had? I'll take that, thank you. So let's take a measurement here. So from the lesser tuberosity, right there, we're sitting, what is that, 5 millimeters? Oh, it looks like 7, 8. Oh, let's go. We dropped that. Let's do that again. So maybe 6. I'd say 6 to 7 millimeters. All right. So now we're very carefully going to take this out. All right. I'll take the burr and plant open. And actually, and what I'm also going to need is number 5 ethibonds because we're going to fix this subscap. How much time do I have left?
You've got 15 minutes.
Oh, good, no problem. We'll get it done. All right. And so in this case, we're really going to make an effort to fix that subscap. Let's wash that out. You guys wash and suck. Good. Let me get that trial again. Can I get the trial, please? And let's see if that goes down a little bit further. I'll take the inserter for this. And we can open up the cement. We can open up the stem. We'll hold on the polyethylene. Good. That goes down further. Great. So now I'll take a snap, or I'll take an artery, and I'll take the number 5 ethibonds, and we're going to repair our subscap. Okay. And does someone have a free hand? You're going to burn for me. So where's the cautery? There we go. And so you just burn on me, okay? So we'll go here. Yeah, go ahead. I'll do something. 1 second. Okay, let's try that. Go ahead. Anywhere. Here, you. Yeah. Hard. Do we have a stronger needle driver? There we go. This one's bending.
So George, this is a revision scenario, so obviously you're worried about dislocation, instability, you're making sure the subscap is well repaired.
Yes.
What's your take on a primary arthroplasty?
Oh.
You always repair your subscaps?
Absolutely. I think it's very important, and also it helps. Philippe Collin has shown us very well that it helps with internal rotation. So I definitely repair the subscap. In this revision scenario, I'm also going to use a higher neck shaft angle, so I'm going to be using, I'll take more ethibonds, please. We'll have those loaded up, ready to go. And so I'm going to use a retentive polyethylene at a 145. Great, and we'll have the next one after that. We're not going to mix just yet because I just want to give it a clean. We're not going to open up the poly just yet. We'll probably do a trial reduction, but it's probably going to be a 0, 10-degree retentive polyethylene. Okay. All right, we'll take the last one, please. And then we're going to wash this. And we have the implant ready. Good, all right. I think we can just start mixing the cement. What do you think? Should we start mixing? I'll take some wash, please, and we're going to wash this out. And we can start mixing cement, please. There we go. All right. So, and I'll need a long sucker handle, and start mixing, please. There we go. All right. And so we'll do this. So we can, yep, we'll start mixing. Yep, definitely mix. So what do you have to insert the cement? Do we have a narrower section?
Metallic section.
It's a little bit messy here. And a fresh sponge, metallic suction. So we're just going to give this a clean. Yeah, do we have a metallic, something where I could suck down there? Because there's, what do you would normally use? Sorry, we're just going to get a better suction device. Great, excellent. So definitely one thing that I've learned is I typically will always go to a retentive polyethylene now.
For all your revisions?
Yes, just the rate of instability, and so I really want to avoid that.
And your treatment for your subscap is always peel off.
Yes, that's all. Typically I'll do a peel off also. And we can load up that too. Good. All right. And do we have the cement in an inserter? What are you gonna? Do we have a? What do you put the cement in with? All right. I guess we don't, so we'll do this. All right. So I'll take the cement then, if that's how you do it. That's okay. We'll do this. And I'll take a Raytech.
George, when you're revising a cemented humeral stem...
Do you have a... Sorry, just give me a moment
no
here.
Problem.
We don't have any cement injection guns, so it's something I'm just not familiar with. We're just going to do things a little bit differently.
Okay.
Normally I would use an injection gun. Yeah, do we have a syringe to put it in? Sorry, so this is just a little bit, I'm not used to this, but we have to get going. So let's put this in here. Is this normally how a sheesh does it? So I'm going to try to get some cement down there manually. Sorry about that. There we go. Let's get it right down in there. We got the implant ready to go, right? Good. This is actually working. Okay. We're going to keep these separated. So I think back home, normally what I would use is just a cement gun, but this is okay. This is going to work. Okay, we keep these like that. Excellent. Okay. So I'll take a snap, please. A hemostat. All right, great. So what I'm going to get you to do is just going to hold this. You can hold this. So you're just going to put the tip in like that. Disconnect the sutures. Hold that up nice and high like that. And then we're going to go secure the sutures around the implant. There we go. We're going to... Oh yeah, that's okay. It's around, right? It doesn't want to come down. There it goes. We'll snap these, and we'll take a mallet in a moment. All right. And I'll take a septal to get some cement away. A septal, please, or anything like to get the cement. And so you're going to hold this like that, and we're going to go at retroversion about 10 degrees. Good. And we're going to need our ruler again. Sorry, we're just going to get a little bit of cement out of the way. Good. And a mallet, please. All right, so you're going to push up. Ready? So let's go about there. And let's get our... I'm going to take this off very carefully. Can I get something to remove the cement, please? Just like a small scalpel would be fine. Something that I can use to... Like a septal... Do we have any? And some pickups, please. And I'm going to need some pickups, please. Great. All right. So here I'm going to pass this cement back. Okay. I'll pass that back. And I'll take that ruler that we had. Oh, perfect. Good. Let's measure that. Yep, pretty much the same. Excellent. Excellent. Okay. So we'll wait for this to harden now. All right, I'll pass that back.
George, taking this opportunity,
yes,
in a fracture scenario and you're doing an RSA, what's your landmarks to decide about the height of the prosthesis?
Excellent. So there's several landmarks I use. I don't typically use the insertion of the pec major. The reason is that 5.6 centimeters is different. So if you have a 6'6" or like a 200 meter tall person versus a 150 meter, it's variable. So I tend not to use the pec major. What I use is I reduce the greater tuberosity to the shaft, and what I'm aiming for is that the lateral portion of the implant right here to be essentially parallel to the greater tuberosity. So that's what I use. I typically use the greater tuberosity. The other thing that you could also use is the overall tension. So you can put the trial in and reduce it, even with the tuberosity off, and get an assessment of how much pistoning there is in the implant to get your correct height. So I typically try to use the tuberosity though.
So you measure the length of the tuberosity also in order to make sure that the...
If it's comminuted, then I'll measure it preoperatively.
Correct.
Other than that, I just reduce it to the shaft.
Okay, okay.
All right, we'll just hold this in there.
Nagaraj, may I?
Yes, Navid.
Yeah, so my question is regarding the decision making in this patient. So he was operated in 2010 with a hemiarthroplasty. He comes 13 years, 14 years later just for a routine follow-up. He has no pain, his range of motion is full. So on the basis of this X-ray, we decide to operate. So could we have waited? How did we convince this patient to get a surgery done?
You'll have to talk to Ashish. It's his patient. I believe it was because he was having pain and superior glenoid erosion, but you're going to have to ask Dr. Bulbakar. I'm the visitor here.
I think the main indication here is pain.
Yeah.
Pain's the main indication. His range and function seems okay, but I think pain is probably the main indication.
I think predominantly the issue is pain. How's our cement doing? We still got a little soft cement here. And then we'll give it a trial. So the first polyethylene I'll take will be that 039, the first one. All right, and typically I find with my revisions, I like to place them in a little bit tighter than my primaries. The reason is, post-operatively, the number one complication with revision to reverse is instability. If you look at the literature, it's anywhere from 15 to 30% rate of instability after arthroplasty.
Right. So we'll try to prick your brain more on this, George, because little bit more is a very subjective term. So try to understand what's going on in your mind. So when you place your trial, what do you tell your anesthetist in terms of the amount of relaxation that you want when you want to do your reduction, in terms of the relationship of the trial to the glenosphere? So what is going on in your mind when you do this trial?
Very good. So essentially, each implant has a different, volume within the humerus, within the shoulder. And so the implant that I use, I'm familiar with that volume. And what that volume is can I get a trial and a glenosphere trial and a trial implant? I'll take that while we're waiting for the cement to harden. So I'm not sure if you can see this down here on the patient.
We can.
All right. So imagine this is the glenosphere here, and here's the trial, or the cut surface of the humerus. So with this implant, this is when I have the trial in, or without the trial, just the cut, if it's contacting the glenosphere when I reduce it, that's going to be usually a 0 poly. So if it's tight like this, it's a 0 poly. If I can get my finger barely into it, then I know it's a +3, and then if it's loose, then I know it's a +6 or a spacer. So I just get an assessment of how tight it is without the true implants in there.
Okay.
I'm not sure if that makes sense. The other thing I do is I assess the quality of the reduction, how difficult or how easy it is to reduce, and then once it's reduced, I'll show you what I do. We're going to do another reduction here, just because I think this may have gone in a little bit deeper, which is okay. How's our cement now? 2 minutes on the cement. Okay. How much time do we left have on the broadcast?
George, go ahead. We'd like to see that prosthesis.
Oh, okay, good. All right. So it's still a little bit soft here. And do we have any vancomycin powder? Once I'm done, I'd like to put some vancomycin in. I'm not sure if that's okay to do.
1 gram?
Yes, I just put a powder in.
Would you put in a drain?
I typically do not use a drain. It's very rare for me to use a drain. Sometimes if I'm operating on someone that's still on aspirin, I'll consider a drain, but very rarely. I'd say probably about 50% or 40 to 50% of my arthroplasties now are outpatients, so they go home the same day. They have the operation done, they go home, so it's really not conducive to a drain.
George, one more question. So
Yeah.
when you're revising a cemented humeral stem, when do you decide to use an uncemented stem?
Yes, for if I'm revising a cemented humerus?
Yeah.
Yeah. So some people tend to do a distal cement mantle. If this bone up here there was no cement in the bone up here, I would consider using a press fit. But because there was cement up here, I don't think there's any great potential for bone on growth, and so that's why I'd switch to the cemented stem. So I have to see a potential for bone on growth onto the stem for me to use a press fit.
Now, if you could take out all that cement, you still think that it's not worth doing uncemented?
If I do take off all the cement, the one thing when you use a press fit is if you do a press fit after a cemented stem, the bone in the proximal humerus can be a little bit more brittle, a little bit softer. So I'm always worried about fracturing when I put a press fit stem in. The second thing is that in a cemented scenario, most cemented stems are cylindrical or straight. And a lot of press fit stems are wedge-shaped. And so I'm also concerned about putting a wedge-shaped stem after cylindrical, because if you can see in the stem that we removed here, they're most of the old traditional stems that are made for cemented application are very cylindrical. And so the other worry I have is that if I do take the cement mantle out, typically with a press fit, most of my fixation is going to be distal, and then I'm going to be worried about stress shielding. So I like cement. Cement is my friend. It helps me get out of trouble. I love press fit, but certainly in this revision indication for this patient, I think cement is the right answer. Would you do a press fit here?
No, absolutely not.
All right, that cement looks good. Let's get the poly. All right. All right, I'll take the trial, and let's try the reduction. So here's our 0 polyethylene. All right, everyone out of the water. Carefully, good. You're gonna grab the subscap. Thank you, my friend. You're gonna stabilize the neck right here. So I like to stabilize the neck so the neck doesn't get pulled off. I'm gonna grab this and just pop it in. All right, that feels really quite good. Long, skinny, please. It's the retractor. It's a Richardson retractor.
So with respect to your ease of reduction, are you okay with this much amount of ease?
Sorry, we're just looking for some retractors here. Yeah, this is a little bit too easy. So it's a right angle retractor that we've been using. Nope, it's the. Sorry, give us a moment. We can use this, I guess. We'll just use this. So we're just going to show you what we're doing here. So that reduction was a little bit easy, but the other thing is I'm going to be using a retentive polyethylene. Yeah, that's it right there. Perfect, thank you. Let's switch to this. So a couple things, and I'll take some pickups. So this is just a standard polyethylene. It's symmetric at 135. For my true polyethylene, I'm going to open up a 145, so it's going to have more capture, and I'm going to use retentive. So it's going to be much more stable than my trial polyethylene. So I only want to put it on at the end, so I just have to reduce it. I don't want to do a trial reduction with it because it's hard to dislocate, hard to reduce, hard to dislocate. So let's check what our tension is. So I'm going to put my thumb on the coracoid. The reason I want to do that, I don't want to pull the patient off of the bed. So I'm going to put my thumb on the coracoid and pull down. And I see no gapping. So what I'm looking for when I pull down is a gap between the polyethylene and the glenosphere. If I see a gap there when I pull down hard, I'm concerned in a revision and I want to upsize it. In this case, I don't see a gap. So I think what we're going to do, we're going to open up a 0, 39 millimeter polyethylene, 10-degree lip retentive.
Do you assess range at any point of time?
Pardon me?
Do you assess the range at any point of time?
I very rarely assess the range until everything's in.
What about the conjoint tendon tension and the deltoid tension?
I don't look at that. So some people like to look at the conjoint tendon tension. That's not a normal part of my protocol. So for me, it's very difficult to assess. So I just don't do that. I assess the implant tension. So the tension of the implant is indirectly related to the tension in all the soft tissues. So I personally don't see it necessary to assess deltoid, conjoint, and implant. For me, I just go right to the implant because the implant tension is what's going to decide stability. My number one problem with revisions is instability. So if the implant is loose and the conjoint is tight, I'm probably going to put in a thicker polyethylene. So for me, it's most important about the implant. So you're going to hold on to that. And another way to assess it is how easy it dislocates. I can hold this. So I'm just going to put this device in. Right? That's actually pretty good. And it's not too easy, but it's not too hard. So it's enough that I feel comfortable, especially if we're going to be using the retentive polyethylene. So when I put this device in, and then I'm going to rotate the humerus out, all right, and we'll take all our retractors again. We'll take the brown retractor and put the brown in here. So we'll use the same retractors again, the same ones. We'll get the brown one.
So you have a retentive poly in all the designs, in all the options, or only with the 145?
I'm sorry, can you say that again, please?
The retentive poly is an option for all the sizes, or is it only for the 140 with the 145 angulation?
No, it's for all of the sizes. And so then I'll take the brown again. All right, so you're going to put this right here. All right, let's get that poly on and get closed and get out of here. All right, I'll take the true polyethylene, please. Yeah, so the retentive is with all the designs. Here's our polyethylene. So it's a retentive polyethylene. And there you can see that it's angled at an extra 10 degrees. So we're going to go ahead and engage that. Where is it? Right there. There it is. And so you're going to push against me. Okay, inserter for the poly. Great. And you're going to push this, and I'll bring this down. So we'll bring the poly down nicely. There's our polyethylene down. And so now let's go ahead and reduce. So everything, we repeat everything again. So we support the neck. We pull on the subscap. I bring the deltoid in. And now this is going to be harder to get in. See how much harder it is? And I haven't changed anything.
Yes.
The length and the lateralization is exactly the same, but now it's going to be harder to reduce. So what we're going to do is I don't want to hurt my fingers because I want to have some good Indian food tonight. I'm just going to very gently lever it in. There it goes. All right. So we'll take this again. So now this does not change at all my relationship. The length and the lateralization is exactly the same as a trial. So now we can go ahead. I'm just going to move this around. We can keep that in there. See if there's any impingement. All right. Okay. Watch up. All right. And I like that. All right. Let's close this subscap. So we're going to come in now, and we're going to start closing the subscap. So I'll need a needle driver. Okay. So let's quickly do this. I'll take the brown retractor, please. I'll put this back in. There we go. And I'm going to externally rotate a little bit to make it easier. So I'll take some pickups. So here's our 3 medial sutures, which should have needles attached to them. Right there. So I'm going to pass these over.
George, we're going to have to get to the next
No
OR.
problem. Yeah, we're just going to close the subscap.
Perfect.
If you'd like, I could show you my first stitch in the subscap.
Perfect. So let's see that. Let's see you take that first stitch, and then we'll shift to the opposite OR.
So we're just going to move this. You hold this. So here's our subscap. We're going to get a nice repair of that. So I'm just going to go a modified Mason Allen like this. Through. And then we're just going to do this 3 times, 1 for the middle, 1 for the superior deltoid, 1 for the middle subscap, 1 for the superior, 1 for the inferior. So there's our first stitch. We pass this off. We'll do that after. And I'll snap this, please. So we snap this. Put an artery on here, please. And then we throw this off the top. Free needle down. And then I'm just going to keep on doing that. So I'll take the second one. like this.
Rotate the interval, you're going to make sure that it's closed well.
Well, I'll do that depending on if I need to. In this case, it may be beneficial. Like many times the supraspinatus is absent.
Yes.
So if the supraspinatus is absent, there's no interval to close. And the last thing we're going to do right here is we're also going to put some vancomycin powder on. So there's our Mason Allen. So I'm going to come through here, pop that up, pass this over the top, pull this, snap this. Please snap that, needle down, and we're doing the last one.
One question, does the change of inclination from 135 to 145, does it increase the risk of notching in any way?
It does if you have a medialized glenoid. And in this case, we used an augment, we did bone grafting, and I used a lateralized sphere. So the chance of notching, although present, is very low because of my sphere option and my glenoid option. So I was prepared for that, and that's why I chose to use the lateralized sphere. So if it's interesting, with this, we still did a 0 polyethylene, so I'm actually quite happy with that. So now we're going to go ahead and tie, needle down.
He's used the +3 on the
And so now we'll just do a little internal rotation, and there's our subscap's going to come over very nicely. So pull that. So here's my subscap.
George, that looks absolutely fabulous. You've done a great job. Really quick too.
Big round of applause.
There's a lot of applause here in the auditorium. Thank you very much. Do you have any closing statements, George, before we shift the
No,
OR?
it's just an absolute wonderful to be here. And I'd like to thank my assistants who did a wonderful job, and the anesthesia team, and the cameraman who was actually wonderful. Thank you, and we'll see you in a few minutes.
Thank you, George.
Thank you, George.
For the final case today, we have a 46-year-old male gentleman, complaints of right shoulder dislocation, 10 to 12 episodes. All were self-reduced. First episode was 5 years back. Last episode, 6 months back. History of sleep dislocation, 4 times. No history of seizure or other comorbidities. Modified Rowe score was noticed to be 40. On examination, AROM, on the right side, it was 180, 45, and D12. Cuff strength were all found to be 5 on 12. Axillary sensations were intact. No neurovascular deficits. Going into his test, anterior apprehension was found to be positive. Crank jobs was noted to be positive. Mid-range instability was also grossly positive. Posterior apprehension was negative. Jerk test negative. Crank jobs for slap was negative, and O'Brien was found to be positive. X-ray, you can see a Hill Sachs. Going into the CT, the MRI, T2 axial shows a Bankart tear with Hill Sachs, along with posterior labral tear and a small paralateral cyst in the spinoglenoid notch. T2 coronal showed cuff to be intact with small paralabral cyst. And finally, T2 sag, showing the anterior labrum along with posterior labral looks torn. Now going over to Dr. Ashish Babulkar for the planning.
Hello. Hello.
Yes.
Ashish, we see you.
Hi. Okay. So we took a little head start, but that was absolutely fascinating surgery by George Atwal. I was just distracted.
Sir, sorry to interrupt, Anandya. Sir, you have those planning slides.
Yes. So I'll just talk you through this planning. Thanks to Akuna, they've done this. So Ashish Gupta wanted me to share this with you. If you look here, they have calculated almost 18% glenoid bone loss, ideal indication. And on the figure on the right, you can see that, the figure on the right, you can see that this is a 9 mm thick graft. And on the width, on the top, along with the graft is about 27. On the bottom is 27.6. So let's say 28. And I'll take a +2. So I've decided to take a 30 screw, fully having faith in this planning. And that was our calculation as well. So 2 4 mm screws should be doable. It looks like a good length coracoid. It's very important to do a CT scan before. You don't want to come in and see that the coracoid is fractured. So that's being that. We'll come back into the joint now. Can we have a arthroscopy picture relayed? So yeah, this is a playback. So this is a fast scrub playback. What we're doing is just clearing up the rotator interval there just above the subscap. And I'm trying to preserve the labrum, so I've just resected the labrum from the glenoid side, and I've pushed it down, and now I have parked it posteriorly on a looped Ethelon suture. Once having done that, then clear the rotator interval there, as you see, trying to preserve the MGHL as best as I can, and trying to keep my sharp end of the radio frequency away from the subscap. And there I can start feeling the coracoid now. Lot of tissue there in the interval. And as we carefully proceed, then you can see the CA ligament is slowly coming into view. So on the top 12 o'clock, 11 o'clock position, that's our CA ligament. So that will come off eventually, but this is the undersurface of the coracoid. So I've done this and exposed that part, and this is part of the fascia.
Ashish, tell us something about your portals that you've taken till now.
Yes, so the portals is a E portal, which is the northeast portal, and then there's an I portal underneath the coracoid. Give me an artery or a, this camera. So here, so this is the E portal, this is the coracoid, this is the anterior end of the acromion, and no, we need the other camera, yes. So this is the anterior end of the acromion, this is the coracoid here, so this is the E portal. This is the I portal, which is pretty much in line with the coracoid. And so the D and the I, the E is in between those, but a little more lateral. And then I have an M portal here, which is far medial. This is the supramammary portal, but I've just made it cursorily. My inside rod, when it comes out, will dictate and will decide how accurate I've measured this. There will be a S portal coming in here over the coracoid. So let's go in here. I have freshened the coracoid and removed the tissues on the anterior end of the clavicle. So I've made a notch here, just like a fracture line starting to create a stress riser underneath the coracoid where my osteotomy will come through. And this is the entire undersurface of the coracoid. And then I have cleared the anterior glenoid here, as you can see, all the way here. So there's a little bit of a bump here which I'll need to flatten out. And this is to validate the 18% glenoid bone loss. I'll just show you there. Yeah. It's pretty much a straight line. The MGHL is still intact, and that's the inferior part. What you see here is the labrum. I have an Ethelon suture coming in here and is going here behind, parked there. Remove that gently. Yeah, it's parked there. So that being that, there's a posterior labrum tear which I'll address later after the main job is done. There's some cartilage loss here, and I have made a mark just there. So that is telling me which is the bottom line of my graft. I'll just show it to you in a better manner in a minute. Just there. Okay, so that's my mark there. So having come in here now, anteriorly, having cleared the CA ligament completely, and then we've cleaned up the top end. This is a rod that comes through to the D portal, lifts up and gives us a view. What you see is the swath, the sweep of the pec minor, which is attached. That's the promontory of the coracoid, so that should tell me where to take my first hole here. Because of the short coracoids in Indians, we need to be absolutely have precision accuracy on making our drill holes here, because if I make this too posterior, then I end up going there, and then my osteotomy will break through the beta hole. So I'll be careful today, but this coracoid looks a good length here, nice. So we will start now. This is the interval between the pec minor and the conjoint. So I'm going to do a pec minor resection here. Almost flush, that's your pec minor coming off. And so till the last fibers of the pec minor comes, it does not retract. It's important for it to retract so that it takes the tension of the brachial plexus and also allows me to go and check on the musculocutaneous, which is, again, as I said, obligatory. So this is the dangerous area here now because we are crossing medial to the coracoid. This is where we break all the rules. Okay, we'll clean up the medial wall. So we've exposed all 3 sides of the coracoid now, 4 sides actually. And then it's important to release the conjoint from the pec minor, otherwise it can cause some traction neuropathy of the musculocutaneous. It's not unknown after a Lataje purely because the releases were not done. Whether you did it arthroscopically or open, both ways. And that's why it's important to identify, as Jody Beer said, the musculocutaneous nerve enters about 3 centimeters distal to the tip of the coracoid. If it's any shorter, then the chances of musculocutaneous neuropathy are quite high. So we're trying to look for the musculocutaneous nerve now. Yeah, it's just here. And so use the back end of the radio frequency, not the working end of the radio frequency. The radial should be right behind. This is Basam's favorite territory actually. I have to be very careful here. Yeah, I'm okay. Okay, that's your musculocutaneous nerve here. Is that visible? Is that showing up? Yeah, so that's musculocutaneous. I've got that. Once I do this, I'm happy I know where it is, so I make a mental image of where it is and then freely do some releases. And that's enough. And then we come up here on this side of the conjoint, and then I bring my Wissinger from the top to bottom and then retract the conjoint like so to open up. And then come in here. So 3 sisters are angry. So we are on the sweep. This is the entire subscap. This is the upper border of the subscap. This is the anterior glenoid. And that's the muscular end of the subscap. There's a lot of fascia here which we still need to remove, but we'll come to that later. First job is to go and find the axillary nerve now. So coming in here, that should be the lower end. It's always very, very interesting that the axillary nerve is right there in the path of the screws and the Wissinger that comes out of the M portal. Again, use the non-working end of the radio frequency to dissect out the tissues. So should be here in this. Can you see that? It's coming into play now. Just there.
Yes.
So that's your axillary nerve now. Okay. Having seen that, now when the Wissinger passes, you'll see how close it does to that. Now we change the arm into external rotation and then come out and enter the glenohumeral joint coolly like this. So, sorry, one sec. The radio frequency is a little bulky. So, just there, yeah, traction. I meant the labrum is a little bulky because they attached MGHL, and this is where the split will go through. Go little lower, Amit, just little lower, yeah, yeah. So that's going to dictate where the split is going to come in, and I'm going to watch where it comes out. There it is. So that's my level. I need to double check, is that the right level? So this is the upper end of the subscap. This is where, and this is the lower end. So I think I'm quite happy. It's on the lower sector, not too high and not too low. So what I shall do is accept that and come a little, I'll just clear up this.
Do you alter your level of split based on the ligament laxity status?
Never. That's a job that Alex Ladderman does on the DAS. He has the liberty to do that. Here it should, see Nagaraj, the level is very critical that it has to be lower third because the graft will not hit in the correct position otherwise.
Yes.
So there is very little room for negotiation here. That's a clavipectoral fascia. I'll just clean that up so that it doesn't herniate into the wound. And that's pretty much my line of control. Okay. Yes, thank you, Karthik. Boys are good. They know when to do the pushback and when to help the boss. So most often we'll try and do a resection and cut the subscap separate from the capsule. Not that it helps, but it's good to identify structures separately and then try not to get them fibrous together.
Any indications, or do you always try to do a Bankart repair also, or do you have any?
No, if the labrum is healthy, then I'm a little loath to, do away with the labrum. That's not how the originator Lafosse described this. He doesn't bother with that, but I just feel very guilty. I don't think it's a mechanical constraint to dislocation. I like all that proprioception there. So that's what I want. I want native tissue. And if it's there and it's going to keep the graft extra-articular and provide proprioception, then I think it's every bit worth it. And it takes, 7, 8, 10 minutes extra. No harm.
Yes. In which case you would place the anchors
between the screws.
Between the screws, initially itself.
Yeah. No, not initially.
Okay.
No, the Latarjet is such a consuming procedure. It consumes, it's like one coronary at a time. So it's better to be done with the Latarjet and then decide if there's any blood or vessel left. Then you go ahead and do the rest, because I think this is one procedure that requires relentless tenacity, focus, concentration.
Yes.
And that steps, Bankart you can do plus minus on the subscap repair and rotator cuff repair. As Peter said, you could tie sometimes the lower sutures, then you can try the upper sutures. It's okay, you can change. Here, you can't change the steps. You just have to go in that complete military precision. You think you can come in? No? No, okay.
Ashish, give us some tips on arm positioning during your subscap.
So that's very important. I think that's a good point, Dinshaw. So when my assistant is doing an external rotation, it allows me to address the medial muscular tendinous junction. And then if I want to go in laterally, she's going to take the arm into internal rotation. Ensure that you don't encroach into the biceps there accidentally. So now we are going to medial territory. So she's forward flexed and then externally rotated. And Karthik here is doing a pushback maneuver to take the cartilage and the head of humerus away. Moment I get a semblance of window here, Amit, my assistant on the back, is going to come up with his rod and lift. Moment he does that, the window just opens up and then it's easy. Bob my ankle after that. But till that time, you have to be very careful. And that's why, again, the working end of the radio frequency should be away from the cartilage. And just enough. Perfect. So she just did an internal rotation maneuver, allow me to insinuate my radio frequency into the subscap and the capsule. So that's a safe way of doing this. But you must understand that the tendency is to go from low lateral to high medial, and that's not on. You must be in the same level, same coronal plane to ensure that you've not left a asymmetric subscap split, because then you can have a subscap tear. Internal. Yeah, one sec. Let me do this and let me do this. Yeah, lovely. Perfect. And elbow varti uchal. And then I come in. I mean, do you think you can? Okay, let me take this out and then we'll be able to. Okay, just there. So even if you have this much gap, then you can have the radio frequency come in. And that's, I think, a good split.
Ashish, do you think a capsular label repair after Latage results in loss of range?
So I haven't met that problem. The Latages in my series have a much better range of movement, in the sense external rotation, than my Bankarts. I end up doing a much tighter capsule label repair. This is not the shift that we do like in a Bankart. We don't tend to do a big shift here. So I have not encountered that. My Latages, on the whole, have had a much better range of movement than my Bankart patients.
May I? Ashish sir, when you do this subside split, what is an extent? Should we reach right from the musculotendinous junction to right to the attachment of subscap at the LT, or what is the length of that split?
Vivek, yes. My biggest Ortho fan. Yes, good question. Okay, now see, I've lifted the top leaf up so that my assistant with the posterior, one second. Let me take this. The labrum is coming in the way. Let me take this. I got it. There. You just come in there nicely, and then that just sneaks in there, so that makes the whole job. It just opens the world. Yes, Vivek, to answer your question, start from musculotendinous junction, and then come short of the footprint, because you don't want to encroach into the biceps or the sheath of the biceps. That won't be good, because you might create pain. So you don't need to go all the way external, all the way laterally. I would say stop 2 centimeters short of the insertion point on the tuberosity. And so you can tailor make that. If you're not happy, then increase it. I can even come now and increase it further. But I don't want to see the footprint of the subscap. But that's good enough. This is a good split. I think I've done well. What is important here is that if I'm too high, then my graft is going to come up here. I have to understand that that's 6 o'clock. I want my graft to sit here, okay? I don't want my graft at 6 o'clock. So I think if I make a mark here, then that should be good enough. So take that opportunity, clean that up just a little here. There's an old bony Bankart, so that's causing a bump. It's important for me to remove that bump to ensure that my graft will sit where it needs to sit. So we are like 25 minutes since projection. We are good. I think we should make it on time. Lovely. That's the bare spot. So I just take a splitter here, come in through the eye portal. Knife, can I have a knife? Thank you. I just extend my eye portal so that my splitter comes in there and just sneaks in through the slit nicely and then clears up the path. Yeah. So just remove all the soft tissue, release the subscap, takes the tension of the axillary nerve, and that does well.
The other system for Latage has got these nice spreaders which come posteriorly.
Yes.
So
yes.
What's your take on that? Have you started?
So we've never used them for this. On the MyTech set, they've got some very neat instruments. Good. But yes, the spreaders are quite impressive. The problem is, in my hands, I use the spreaders, and they tend to leave a lot of skid marks on the glenoid. Outside camera, so this was my portal. It's exactly where my portal is. Don't tell me and don't ask me how I got this, but it took me some time to ensure that my marked portal matches the actual portal. Okay, and I just pass a screwdriver just to create that path. This is where I swap my viewing portal from the from the E to the, you can relax now, Farzana, to the eye portal. So I'm now eye portal right in the plane of the coracoid, watching directly. And then this is the time to come in with the radio frequency from a medial portal and just clean up that medial surface, because there are usually adhesions here that after the osteotomy can create problems and put tension on the musculocutaneous nerve. So try not to go into the, you can see the CC ligaments very clearly. Just here, these are CC ligaments. That's your entire medial surface. And just taking the tension off the pec minor. This is very important. It looks unnecessary, but by doing this, you are ensuring that the musculocutaneous nerve is completely freed and the conjoint is free all the way down. It's a good 5-6 centimeters down. That's where all the brachial plexus is. You can see all the nerves there. Should be the radial there.
Also, unless we do this, when you're mobilizing your coracoid, you might land up putting too much traction in order to release the adhesions between the pec minor and the coracoid. So
you're right. There's another neat maneuver I will show you, hopefully if I don't forget, to ensure that the adhesions don't bite. Okay, we are done. Needle knife. So this is the point I was trying to make about there are veins right in our path. So this is the portal that bleeds the most. Pray for me that I don't catch the cephalic here, but sometimes I do. So knife coming in. So if you look from the top, you will see that it's not a perfectly perpendicular portal right there in the path. That's where I want it to come, okay? So right in the middle of coracoid, perpendicular there. So actually if you look from, from the bottom camera, outside camera, you'll see that that needle is not vertical. It is actually inclined almost 30 degrees, okay? Yeah.
So that's the orientation of the coracoid to the
That's
clavicle.
right, that's right. Now, I'm coming in with my knife. I'm trying my best not to capture. Oh, very careful. And that's the alpha beta guide coming in. Yeah, she's always there, right in the path. How I managed to get that? Ah, there. I knew that would happen. That's the portal that bleeds the most. Never mind. There we are. Now, placement of this guide, I was saying that this is the promontory. So I have to be really distal. In a Caucasian male, I can start here because they have real long coracoids. Here, I have to be right at the edge, at the risk of perforating the distal. If I don't do that, I will not get my osteotomy away from the beta hole. So this is where you need some critical accuracy. That's the most restrictive problem in the Asian coracoids. They tend to be short. So, okay, here. Now, I am tilting it more medial than lateral. That way your screws stay away. And then I've got some stuff. I have a little bit of coracoid behind. Now, one sec. Take it out. I think I'll come a little anterior. My fellow Karthik also objected. Yeah. So this is risky. Yeah, go on. You come in. You take a wire in, then I will position it. Now the head also comes in between because this is a real in-the-face portal. One sec. I'm not done. Yeah. So that's really, really close. One sec. Yeah, we'll accept that. Go. One sec. So I take a lot of effort to ensure that. Don't worry. Go. I'm going to take this. So one second.
Anand, the mic here.
So this is really, really risking it, but I'm going to gamble on this.
Hey Ashish.
Yes.
Basim here. This is fantastic. Can you comment about the real appropriate placement of this one so that you don't come very close to the distal tip? Like, what are your tips to make sure after you put the screws, you're not too close, it may break because it's very close to the tip of the coracoid?
It is. So, you know, Basam, when I'm dealing with a Caucasian patient, I don't bother because you have so much real estate there that you can be very safe and take a safe zone here. But in Indian patients, I can't because anybody who's 5.5 feet. So this is what I do. I stretch the conjoint and that tells me that this is the point which is the tip here, okay? So I have 10 mm here, but it's a slopey 10 mm, okay? But if I do this, then I have this area here, and then when I'm here, now look, I can take my osteotomy from here. If I had gone 10 mm behind, then my beta hole would be here, and then my osteotomy would either destroy the CC ligament or it'll take too much of the scapula and then the graft becomes curved. That's why I said it's always very challenging in Asian patients. I'm really, really inching to a precision fit. So this is also slightly risky. One of my assistants is not happy. He's like, boss, this is not good. So I'm like, we'll be okay. So, and because there's tissue there, see, can you see that? I've got real estate anterior to my this thing. So we are good.
Ashish, the anterior aspect of the coracoid doesn't tend to be parallel to the undersurface of the coracoid. So when you're talking of perpendicular, are you putting your wires perpendicular to the anterior aspect or the surface which is going to hit the glenoid?
No, we don't have an option to check the surface on glenoid. Go. It's the dorsal surface, perpendicular to the dorsal surface.
Okay.
Because I'm not too worried about the curved inferior surface that's going to attach because I can prepare that with my shaver, the bird. I can't change this. So I'd be perpendicular to this.
Also, from the discussions that we are having regarding the location, obviously you're more concerned of this particular screw now that you're going to drill because that's the critical one. So you need to make sure there's an adequate bone bridge between this and the osteotomy.
Because this screw will dictate this position. But I'll show you. I know this is risky, but look here now. When I clear up, try and get you. See? I have got 4 to 8 mm of bone here. Okay. But having done this now, look how much area I have left with. That's it.
Looks good.
That's it. So I still can do a substantial osteotomy here, still get about 8 mm here, which is nothing. Now if I had erred 10 mm on this, look at this. If I had erred 10 mm behind, my beta hole would be here. I would have to cut this and I would end up getting a curved portion of the scapula here, which will make my graft non-linear.
So obviously with so many years of experience, you're able to navigate through such a small coracoid.
I would say so many years of balding head, hair loss, fired coronaries.
Don't talk about hair loss to me, sir.
I know. So you're way ahead experience than I am. Is that the conjecture then?
No, I didn't mean to say that.
I'm with you. I think Dinshaw would be in his infancy by that standard.
Ashish, have you ever found it necessary to put a single screw in one of these very small glenoids?
I wouldn't use the word necessary. Compulsion would be a better word. I have done that twice. When this got fractured and I've not had a premature coracoid break, but my osteotomy entered the beta hole and made it defunct. So this was Nagaraj's question about the saw or the osteotome. So both options are there. But I kind of rely on the osteotome. And I'm in control. I let my assistant hammer. And you do this in sequence, step by step. Slowly as you go in, you start pushing your osteotome posteriorly, trying to get the osteotomy to enter.
And you had created a stress riser.
I had. So what's important is you create the stress riser, the two have to match.
Yes.
You see? Slow down. Yeah. There we go. Here we are.
Nice.
So I think that's pretty much a perfect osteotomy. I don't think we've got any bit of scapula there. And so nice and clean. There's some tissue here attached in spite of all the cleaning that we did. Just remove it safely. Ensure you're not dealing with the musculocutaneous nerve because we've seen it. I know where it is. Done. Okay, doc. So now we get the splitter to go through the M portal just to create the smooth passage. Leave the graft there, and I need to prepare the glenoid. So I grab this Wissinger, internal rotate Farzana, pull the subscap out. The MJHL is going to create a little, push this behind, yeah. And both my assistants will create a little bit space. No, Amit, I need a better space there. Come in through the S portal. And this is where we are going to try and flatten out just there, yeah. So as I said, this was the bony bankard that kind of dissolved and underwent osteolysis. One tip here, in case you find that your burr is jumping off and you're unable to control it, just go and use the reverse option. And because this is weak, fragile bone, the reverse will never jump in this situation, and you'll still be able to. So I'm using the reverse now. So that way I have a better control on what I'm doing. And this preparation is important to ensure that the congruent surfaces match each other. Sometimes it's like a wedge. So you just take bevel this end here so that the graft sits absolutely perpendicular to the, okay, I'll go back to the reverse mode now so that because we are going on the medial side.
Ashish sir, I'd like to use this opportunity to ask you,
yeah,
because of your wealth of experience now, when we're drilling from front, there are so many variables which are beyond your control, especially the scapular position. So given a choice, if there is a drilling system which comes from posteriorly parallel to the glenoid, you're always going to be accurate in terms of your placements. Do you think you're going to be thinking on those lines, changing your techniques for your scopic lataje as time progresses?
Nagaraj, I think I disagree with you. I like to be under complete control when I'm doing my ortholataje. So coming from front, having identified all the layers, I know that. Coming from behind, blind, I have not exposed the musculocutaneous nerve, axillary nerve, risky. Number two, whatever you do from behind, whether you put buttons or tension sutures or circlage or this thing, you are going to have a working length that is at least 30 mm, if not more, which means that much more cyclic loading, that much more creep. Every implant is undergoing creep. The screw will never undergo a creep. And even a small creep is going to allow micro motion at the graft surface here. So I'm not with you on that front. I think what the screws achieve from the front is incomparable.
Okay.
Having said that, I have done the button lataje. And so I would do that for a subcritical bone loss, not using it as a lataje. I'm using it like a subcritical bone loss to augment my bankard repair.
Soft tissue repair.
On my lataje, I don't repair my labrum, bankard doesn't matter. It's still going to do well. So there's a difference in the thought and the philosophy of doing a circlage versus a bone marrow. I think I still need to do a little bit more because once my graft comes in, then I don't have the opportunity to shape this glenoid even more. So I turn the light source slightly, sorry. I hope I'm not making you seasick. Slightly, yeah, just the bump there.
Dr. Ashish, Sujit here.
Yes, Sujit.
Yes, more important is to have a very good bloodless field as well. So could you tell us about the tricks the anesthesiologists do, or you advise them about Tranex or the hypotensive anesthesia, the pump pressure, stuff like that? Because
you are so right on that. I was going to allude to that at the end of the procedure, but we make friends with the world's best anesthetists. And knowing that it was a conclave, we have Swapna Naik, who's our shoulder anesthetist for God knows how many years, at least 20, I would think. So they know exactly what you want. They know the lataje. In fact, she's whispered into my assistant's ear, please tell me when the osteotomy is going to be done. So she keeps a close watch. She knows that the pressure can change. The moment the osteotomy is done, the bleeding can go out of control. So they also need to understand the procedure and they need to go, they do that. They go out of the way. And in a young patient, I don't think there's an issue there of controlling the blood pressure. I think it is sacrilege if a young patient, Saatulataje, and I know, Sujit, you do a lot of these, you also face the same thing. So have the best anesthetist or go and marry one so that you get the best care. I think we are good here. You quit while you're winning. Let's go now. Now, this is the change in step that I'm doing now. So I'm not capturing the graph, which is what normally I would do. It would save me 15 minutes. The posterior Wissinger has to be withdrawn. I'm coming directly with my blue cannula naked, just there. So this is kind of heresy. It's something that's not been propagated. But I thought, one sec. One sec. He's right. Forward flexion here. Now, so you identify the split here and then get your posterior external rotate. Yeah. Thoda, yes. Yes, perfect. He's got a little labrum there, yeah. Yeah. Yeah, keeping the labrum makes it a little wee bit tedious. Yes, I'm good, yeah. Perfect. Need a little bit of pushback. Please, somebody forgot to hold this rod. That's there. Thank you. Yeah, I'll do that. I can change my wing portal and go back to the E portal. And that allows you, and then you can clear up some stuff here to give you a better view. You're good, you're good. Here. Konitari Arif Khalitaba. And that's my blue cannula coming right through the split. Like so. And as I'm parked in there, because it's transparent, there's no graph that's limiting me. I know this is my, just a little bit, yeah. And then you have to hold the scope. And then there's always a lot of backseat driving going on between the two fellows. Not here, sir, a little bit here, a little bit there. So you have to get used to that. And then I'll move it a little medially. Okay, I think I like that. That's going to be, yeah, that's perfect. Okay, let me just pass.
Now, Ashish, when the graft is there,
yes,
you can always make sure that that's flush. Now, when you're making this without the graft, is it eyeballing that you're assessing that when the graft comes, it's going to be flush, or how do you decide?
Good point. The margins of the blue cannula almost coordinate with the graft, almost. So I've kept my plastic cannula lateral wall just 1.5 mm medial.
In terms of the o'clock, is this a 4 o'clock, 4:30?
5.
It's a 5.
See, the risk, Nagaraj, of going to 536 is if there's a 10% error, then your lower screw is going to come out.
Yes.
You understand? So I bias my placement a little in favor of 5. So even if I'm gone wrong, I would still have my screw at 530.
Sometimes the inferior glenoid bony support is unpredictable. Sometimes it can be, very acute turn there. So
that happens if you're below 530.
Yes.
So we are above that. Okay, now he's going to withdraw the wire. And then there is a fallacy with what I do. I'll try and explain later. Remove the wire, remove the wire. Yeah, just keep it there now. Thoda azun withdraw. Bas. Okay. We take out the cannula. Give me the blue trocar of the cannula. And now we have to go and find the graft. and capture the graft. So now we go to the old technique as it is. Yeah, give me the RF, yeah. And then graft should be here. Okay. And just push the graft into the field, just there, okay? Then, come in here, give me, hey, dhartoy koni, yeah? Just slowly take this out. There's a sudden loss of pressure. And then come in and capture that graft. This takes about 12 minutes off your procedure by doing this. If you do it the conventional way, which is also good, could be a little faster. Okay, now, the point I was telling you about the tissue, withdraw the, yeah, enough. So you can just do this maneuver. So this is the cross, yeah, just do the holy cross, and you're releasing all the tissue, whatever is there, and then you're ready to go in there. Hold this here. Now, there's another thing that I do. I'm a very lazy person by choice. The top wire can come off. So, yeah, withdraw. So I just, instead of doing our burrs are not fresh, they're not disposable, so they're not as sharp as they ought to be.
So you've combined arthroscopic surgery and open surgery now.
Yes. So don't look, don't do this at home. Yeah. And then, sorry. Okay. And then you just look at the water. Come in there to do the finishing touches. I just need to see where my, it is. Yeah. Keep the burr steady and move the graft. That is the safer thing to do. I don't want to move the burr because it can create a lot of soft tissue damage. So just ever so little, just bevel the edges so that the sharp edges can catch the subscap as it is going in.
You're making it look as easy as it is.
Sorry?
You're making it look as easy as it is in open surgery now.
Honestly, Nagaraj, this surgery is not difficult. It just requires tenacity, and I think you should have a perfect knowledge of your anatomy. There's a lot of hype against the arthrolatage and people shirk, and that's how it started. I went to La Fosse against the arthrolatage because I was everywhere told me, don't ever do the arthrolatage. So I went as a nihilist, and I came back converted. Okay, that's as good as can be. Yeah, see my fellows are like, stop, 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 don't do anymore. Good, so we are done there. Now we have to go back and find our split. So wash, please. And I'll just see if there's anything that I have aggravated. Nothing? Okay. So the radio frequency can come in temporarily. Just finishing touches. We're almost, give me 10 minutes, I won't need more than that. But if you're running late, let me know. Push this down, yeah, and graft coming in. Karthik, your rod needs to push that subscap down. Hold the scope, I'll do that. Hold the scope. Yeah, for arthrolatry, you need 4 hands, you know. That will make life really easy. Yes. Now, can you just hold this one, Karthik? And now you have to skewer. One sec. Just his scope, the blue cannula, blue cannula. I just bring the cannula steel one out. Yeah. And then go and, yeah. Just mate it nicely. If it dovetails in, yeah, so that's gone in. Sorry, I pushed it back. push out the wire so that, yeah, it doesn't bend. And now, you just rotate, find out the correct mix. Ensure you agree it's flush. To hath sodin there, Rani.
Absolutely.
Yeah.
Looks good.
Correct. So we are done. That's a good position to take in. I'm going to put in the top wire so that this doesn't rotate anymore. Yeah, the table goes down. This is another tip for you. There is a good time to take the table down now. I learned this from Laurent again as he modified the stuff. So that ensures that you avoid the high okay. So you can right click on the account. I mean, this should take no more than 6 to 7 minutes. Thank you. Screw them. Yeah, I removed the steel cannula. So what we'll do is, since we have drilled the inferior hole, we will validate the hole by passing in the screw first before we drill the top one. And then I won't tighten it completely, but it'll just help prevent the rotation. So I'll just keep that there, ensure that the graft hasn't changed too much. Yeah. Drill, please. Screw, please. And that's the second screw coming in. Okay, now just do the alternate lower and inferior so that you get a good compression. Just one sec. One sec. Give me this, so that we get a better view. Yes, thank you, Karthik. Just do a better focus. Yeah. And that's flush. So if your surfaces are congruent, never do the bottom one complete because it tilts the superior part medially. So that's pretty much done. I think that looks okay. We'll put the scope posteriorly and give you a view. Before I do that, I need to pull out the echelon. Okay. You can remove that rod. Eye strong, please. Remove your rod. This one. Here. External rotate. Yes, perfect. Okay, release the artery. I need to pull the echelon out. Yeah. Okay, that's done. 1 minute and then I can hand over to you so that we'll finish the posterior labrum repair here and the Bankart repair, but you don't have to watch that. It'll just delay everything.
Ashish, maybe you could just show us with the, yes.
Yeah, just this final.
Perfect.
Probe, please.
And with the grasper, how you'll get your soft tissue.
Yeah.
Yeah.
So if you look here, this is exactly at 5, exactly where we marked it. It's pretty much flush. The way you tell whether it's flush is, I need an exchange rod. So you can't tell from here whether it's flush unless you pass your Wissinger through the medial portal. And so that's flush. That's flush. I think I'm happy with this. We'll try and get you x-rays for this. But this is done. One grabber, please. And trust me, this graft is so strong, it's not going to move at all. So I don't restrict their movements at all. They can do your third week exercises with stuff. So, okay. So this is how it's going to sit here, okay? So there's a bottom end here, which will pick up and we'll grab it here and then put it back there, okay? So I think we've cut off half the labrum here, but I'm going to put that down there with an anchor here and then finish off the posterior labrum repair.
Great.
Thank
you. Thank you.
Thank you.
Looks great. Thank you,
Thank
sir.
you, thank you, thank you.
Big round of applause.
Thank you very much. I appreciate Swapna Naik and the team, Karthik, Amit, Sonia, and Farzana. Thank you very much. I'll see you soon.
Thank
Bye.
you, Ashish.
Cheers.
Okay, so we've had some excellent surgeries, 3 surgeries back to back. I think everyone's had their lunch, and we'll proceed now to the post-lunch session. This is the rotator cuff tear session, and may I request our moderators, Dr. Deepak Chaudhary and Dr. Bhuv Machani, to take the floor.
Requesting faculties to upload their talks for tomorrow morning's workshop sessions at the preview point. Thank you.
हम कोई मंदिर का घंटा है कि कोई भी आके बजा जाता है?
So now we are going to have the rotator cuff tear session, and there's going to be a debate, very interesting one, between Dr. Mehata and Dr. Alexander. So first of all, I call upon Dr. Mehata to speak on SCR solutions to global warming. Dr. Mehata, please.
Thank you very much. Now I'm telling why we need to do the SCR for rotator cuff tear patient. So here's my disclosure. So history of arthroscopic management for rotator cuff tear. It's Dr. Barkhout developed the partial repair arthroscopically in 1997. Actually, this is very nice surgery, and also still maybe some doctors still doing. But actually, he switched to SCR 20 years later. It means the SCR should be better than partial repair. That's why he changed it. So I think there's no question about SCR, which is the best arthroscopic management for rotator cuff tear now. But actually, various SCR is reported in the world. My technique, my graft is fasciolateral autograft, and other dermal graft and allograft, hamstring, biceps, and synthetic patch. But now I can say gold standard is fasciolateral autograft because indication is grade 1 to 3. It means all rotator cuff tear without osteoarthritis are covered. And also maximum 3 tendon rotator cuff tears, we can do the SCR like supra-infrateres minor or supra-infrasubscapularis tear. But for tendon tear, actually, now I'm doing the reverse. And in many countries, the excellent short-term clinical outcome was reported. And also, much study shows excellent clinical outcome. And long-term follow-up study also showed the excellent clinical outcome. And many biomechanical studies show the complete restoration of good linear stability after SCR. And also, historical study also shows the regeneration of fibrous cartilage insertion in both greater tuberosity and glenoid. And but I'm doing the fasciolateral SCR, but United States or European country, they prefer the dermal graft SCR. But actually, the last 10 years, these two techniques discussed together, but actually, it's a totally different surgery. So I want to tell now why totally different. It's a biomechanical study. After range of motion measurement, just check the external rotation, internal rotation measurement. The fasciolateral graft, of course, no change the size, but dermal graft, 15% elongation. And of course, the stability after SCR, the fasciolateral SCR completely restored, but dermal graft SCR partial restored because of elongation. So now I can say the fasciata issue, dermal graft issue, totally different animal like a tiger and cat. So we cannot discuss together. So this is a very different surgery. So from now, I'm talking about the fasciata issue. So until last year, actually last year, finally I reached the 1,000th case of the issue. Then I'm telling what we learned from 16 years experience. So more anatomical surgery, the MRI show looks like after local repair, but that was fasciata graft. And also the arthroscopic finding, ill parallel here and fasciata issue just after surgery. And same patient 3 years after surgery, it looks like native broadcast tendon tissue, but here tendon, but actually that was ill parallel here and fasciata graft. So we can expect the remodeling after surgery. And a very nice function. Maybe you cannot realize which side I did surgery with this patient, right shoulder, I did SR. And also we can expect consistent good outcome. It's a recovery rate of pseudoparalysis in my previous study. So 95% recovered pseudoparalysis, very high rate of the recovery rate is consistent. And 2 patients had graft here, that's why I did not change it. So if graft here, the almost 100% return to the normal function. And this patient, carpenter, before surgery, he cannot level arm, even we apply the injection too. The MRI shows massive tear supra-inferior, even teres tear too. Then 3 after surgery, I make a big graft, super side to posterior side. Then 3 after surgery, graft is still intact. Then, of course, good range of motion, and he's still working as a carpenter. And also highlight of return to sports and physical work. Even 3 tendon tear before surgery, they can throw the ball, and then he's a gardener, he can do this movement. So for the manual workers, if the patient want to return to the sports, sure is a good surgery, good option for this patient. And also, we have some complication, but not so severe, and it's a relatively low rate. Graft here is 3%, infection 0.9%, ankle pull 0.8%, stiff shoulder 0.5%, severe hematoma 0.5%, and gluteal pain 0.2%. So this is another advantage of this surgery. So recently, we did a long-term follow-up study, so I showed this result. If the graft heals, the 1 year after surgery, active elevation significantly increased from 89 to 149. Even after 1 year after surgery, still increasing gradually. And 5 years, 162, and 5 to 10 years, almost not changing. But if the patient has graft here, active elevation decreases with time. And also, we check the post-operative graft osteoarthritis. It's a healed patient. It's a before surgery. The 6% had the osteoarthritis even before surgery. And 10 years after surgery increased to 28%, but contralateral side also increased 16%. So this osteoarthritis may result from the aging, not from SCR, but failed patient, if graft is failed, actually torn, before surgery, there no osteoarthritis, but all patients have severe glenohumeral osteoarthritis. So SCR can prevent progression of postoperative glenohumeral osteoarthritis at 10 years after surgery. All patients is at 10 years after surgery, actually very good range of motion. Maybe you cannot, I did the surgery. And also most of the patients, they said, yeah, forget they did surgery because already 10 years passed and they feel normal. And also not only the ill parallel cuff tear, even reducible tear, if the tendon tissue is very degenerated, like a thin and short tendon, I do SCR. Plus root canal repair, SCR for lymphocyte, we call SCR. And this is a recent study. The return rate just after isolated root canal repair, 6% to 38% in 2022. Actually, this number no change last 10 years or last 20 years. Even the technique is modified. But actually, my surgery, SGR plus scar repair, is still 0%. Last 10 years, more than 300 cases. So that's why I really recommend this surgery for degenerative and reducible root cuff tear. SGR can prevent retear after root cuff repair. So finally, I show the two cases, the competitive athlete and also retear after root cuff repair. This patient, 51 years female, volleyball, very active competitive player. Actually, she cannot elevate her right shoulder before surgery. Then, 1 year after surgery, she can elevate her arm very well and graft is healed very well. And she returned to the previous competitive level, so she can do this movement. Even we harvest fasciata, a very big one. And also this patient, 54 years male, the failure can repair 3 months. The repair tendon very thin, and 6 months we found a retear after surgery. And so we did SGR because he couldn't elevate arm after the root canal repair. Then after SGR, he can elevate arm, and 10 years still good range of motion, and still graft is here there. So now I can say that I want to ask, can you satisfy this patient without using SGR with other surgery? So here's the take-home message. SGR is a very reliable surgery for apical root cuff tear and also degenerative reducible root cuff tear. So why not SGR? Thank you very much.
Thank you so much. I think that's
Don't
good.
angry me. जो मैं बोलता हूँ वो मैं करता हूँ और हाँ जो मैं नहीं बोलता हूँ वो मैं definitely करता हूँ.
So Dr. Ladderman, thank you so much for coming, and I think I'll have to listen to you to see how you actually can defeat or prove otherwise what's been said before. We'll wait to hear from you.
Thank you. So I never did a superior capsular reconstruction, and you will understand why. I would like during the next 10 minutes, maybe 11, talk about the unbelievable result that has been published previously, and you should see the score. I will talk about it. I would like to go back to the basis because from time to time it's important. I would like to talk about the different way that we can treat irreparable rotator cuff tear. Finally, I would like to see if it's something that is really rational regarding to the cost and the science that is behind it, and just to talk just a few words about biceps SCR. So you just heard unbelievable result, 0 retear rate on more than 300 superior capsular reconstruction. If you have a look to the first series of Miyata, the ASC score was around 93. It's a mean of 93. And with patients that are quite old, with osteoarthritis, some patients had AMADA 3 and 4, and they were already beginning strengthening after 8 weeks. 8 weeks, that is quite early. Another publication from Professor Miyata, 97 point of ESCS score. And it's very interesting because my patients that don't have shoulder problem at this age, they usually don't have 97 point of ACS score. This is my result in press in asthma, and I compared the two different groups. However, if you just take into account the D type, I have with functional shoulder. It's good muscle, good tendon that has healed. I have 90%, 90 of ASCS score. Professor Miyata, he has non-functional shoulder, no more muscle, bad tendon, and he obtained 97%. This is a problem for me. Second point, this is the bias that industry push in this for this technique. You know the technology S-curve, and this is what happened with SCR. So Professor Miyata has his great idea. People started to use the SCR, and they realized that this was difficult, that there was some variance in outcome. And then the industry came and said, but we have xenograft. So again, we started to do SCR with xenograft, and as we had some failure, the industry came and said, yes, but we have now allograft, and you need to put 2 layers, so you have thicker graft, and you need to put more anchors. So we did it. And then we arrived to a third curve where, again, people said, if you don't have good result, it's maybe because you don't put PRP, you don't add PRP, you don't put PET in your graft, you don't put Teflon, and so on and so on. So now, let's go back to the basis. You know the classification of Philippe Collin, and today we are talking mainly about D-type lesions, so supraspinatus, infraspinatus. These massive tears are quite frequent, and they represent around 60%. If you have a look to the series of Bassem, of Philippe, it's around 50% of massive rotator cuff tear, and only 15% don't have teres minor. And I just remind you that if you want to have the bridge, you need to have the teres minor and the subscapularis minor, and most of these patients, they have both. So this is balanced shoulder. And if you have a balanced shoulder, the risk of persistent pseudoparalysis is really low. It's around 2.9% for D-type lesion. So first take-home message, very few massive rotator cuff or irreparable rotator cuff involve teres minor and subscapularis minor. So how to treat this D-type? The conservative treatment is probably the basis, and this is something that we published last year. Unsuccessful response to physiotherapy are poor anterior forward flexion, complete tear of the subscap, lack of teres minor hypertrophy, glenohumeral arthritis, stiffness and weakness in external rotation, and all this is quite rare. And how do you treat them? If you treat them properly, and this is what we did in 2015, we follow 45 patients with pseudoparalysis, and 90% of them regain anterior forward flexion, and this persists in time because we follow this patient doing more than 2 years with a 0 complication rate. Just one example, this patient has a superior capsular reconstruction 4 months before done by one of my colleagues. This is the typical result that you can obtain with a xenograft, nothing left after 4 months. And I saw him 5 years later for his other shoulder. He has poliomyelitis. And when I did the clinical examination, I said, I'm sorry, sir, but you didn't tell me that you didn't tell me that you had a problem on the left side. And he did. He said to me, yet I had a superior capsular reconstruction. So 5 years later, no pain, very good function. He's also able to do this with a complete failure. So the take-home message number 2 is that superior capsular reconstruction is very useful when you don't need it, because in for most of these patients, the conservative treatment is successful. Then, if the conservative treatment fails, this is all the options that you have in the literature for the same lesion. So I'm just going to mention 3 of them. If you go to Boston, you will have a low trap transfer done by Bassem. In Brisbane, you will hear this a little later in the day. Gupta will do an advancement technique. If you go into Japan, you will have a fascia lata, and so on and so on. So for the same lesion, the treatment depends on geography, surgeon experience, healthcare system. For instance, the superior capsular reconstruction is not reimbursed in France, implant cost, and conflict of interest. So George and I, in 2018, we summarized the literature for you. So we took all the main series, and this is what you have in front of you in this table. Interestingly, whatever you do, if you do a biceps tenotomy, a latissimus ossei transfer, a superior capsular reconstruction, all the preoperative scores start at around 50. It's a mean of 50. And then they all finish at around 75, okay, all of them. So what does it mean? It means that whatever you do, if you just cut the biceps, the result is really good with different types of failure rate. An interesting point is that the graft healing might not be an independent predictor factor of success. And this has been published by Label, meaning that you probably don't need to have a healing of your graft to obtain a good result. So when you have all these solutions, why don't you, I love to, I'm coming also from France, I love to kiss, so keep it simple. A biceps tenotomy and a partial repair takes 10 minutes, it costs 200 euro. A superior capsular reconstruction lasts 2 hours and costs 5,000 euro for exactly the same result. So take home message number 3, I think that whatever you do, the result is amazing. It's amazing. So let's talk a little bit about science. The level of hierarchy, you know, this level 1, very high quality of evidence, level 4, 5, low quality of evidence. And when you compare a new technique such as the superior capsular reconstruction, you need to compare it to the gold standard, that is for me biceps tenotomy and partial repair, or placebo or sham treatment. So let's do this. It has been done for the balloon. If you compare balloon to gold standard, 0 difference. If you compare latissimus dorsi to gold standard, 0 difference. If you compare superior capsular reconstruction with the gold standard, 0 difference. And some of these science are biased because most of the authors, they have conflict of interest, and there is also a spin that is highly prevalent in the abstract of superior capsular reconstruction paper. So take-home message number 4, there is very few and low level of evidence behind the superior capsular reconstruction and some biased science. So now what about the cost? I'm an expert in Switzerland. I receive a lot of files like this, and this insurance said to me, okay, this patient has been operated in US. Can we have your opinion? So this is a lady that has a superior capsular reconstruction. The surgery lasts more than 5 hours. The shoulder implanted only 11 anchors, and the result was so bad that he put on the top a balloon. Okay, so $10,000 US to remain paralytic after 1 year for simply an avulsion of the cuff and an incarceration of the subscap into the joint that I could have probably solved in 45 minutes with an open surgery. So in Switzerland, I'm coming from Switzerland, you think that I am rich, but I am actually a rich poor that pay for this kind of surgery. This is the amount that I have to pay for my family to be covered by a private insurance in Switzerland for 1 year, $34,000. And this helped to pay for this kind of surgery. So take-home message number 5, I think that the superior capsular reconstruction is a complex and expensive surgery that ruined the healthcare system, and we are responsible for this, all of us. So Johan Bart, one of my friends, introduced me the biceps SCR. I'm going to be really short because we are short of time, but this is a very nice, elegant, autographed, and unbiased solution. So take-home message, there is little science behind all these techniques, superior capsular reconstruction and the other one. It's very useful when you don't need it. I will never put some skin of dead pork, of dead human, PET and Teflon in the shoulder of my patient. You saw the live surgery from Peter this morning. I mean, instead of playing with new industry tools that ruin the system, you should do like Peter this morning and never give up, okay? Because most of the cuffs are repairable, and if it's not, keep it simple. So I trust the gold standard with conservative treatment. If it fails and I have a biceps, I will do superior reconstruction. If I don't have a biceps, you may use the technique of Miyata with a thick wrap, but I think that your patient must know that there is no scientific proof today that there is a consequent radiological failure in other hands, and the superior capsular reconstruction compromise subsequent surgeries. So I prefer to treat the patient conservatively, and if it failed, do a reverse. Thank you for your attention.
Wow. So it is a debate. I think rather than open to questions, so before we open to the questions and before Dr. Bassam jumps on that one.
Hello, Bassam.
So we will
Pleasure to see you.
Yeah, so we will leave the faculty not participate in this. We leave this to delegates as open. You can stay there. I can stay there. So assuming that there is no alternate and we are taking only SCR as advised by Dr. Mehta and now by Dr. Lederman, delegates, how many of you would support our first speaker in the given circumstances? Hands up. Go on. So about 10. And delegates supporting the second speaker? Right. So we have a clear winner here. But we now open to questions. And congratulations, Dr. Lederman. I mean, this is no disrespect to you, Dr. Mehta, but I think delegates, we have a vote, and then at the end, the debate, they should have a winner. So, Dr. Bassam?
Yeah, Alex, this is a really beautiful presentation. I really appreciate it. So, I am with you about, this is what we spoke in the morning with George about, like, there's certain patients, you can do any of these procedures, and you may get the same outcome. Now, my question for you is, young patient, massive tear, through ER lag, that they really, through ER lag, they have no suprainfraoteris minor. You try to rehab them 1 year, still, they come to you, please, they're 35 years old.
Bassam, we are not talking about low trap transfer.
No, I want to see what you want.
We are talking about superior capsular reconstruction.
I want to see what you do, not me.
So,
if you have, like, you showed us your option, biceps tenotomy, this is your way to go, and you said sometime I can do some other, biceps SCR is your way to go. Is this your way to go if the patient has complete ER lag? This is my question. I'm not saying about lower trap, I'm saying about your technique. What would you do in your clinic for patient young with complete ER lag? What would you do?
So I have some question for you. Please